Good morning and welcome to the second day of Advanced Valve Therapies 2024. It's my pleasure to start up this day along with the program director, Dr. Iacovu, as well as the legendary chairman of heart failure in Onassis Heart Center, Dr. Stamatis Adamopoulos, who is going to be chairing the session. Dr. Iacovu will present the first keynote lecturer.
Okay, so this is a mitral and tricuspid day, but there are other therapies as well. So in this session, we're going to start with Arik Finkelstein, our great friend. He's talking about our long and fascinating journey. No, he doesn't want to do that. So it's a last-minute change. Yes, it's Dr. Kolyanskaya from Belarus. So she has extensive knowledge in intervention therapies for heart failure. So she will present her aspect on these therapies. So, Arina.
Okay. Okay. Kalimera, dear colleagues, dear chairman, it's so nice to be here. Thank you for invitation to this great event because a lot of time was in your country. I really love your country, but only for vacation. And now I'm here to share with you my experience and our experience of our center and whole team in treatment patient with cardiomyopathy and using Akusinch system device and study Akusinch heart failure study. And it's my disclosure. And you know that despite optimal medical therapy and resynchronization therapy, mitral clip device, patients sometimes need some new devices to reduce dilated left ventricular, and sometimes we need to win some time before transplantation, patient who waiting for transplantation or implantation of left ventricular assistant device. In our center, we perform about 50 transplantation of the heart per year. And this new device is Transcatheter device to treat dilated left ventricular and reduction size of left ventricular and reduction of left ventricular wall stress. And that's why initiate a biological reverse remodeling. And I can see you a short video how device goes to the left ventricular under the mitral valve and on the free wall of left ventricular behind the heart, and then stitching this left ventricular. And that's why we have such kind of the advantages. And on this fluoro, you can see green light after stitching of left ventricular and purple line before procedure. And we can see acute reduction of left ventricular in 8.7 millimeters. And then we can see during the follow-ups biological reverse remodeling during 12 months of observation. It's CT from our patients, 3D CT. You can see left ventricular before and after the implantation of 12 months of observation. And now it's a nice slide how device Akusinch integrated into the tissue of left ventricular. On the this slide we can see we can see device integrated just immediately after the implantation. And on next slide we can see 10 days after the implantation, and last one at 90 days after implantation. It's picture from our center because this patient went to the transplantation of the heart due to arrhythmia, and that's why we can such nice picture when Akusinch integrated into tissue of left ventricle. And we published our 12 months outcomes in journal last year when we can see progressive reverse remodeling and improvement in quality of life and functional capacity. But now I would like to speak about 24 months outcome with these patients. It's the first time we speak about 24 months outcome, and here we can see 51 patients with most of all with non-ischemic cardiomyopathy, with some implantable device, ICT, CRT, and we understand that this device not influence so much on the mitral regurgitation. That's why we include here patients without significant mitral regurgitation with dilated left ventricular and ejection fraction about 30%. And we haven't serious complication, just access-related complication, one tamponade and one stroke, but it's possibly related to the procedure because it happened in our center 7 days after the implantation of device. And during this period of follow-up, we can see a reduction significantly in left ventricular diameters and volumes here, and increasing ejection fraction as well as quality of life and functional capacity. And that's why we have survival 90% and 2 years. Unfortunately, we have 5 deaths, and 3 deaths were suddenly deaths. It's not due to decompensation of heart failure, one due to cancer, and one death was due to decompensation of heart failure, and 3 implantation of left ventricular assistant device. We can see a reduction of hospitalization during this period of follow-up, significantly reduction in hospitalization. And now we involved in new investigation, COSINCH heart failure study. It's investigation, it's randomized investigation with patient ischemic and not ischemic cardiomyopathy, with patients with ejection fraction 20-40%, dilated left ventricular, and as I told, without significant mitral regurgitation. And we can involve a patient who was implanted with mitral clip, because we understand now that this device, mitral clip device, influence of valve of mitral regurgitation, but unfortunately not significantly influence on dilation of left ventricular. And this device, a COSINCH device, we can use to reduce left ventricular, but unfortunately it's not influence on mitral valve. That's why it can be used together. And now in this study involved 100 sites. It's the Netherlands, Germany, Czech Republic, Italy, France, Belarus, and Lithuania, and 3 sites from your country will take part in this investigation. We can see on the map, and more than 160 patients approved to randomize. And in our center, in this study, we approved to randomize about 65 patients. And now I would like finally to speak about our result of our center, because we have observation follow-up about 4 years. But here result of 2 years of follow-up, and we can see significantly reduction, acute reduction in the left ventricular volume and diameters. And then we can see on the graph dynamic of indexes. It's biological reverse remodeling during the 24 years of follow-up. On the picture we can see TE pre-procedure and after the procedure, and 3D TE during the procedure, just to show this device. And we also can see increasing in left ventricular ejection fraction and decreasing pro-BNP. Unfortunately, not statistically significant, but we can see the big variation, and number of patients that we included was 23. That's why, but not so significant, but it's, you can see good tendency of decreasing of these parameters. And one of the best candidates for this procedure, it's a patient who has ejection fraction 26% and volume and diastolic volume about 237. And we can see in follow-up 24 months, really increasing in ejection fraction till 49%. It's a bridge to recovery. But sometimes we use this device in patients as a bridge to transplantation, because in our experience for 4 years, only one patient came to the transplantation of the heart. And that's why this device, acoustic ventricular restoration system, treats ischemic and not ischemic cardiomyopathy in patients with reduced ejection fraction without severe mitral or tricuspid regurgitation, who remain symptomatic despite optimal medical therapy. And early clinical results demonstrate acute reverse remodeling and biological remodeling and protected of further dilatation of the left ventricle. I think it's one of the most important things of this device, to protect of further dilatation. The acoustic ventricular restoration system could be used to restore hemodynamic function of left ventricle in patients with moderate dilatation and with severe dilatation, as I told, as a bridge to heart transplantation. And result from our early clinical studies in patients with reduced ejection fraction demonstrate a favorable safety profile as well as significant improvement and reverse remodeling and increasing volumes and decreasing volumes and increasing ejection fraction and in quality of life, functional capacity and heart failure hospitalization. And randomized controlled study is currently underway to assess clinical safety and efficacy of the acoustic system in patients with reduced ejection fraction. And your center will be take part in this investigation too. And I'm proud of our team, and thank you for your attention.
Thank you very much. Very interesting approach, very interesting intervention. As we were discussing earlier on, it's very important for low donation environment like ours, actually, because I realized that it delays the progress of heart failure. I realized that if we have got mitral regurgitation, severe mitral regurgitation, we have first to repair the mitral valve and then to carry on with this system, isn't it?
Yeah.
Vice versa?
Yes, we can use it's worse, but in the first investigation, we include patients with severe mitral regurgitation, but unfortunately, if we have a degree about 4, it's not influence, but we can involved patients with degree 2 or maybe 3 with not big volume. The volume of regurgitation about 25 till 30, not more. But if we have regurgitation about 40, 50 milliliters mitral regurgitation, the first step, I think we have to use mitral clip, but unfortunately mitral clip, according to our experience, we have about 100 implantation of mitral clip system, and we can see if it's functional mitral regurgitation, mitral clip don't influence on big dilated left ventricular. It's influence only on the valve, and then we can use something else to reduce diameter of and volume and protect further dilatation.
Right.
And then, congratulations, it was an excellent presentation. Have you identified any markers of successful implantation? Do you have any any BNP kind of markers?
Yeah,
Yeah.
we use pro-BNP markers, and you can see really decreasing of pro-BNP markers during our investigation, and in all patients we can see improvement in pro-BNP marker as that's quality of life and our parameter of left ventricular, not another one markers, just pro-BNP.
And if there are structural changes in the right heart, if you have pulmonary hypertension, if you have
No, we are not
dilated
include.
RVs?
I see. We are not include patient who has pulmonary hypertension more than 70 milliliters, just not so severe, because we cannot treat this one with this device.
Roxana?
Congratulations on your work. It really is intriguing to see possibilities of this device. I guess one question that I have, in what way are you disrupting with the implantation, the mitral valve apparatus? Because it seems to me you're coming from below and then you're going somewhere close to the mitral valve, but not quite in the mitral valve. But the apparatus, as you know, is much more complex. Is there disruption? Have you seen anything like that where the apparatus, the chordae, get in the way when you're implanting this device?
We are not disturb mitral valve because we are going through aorta valve, and everything that we made with TEE, and it's situated about 12 millimeters under the mitral valve. That's why it's not disrupting, but sometimes we can see during the procedure severe mitral regurgitation, but it's during the procedure before cinching, and when we stop cinching and device go back, it's disappears this regurgitation. Sometimes we can see arrhythmia, and sometimes in 3 patients we can see bundle branch block after the procedure. But in some days it's disappeared. And we have experience with implantation 35 patients, and we needed 3 CRT implantation in 10 days after the implantation of this device, because before procedure they have temporary bundle branch block, and after the procedure it was permanent, and we have to implant this device, new device.
I'm sorry, but I'm just continuing, and it's just really in order to understand. The apparatus goes down up to the papillary muscle, which is very, very low. So there is no way that you do not touch it or disturb in any way with the action of the apparatus. You understand? We're asking it just in order to understand. Maybe this is part of the treatment, but there is no way that it is just holding it without influencing in any way on the apparatus.
You know, maybe you can go back and show us that slide with a procedure so we can discuss while people can see.
No, I think it's intriguing. It seems to me you go, from what I saw, that you bring it in, but you go around the apparatus. You try to go around the apparatus.
Behind the heart.
And behind it like that, because it's like like a snake. It goes around and then you cinch it. But it could have those important, so it seems to me you really need very, very good transesophageal echo to watch the procedure. But maybe you can show it, because that would be helpful.
Before procedure, we made CT to really understand. Okay. Before CT, before procedure, we made CT to really understand how possible we can go. And we know about hearts, we know about everything, about structure of mitral valve, about hearts, and during this procedure we make TEE to really understand how catheter goes. Because I perform TEE too during the whole procedure, and it's the most important moment of the whole procedure when you go behind the hearts. But previously we can see all structures on CT, and we discuss with proctors where we have to have big attention to what point. Because in P2 and P3, sometimes it's additional heart. That's why we have to go very closely to the left ventricular free wall and really behind the heart. And if we have not suitable structure for implantation, we reject such kind of the patient. It's if a lot of hearts and we cannot go forward.
Is there a way to use MRI before to see the chords a bit better?
CT.
And any role for utilization of intracardiac echo in addition to
Yes,
TE? That could it help? I mean, we're going to have a similar session right after about the tricuspid valve, but over here, maybe ICE also might help?
We use only TEE, esophageal echo, during the whole procedure. Before procedure, during the procedure, during this important moment, and after the procedure. It's the same technology of using TEE as implantation of mitral clip. But according to my experience, mitral clip is more difficult for me, how specialist, when we do TEE during the procedure. It's more simpler.
Okay, I think this is very interesting. And another thing, it looks pretty standardized, the procedure, right? Yeah. So we did the animal training. We were looking to overcome some bureaucratic hurdles that we have in the introduction of the study in Greece, but it looks standardized. And in your opinion, what's the learning curve? You know, how many cases does an operator need to have in order to be capable in doing this procedure? So it's 220.
How many cases?
Yes.
I think it depends how often you do this procedure. Yes. For example, if you do one procedure per month, it's not enough. Yes. Sometimes we did, for example, during the week, one procedure per day to be more to have such experience. And now we perform 35 procedures, as I told, and I think that operator now it's enough can do this procedure in future, and now he is a proctor. Yeah,
because you have in our centers, the transplantation center, and the Dr. Adamopoulos and his team, and Dr. Bonius, I see here, he's our heart failure specialist. They are doing the best they can. Transplantation capability in Greece, we don't have a lot of donors. So maybe as a bridge to therapy, and you give ARNIs, you give ASS, GLT2s, inhibitors, and maybe you cannot do anything more than that. So maybe it's a solution. We have to figure it out.
We really need interventions to delay the heart failure progress, actually.
I think that's very important.
Okay.
Now, one final question is, you talked to us about how many cases the procedure has to do. How many cases does a TE specialist needs in order to help with the imaging of the cords and all these things? I mean, that's also another level of expertise that you need to have. So
but if
it's easy, let's say a TE person who is used to mitral valve interventions, mitral clip, this no problem to do this right away, or they need some special training to obtain some special views, etc., for this imaging? Yeah, it's not big training, but if person perform TE during the mitral clip procedure, it's not difficult to start to do this procedure. But you have to use some additional view, transgastric view. We don't use this transgastric view during the mitral valve procedure. But if you make tricuspid valve procedure, it's really more simpler.
Good. So, thank you.
Okay,
Dr.
thank you very much.
Thank you.
So it's my pleasure to ask Professor Finkelstein from Tel Aviv Medical Center to talk about transcatheter aortic valve replacement, our long and fascinating journey. Professor.
Kidding. Good morning. Thanks again. My name is Eric Finkelstein, and I'm from Tel Aviv Medical Center. And I was asked to give a short talk about my way or our way, our odyssey in the last 20 years with the TAVR. So I'm going to say a few words about the history of TAVR evolution, our frustration in the beginning, what have we learned, and finally what I have learned from this journey. Now, regarding the history, you have shown this picture of Anderson, who did the first step, but as a matter of fact, the real deal was done by this wonderful person, Alain Cribier, with Martin Leon and Helen Elchaninov 22 years ago. Now, they did this case in a retrograde manner, and this is the first case, and this is what it looked like by the end of the procedure. Almost in parallel, but a little bit later, Jean-Claude Le Baudet with Eberhard did their first case with the self-expandable valve. And then we were introduced with the first generation of the core valve that was non-retrievable those days, and Sapien, and then the Sapien XT. We have learned the aortic valve, which is really, really much simpler and stupider than the mitral one, with just a fibrous core and endothelial lining. We have learned and invented, as a matter of fact, those three rings that are not true anatomical rings. And we learned from that time in the beginning, whereas the AV node that we have to be aware of, and the distance to the corner is that according to the PM, CT, and angio, were longer in the right corner than in the left. And then we started with our frustrations. We're frustrated because it was what we call the unfair play of TAVR, that as opposed to PCI, that every fellow starts with the simpler case of discrete, accessible, non-calcified type A lesion, we started with the very, very high-risk patient, very challenging and very difficult clinically and anatomically. They were very old with LV dysfunction, comorbidities, and renal failure, etc., but as compared to those metastatic carcinoma of breast, lung, colorectal, prostate, and ovarian, this was the prognosis of the patient that we started with. So they were very old and very frail and very sick, but they wanted to live. So we had those first early hurdles with the mortality, the stroke, the aortic rupture, the occlusion, embolization, the PVL, etc. You all know it. And most were significantly reduced a long time. We started with the huge numbers of mortality, as Roxana said yesterday. We were not used to it. I mean, we're dealing with coronaries, and you rarely see a patient who is dying in a procedure unless he comes with a shock or acute MI. And here we started with almost 2 digits of mortality. We're frustrated because we had around 10% of severe or vascular complications that increased mortality. But the main problem was the calcium. You see those two bones here. Do you see that? Oh. Those two bones are the valve. And just have a look. You see, this is the balloon, and this is this bone, and we just move it to the side. And you see it's here. We don't really break it. And when we inflate the valve and this is the Sapien, the first generation, you see it's here, and we just move it like a door to the side, and it is still there. Nothing happens to it. So sometimes it's still there, we're lucky and have a nice result. But sometimes it's here, we're not that lucky. So we wanted it to look like this, but it's not like this because it is still there, and we hold those windows to have the PVL. And PVL was again, a 2-digit number and increased mortality as well. So what have we learned? Well, you know that we learned from randomized controlled trials, from registry, and from small observational studies. And we had the partner one, and you know, and I'm not going to go over it, but what you know, and it was published in the New England, we know that there was no inferiority to surgery, but as opposed to medical therapy, for which the vast majority of those patients were entitled to, there was a reduction, an absolute reduction of around 24%. And if you want to understand what does it mean, the absolute reduction of aspirin, fibrinolytic, beta blockers, ACE inhibitors is those numbers. And here there was a no option patient with a 24%. And then we had all the other partners, and I'm not going to go through it until the low risk one. And then we changed the generation of the valves, and we got better and better results, and everything went down. The mortality went down, the stroke went down, the moderate or severe PVL went down to now, those days, almost 0%. The devices became smaller and better, and we had the protection, cerebral protection devices, and then we learn about the halt, and then we start talking about the durability, and we had the VARC 1, 2, and 3 definition. And the notion showed us that we are not really inferior to the surgical valve by the durability. And then we learned about doing this with bicuspid valve, and Ewan and Raj Makar showed us which patient should we do and which one we should not do with the calcification. And Ran Kornowski, my friend, and Danny Dvir, that was supposed to be here, he was those days a fellow in Tel Aviv, and they published the first registry of valve-in-valve. And later on, Uri Landis was a fellow at the same center, did it with John Webb, with TAVR-in-TAVR. It's not working? Oh. And then we have even cases of TAVR-in-TAVR. We had the coronary access difficulties, and then we started to do a TAVR in the mitral until we'll have the next generation of mitral valve bioprosthetic for implantation transcatheter. And we had patients like this as well. And Roxana talked yesterday about the adjunctive pharmacotherapy that we learned more and more and more. And we did the minimalistic approach that Ioannis wanted to show us yesterday. We started like this. And this is what I look in my cath lab those days. I'm pretty much alone. Somebody is joining me just for the implantation. I have one nurse and one technician. But what I have learned of this journey, well, I've shown you yesterday, those are the guidelines, the European ones, and those are the Americans. But those are the numbers. It's pretty sad. Those are the numbers in spite of the guidelines. And the numbers are because this is what a 75 years old patient looks 24 hours after surgical AVR. And this is what Mr. Cohen, who is 85 years old, looks 12 hours after a TAVR. So we say in Hebrew that the patient are voting with their legs. And Michael Mack said once that when two procedures are equal, the less invasive procedure wins. It should not be like this all the time. It should be like this only if it's correct. And I'm telling you this because, you know, this is a paper in the New England comparing lap cholecystectomy to open cholecystectomy, okay? Do you know this paper? No, you don't. You know why? Because there's never been a paper like this. There's never been a study like this. It's a fake. I just created it. It's because the same people are doing lap and open at the same hospital. So they don't have to prove themselves which one is better. And I'm saying this because, look, when the TAVR started, you know, the Gillette stock market, you know, the shaving knives, they dropped by 92%. And this was just because this man, you know him, right, Clooney? And a few weeks later, the soccer Beckham player, okay, they didn't shave. And all the rest is history, okay? My 4 sons-in-law and my son, they're not shaving, they're just like this. And I'm showing you this because we are in an era that many things cannot be anticipated, but many can. And Charles Darwin said that it is not the strongest of the species that survive, not the most intelligent, but rather the one that is most responsive to changes. And when I'm talking about changes, you know, that's what I did in my hospital. I took my chief of surgery and convinced him to join me and to do TAVR cases with me. And I said, like Confucius said, you know, a long journey starts with one step. And this is Udi Ra'anani. Muni knows him. He is the leader of cardiac surgery in Israel. And I love this picture because we're here in Toscana. We're here in Toscana. We're laughing. We're debating a lot about this. And we're sitting in a chair that each one of us is in a wrong direction, but we're still friends and we're laughing. And this, in spite of this, have a look. This is the TAVR. And this is the surgeon. He's not that poor. Have a look. This is me. Now, regarding the future of valvular disease, we need to work with the surgeon to define where we go next. Neither TAVR nor surgery will look the same in 10 years, and we're at a critical time in terms of defining the future treatment of valvular and structural intervention therapy. Now, I had the privilege to witness the TAVR evolution over the last 20 years, to study the field, to learn the technique from pioneers and top experts, and to teach others. I had the privilege to help aortic stenosis patients in need, to explore research, to contribute a bit, and to look for the future with great enthusiasm. I feel fortunate to be part of this exciting medical journey, and I strongly recommend the young generation of cardiologists to get on board at the various treatment tremendously important specialties of structural valvular disease, diagnosis, and intervention. I truly do think so. Thank you so much for your attention.
Thank you very much, Professor Finkelstein. I mean, you made this journey, a really fascinating journey, so educational and so nicely presented. Can I talk about expanding the criteria, expanding the indications in moderate aortic stenosis? I mean, I can understand in moderate aortic stenosis, we need criteria like imaging criteria, GLS or interstitial fibrosis. But do we really need criteria in patients with moderate aortic stenosis and heart failure in a double-loaded ventricle to get rid of the afterload? You understand what I mean?
I think it's a wonderful question. It's one of the most important questions those days that we are facing. Now, you know, it always gives me a déjà vu of the stent era. Now, you all remember that none of us would have sent a patient with just a proximal circumflex stenosis to surgery. But at the same time, and I'm talking about the time that I became interventional cardiology, we had no stents, okay? And part of the patient were inflating a balloon and then standing for 20 minutes with inflated the balloon, which was reperfusion balloon, you know, with a hole inside, in order to, anyhow, to take care of this dissection. Now, why am I saying this? Because unlike surgery, you know, you can say, look, the patient has got moderate aortic stenosis, but he has LV dysfunction. Why won't I do TAVI? Because it's not opening the chest, it's a 40 minutes procedure, etc. You're absolutely right. But unlike the stents today, there is one black side, the durability. So any patient that is coming to me and I see that he has aortic stenosis, but he is not symptomatic, for instance, or is mildly symptomatic and he's got no, I'm trying to postpone it according to his life expectancy as compared to the durability of the valve, because this is a critical part of the decision making, not like many things that we did before. Otherwise, I got no doubt that somebody with moderate aortic stenosis and reduced LV function, TAVI will help him. The only question is if it's right to do it early or not. But whether it's going to help him, no doubt about it.
Yeah. So on the same note, so we were talking about lifetime management, and we discussed yesterday as well, and Roxana had this argument that maybe it's too much for a 65 years old and a younger patient to proceed to TAVI, but still you see the TVT registry data, and you have 50% of these people, these patients undergoing TAVI. But yes, maybe it's too much, but maybe, you know, it's their decision, and they can do it.
Yeah.
So it's patient decision as well, and if someone wants
That's
to
the point, Ioannis.
do something,
it's not always the patient decision.
Yes.
This is wrong. You know, I think that the patient in the center is right until a certain note. You know, because the patient will tell you, I don't want surgery. I mean, you can understand him, but your duty is to convince him and to recommend what is better for him.
But if you, let's say that you have a patient, 60 years old, you know, healthy, but suitable for transfemoral and approach and has tricuspid valve, and he wants to say, you know, you have and you propose to him to place an annular valve, and maybe after 8 or 10 years you have a supraannular valve. Why is it bad? So it's the life expectancy is 80 years or more. Yeah,
because if nothing changes, it won't be enough. Because within another 10 years, he's going to need a third valve. Now, you can be the devil's advocate and says, Eric, come on, we both know that within 10 years, there's going to be a resilia that will last for 30 years. And I'll tell you that you cannot treat patients according to future technologies. So, you know, it's endless. It's really an endless discussion. But I think that right now, it's really incorrect to take a 60-year-old patient, unless you have a good reason for this, and do TAVR on him.
Good. Any other comments?
Just to clarify also, there's a lot of discussion made about this 50%. First of all, it's a percent. Not that many people exist in that bracket, all right?
In what?
In the 50% of under 65 in the United States, TVT, first of all, that bracket is very low. There are not that many people getting valve surgeries. And I can tell you the TVT registry doesn't capture many things, rare things, lymphoma, myelodysplastic syndromes, this, that, the other. And many of these people have one of those rare conditions, any one. So it's not like fantasizing the normal disease-free 55-year-old walking in and having a TAVI. I don't think that at all. It's just that has things the registry doesn't capture. Each one of those things is rare, but any one of them exists more frequently than we think. And that's what it's, of course, a few of them that, you know, I don't know, maybe they don't want to take time off their work, this and that, you know, who knows, maybe they think they're smarter than the data. This is a small minority. Most of the people, they have a reason, some reason. Now you tell me, you know, is it significant, is it, no, maybe not 100%, but there's some indication that is weird, and any of them can exist in more patients than we think.
I hope so.
Comment? Vasily?
Μικρόφωνο όμως, έτσι, μικρόφωνο. Είσαι στη λάθος θέση, Βασίλη, στη λάθος θέση.
Are all these procedures in US below 65 years old covered by the Medicare or by insurance?
Yeah, Medicare doesn't exist in there, but commercial insurance exists, and I'm sure they're covered. The majority are covered.
Because
I'm sure some people can pay out of pocket, but you know, most people are covered. Covered, yes.
Just a comment.
Yeah.
That heart teams, I think, should incorporate heart failure specialists. This is our practice as well, because they can offer their expertise before TAVR and especially after TAVR, because sometimes TAVR is just the beginning of the heart failure management. Just that.
I know Samatis wasn't here yesterday. We had discussion about that, and you know, we said that, I'd said at least, that a new subspecialty of heart failure is emerging, and it is a heart failure related with significant valve disease. That we can say, okay, whatever, that's well known. I don't think it is. Most people were trained in heart failure at the era of IV drips, of inotropes, ICU, heart transplant, LVAD. That was their interest and their training. And then, of course, some people have valve disease, and they were discussing with the surgeons bridge to transplant versus maybe multivalvular disease. And that's it. So nobody was really trained in having multivalvular disease and maybe fixing one of those valves. And what happens with that? And is it moderate or is it moderate to severe? Should we do the aortic first, the mitral? Is it worth it? And now all these possibilities all of a sudden exist, and all of them can also be bridged to LVAD or bridged to transplant or just stand alone. I can tell you there is some people, many people perhaps in heart failure, that not only feel they don't, I don't know, they're not that equipped about it, but also maybe they don't like that. Maybe they like the transplant. So I think the new generation that see more of these things, they're going to be a little bit more acquainted with these types of things.
Thank you, George.
Yeah.
So, Arik, it was an amazing talk, and but now we have an equally amazing talk coming up, and it's from Roxana Meran. It's on new and future pharmacological therapies in cardiac patients. So, Roxana, we're all ears.
Good morning. This is we're really going to be talking about something completely different. It's not quite about valvular heart disease, but more about all of our patients with cardiovascular disease. I think often when we are doing and working in all of these years, I'm almost 30 years that I'm doing this work in interventional cardiology, we forget that prevention is incredibly important, and that the medical management of these patients with regard to what we can do for their cardiometabolic health could be ever so important, and in fact, not just in improving our outcomes, but really reducing the recurrent rates. How much of, let's say, heart failure with, we're seeing that so much now with all of the treatments and therapies that are becoming available, and we're seeing HFpEF now being treated with anti-inflammatory drugs, or HFpEF, heart failure with preserved ejection fraction, where we really don't have devices for these patients yet, is being treated with diabetic drugs. So it's important to kind of really think about that. And so I really appreciate that you're giving me an opportunity to talk with you a little bit about what we need to know. You all saw my disclosures yesterday, but I'm going to talk about these three areas on the antithrombotic therapies, lipid lowering, and inflammation. We talked a little bit about the time course between balancing bleeding and ischemic complications. Let's just here talk about our patients undergoing PCI. But it's very similar in TAVR as well. It's that early first 30 days where we see rich events because we've done a big, big procedure. But let's understand that what we're treating in the coronaries is just the tip of the iceberg of what else is going on in the patient's entire body. And so their recurrent events over the next ensuing years have to do probably with what's outside of the stent. Over the last 3 decades, we've been riding this roller coaster of duration of antiplatelet therapies in our patients undergoing PCI. We started with an arbitrary number of like 30 days when we first learned that you need to have something more than just aspirin alone with a P2Y12 inhibitor. And then we went for prolonged and ever so long with the DAPT study. Then we started to come back. And I think what it was is we started early when stents were being evolved and developed with this era of thrombosis. We knew that we needed something to protect against clotting off that stent. But as we became extremely aggressive there and started to see that and came about with the next generation drug-eluting stents and pushed our antithrombotic regimens and antiplatelet therapies and with novel potent agents, that we became aware that bleeding was a thing and that bleeding is associated with mortality. So what did we do is we pulled back on the antiplatelet therapies. I think where we are now is this area of equipoise. We have new stent platforms, better understanding of what happens with dual antiplatelet therapy cessation, and experimental approaches that are now becoming guideline therapies where we're withdrawing the thing that we were so attached to, aspirin. So we're taking away drugs and thinking a little bit about how do we balance this. And I think where we are now is in this like aspirin-free strategies. Nobody ever imagined when I designed Twilight, I couldn't get centers to come forth because it was so incredibly difficult to get people to imagine that you would withdraw aspirin in patients who are having a stent placed. And we put now the patients in these 4 buckets. Where are they in terms of their thrombotic and bleeding risk. And I came up with this cute schematic on the left, but this is what AI and machine learning will be working on individual patients to figure out where they fit in these boxes and how do we design the best therapy for them. That's the future. But then there are also new therapies. This factor 11 inhibition is exciting. Targeting residual thrombotic risk without increasing bleeding events, is that even possible? Well, let's think about that. Right now, we have randomized clinical trials on P2Y12 monotherapy. Look at the number of trials, and they're growing ever since in terms of reducing and taking aspirin away. But is uncoupling hemostasis and thrombosis even at all possible? Well, let's go back to hematology lessons. Hemostasis is from the extrinsic extravascular pathway that's triggered by tissue factor, and factor 11 is implicated in that consolidation, but not essential. Thrombosis mostly comes on the intrinsic pathway, intravascular pathway, triggered by contact, and factor 11 is also implicated in the amplification, but not essential. So can we uncouple this? Can we go up, above, and get there? Well, there's a lot of interesting ideas to go to factor 11 as a target. There's human genetic deficiency data that shows that those patients who have congenital factor 11 deficiency, 1 in 450 Ashkenazi Jews, have a reduced risk of thrombosis and rarely experience spontaneous bleeding. Genetic epidemiology in a very large GWAS cohort studies have shown that the risk of thrombosis is twofold higher in those patients who have high levels of factor 11 compared to those who have normal levels, 40 to 90% lower in those who have lowest levels of factor 11. And now we have animal studies in multiple animal animal models with mice and rabbit and monkey and baboon, no increase in bleeding. It's really unbelievable. And look at the explosion of clinical trials investigating factor 11 inhibition. We've got to get the dose right. You saw Oceanic AF stopped early, and we're going to hear, hopefully at the ESC this year, exactly what happened and what's going on. But look at the number of different programs. The programs include antisense oligonucleotides, antibodies, and small molecules, and we're working on many of these. What's next? This is the program that I'm working very closely with, the Librexia program with milvexian, which is a small molecule. And there is now 50,000 patients that will be evaluated with secondary stroke prevention, acute coronary syndromes, and atrial fibrillation, all well underway and enrolling faster than we would ever imagine. Our ACS trial is ongoing on top of dual antiplatelet therapies to be given a factor 11 inhibitor. So what about early treatment of high-risk patients after an acute coronary syndromes? Can we get the patients involved and people outside of the hospital involved? We need to do something better because you know what? The residual events of those patients with acute coronary syndromes, no matter how fast we get to them, once they make it to the hospital, we are not making the impact we want to make. There is still about 10 to 15% residual events, hard events like death, MI, stroke in those patients. Well, there is a novel P2Y12 inhibitor that you could self-inject. And boy, since Ozempic came out, everybody knows how to self-inject with no problems whatsoever. Patient comes in with an acute coronary syndrome, and what we want to do is to reduce those recurrent events. We send them home with an injector. Half of them are placebo, the other half are real drugs, P2Y12 inhibitor, and this is the subject of the SOS AMI study. We are giving selatogrel for STEMI and non-STEMI patients who come in and they go home, double-blind, placebo-controlled, enrolling 14,000 patients, and I'm working on this trial, and it's ongoing and doing extremely well. There's also a promise of a subcutaneous glycoprotein 2B3A inhibitor, back again on that roller coaster. And this one is the RUC4, developed by Barry Kohler, who discovered epsiximab. Rapid, high-grade, limited duration of platelet inhibition within minutes. And they're doing this in the ambulances or very, very early. This is the CELEBRATE phase 3 study, STEMI patients, very, very quick. 2,500 patients are being given 2 different doses versus placebo and then transferred over to the interventional units. Interesting, isn't it, on the antithrombotics? But what about beyond antithrombotics, the lipid-lowering agents? Well, the lower, the better, LDL lowering. High is bad, lowest is best. We know all of these data from our guidelines, acute coronary syndromes. We're going as low as even below 55. It used to be 70, now we're way below. More aggressive therapies in higher risk patients. Strike early, go there fast. PCSK9 inhibitors now are really very, very interesting. So much data, I'm not going to show you those. Monoclonal antibodies, they bind to the PCSK9 receptor and prevent that association between LDL receptor and PCSK9. And we're also targeting it with messenger RNA. These are large-scale studies that are ongoing. Orion 4 that's finishing and following up, and we're doing Victorion, going after this to reduce LDL cholesterol as low as possible, but also Lp(a). I won't go after Lp(a), but let me tell you what we're doing in acute myocardial infarction. There is data now that shows that evolocumab has important, and alirocumab, changes in the component and the composition of the atherosclerotic plaque. This is the HYJUN study. The thin cap fibroatheroma becomes thicker. Pacman-MI showed that exactly after an acute myocardial infarction, that there was a change in the volume, the very, very important thin fibrous cap. And now, Evolve-MI, way ahead of enrollment. I'm on this executive committee, very early after an MI, almost in an acute setting, 3.5-year follow-up. You come in with an MI, you go in, you get your intervention, but at the same time, you're receiving a PCSK9 inhibitor. And of course, this is going on also, as I said, with inclisiran, and stay tuned for what we're designing on what we call V intervention that will come in acutely after PCI and peripheral vascular intervention. We're also looking at cholesterol efflux. This is a synthetic ApoA1 work that we just published in the New England Journal of Medicine, going after the efflux, taking the improving and enhancing efflux using ApoA1. And so this one obviously didn't show the benefit, but in patients with a high LDL cholesterol, there was a major reduction. And so stay tuned for what we're going to do here in high cholesterol patients. And then there are novel therapies for Lp(a) as well. Antisense oligonucleotides, small interfering RNA, and then of course the PCSK9 inhibitors. But there will be pelacarsen, we're working on OCEAN study, in an outcome study that will come out. At last but not least, I know I'm over time, but this is what I'm most excited about, inflammation. It's really important to think about that. Remember, we were focusing on our traditional risk factors: diet, lifestyle, smoking, cholesterol, diabetes, chronic kidney disease, hypertension, and then those we can't change, like our age and genetic predisposition. But those absolutely are very important, but there's an emerging one that is inflammation, but it's not so emerging. Back in 1955, the very first report of high-sensitivity C-reactive protein and its association with an acute myocardial infarction was well described. Is LDL enough? You get as low as possible? Well, it seems to be that there's something more that drives that. And this is Paul Ritker's work from a meta-analysis where you look at those patients who achieve the cholesterol, but it's the inflammation that's driving the major adverse cardiovascular events, even in those patients where you get the cholesterol as low as possible. Why is inflammation relevant? Well, it plays a very important role in atherosclerotic development. So maybe we could even prevent it from the get-go. This inflammasome, the NLRP inflammasome, once it's activated and then chronically activated, it induces this very important cytokine cascade. What are those cascade? Those cytokines? IL-1, IL-6. They're upstream regulators and come down into the liver, and what we see in the blood is the C-reactive protein, which is an acute phase protein that serve as the downstream biomarkers. What's important is on the left side of this slide, which is what's going on with these cytokines. Look at what they're doing. They increase macrophage activation, smooth muscle cell proliferation, vascular inflammation, endothelial function, and of course atherosclerosis. Those patients, what can we do? Where are we with that? Colchicine has been around forever. The concept of inflammation is, for acute myocardial infarction, very, very important. It's these phases. There are 3 phases. There's that acute phase, a burst of inflammation when acute MI happens, the plaque ruptures and all these things are happening. There is that protection and the healing around the myocardium, and then this low-grade inflammation that goes on, that keeps going, gives you that residual inflammatory risk where the patient comes back. And I think it's those early and the late phases that need to be addressed. So in a STEMI, the best possible, or non-STEMI, anyone with an acute myocardial infarction, can we get to them acutely, reduce that, hopefully balance it for the healing, but then go in the chronic phase and keep that patient at a low inflammatory state. Well, there's been a roadmap for this. Colchicine upstream in that NLRP inflammasome, microtubular polymerization inhibitor, proven efficacy with cold cut and low dose coat trials, proven efficacy reducing MACE. Downstream canakinumab, this is an IL-1 inhibitor, proven efficacy in CANTOS, but more infections. We now have ziltivekimab. This is an IL-6 ligand inhibitor with a specific reduction of IL-6 just before it gets into the liver to produce the C-reactive protein. And it's been already fully enrolled in the ZEUS trial for high-dose patients, Hermes for HFpEF patients, and of course, very, very important Artemis trial, which I'll talk to you about. Canakinumab, this monoclonal antibody, look at the hazard ratio when IL-6 levels were high. And what we're doing now is going after this, ZEUS, Hermes, and Artemis. Zeus is already done enrolling 6,200 patients. DSMB is allowing this to go on with the IL-6 inhibitor ziltivekimab. The Artemis AMI is what I'm really excited about. In AMI, we believe if we get acutely and then go after it later, that we could reduce the signaling, and there's been some good data on this already, to enhance remodeling and in the chronic phase reduce events. And this is what we've designed, a 10,000 patient study in patients who present with an acute MI with some enrichment criteria to be randomized to ziltivekimab, loading dose of 30 milligrams subcutaneously versus placebo, and then sending those patients home in a sub-Q once-a-month injection with ziltivekimab. And we will look at that 3-point MACE. We're very excited to have that study launched right here in Greece, and we look forward to make sure that this happens. But thank you. The future is bright in prevention after intervention.
Thank you, Roxana. It was an excellent presentation. So, do you have any comments, Stamati? I think it's very, very intriguing. Do you foresee, Roxana, that we might reach a phase that, after these studies, by prescribing anti-inflammatory drugs or lipid-lower drugs, we have some stabilization, for instance, in the progression of the valvular heart disease as well? Do you think that it's, by targeting Lp(a), for instance?
Lp(a) is a very exciting one. The association with aortic stenosis has been there for a long time, especially in women. And one of the things that is ongoing right now with Lp(a) through Novartis, because they do have a study ongoing with Lp(a) and treating those patients early on to see if there is some association or less progression of aortic stenosis in those patients, early diagnosis of aortic stenosis with high Lp(a). It's going to be very, very interesting. But that will take a very long time to evaluate. And of course, it probably goes back to these GWAS studies and other cohort studies to really, really assess, because this takes too long to figure that out. But I think what I'm trying to say is that your valve patients have a lot of cardiometabolic disease. Exactly. Putting in devices, just stenting it, just valving it, just doing the clipping it, and whatever it is not enough. It's not enough. And we need to think that the causation of all of this comes from the cardiometabolic health status that has never been perfectly fine. And that is the reason. Of course, there are genetic predispositions and other things that come along and things that we're born with, et cetera. But this is a very, very important part. And we as interventionalists have to embrace this. If we want our devices, our work in the cath lab to translate into better outcomes, we have to marry intervention to prevention. And prevention doesn't mean we have to close our eyes and say, oh, we don't want to prevent, because then that reduces our procedures. We need to think about how we could get to a place where intervention and these, whatever these things are now really as low as possible, because we want our intervention to be durable. On the valve side, factor 11 could be very exciting. Think about the frail patients who may not have bleeding and have reduction of ischemic thrombotic events for their valves. Maybe that will improve and enhance valve durability. On the coronary side and peripheral vascular side, it's so important. All of these patients have peripheral vascular disease. We saw the yesterday's live cases. You had to go from the subclavian. There was stents all over these poor patients. Prevention has not been what we think about as early as possible in our patients, but certainly after they leave the cath lab, it's like our job is done, and it isn't. It just only has begun.
Yes.
Excellent talk, very intriguing and very promising, actually. Talking about promising, inflammation is a very important component in the whole spectrum of the cardiovascular disease. And there are lots of theoretical advantages, and I hope all these studies are going to be translated into clinical success. Because in heart failure, which the immunoinflammatory component is very important, but targeting just very specific components like TNF, let's say, was not translated into success because it's a multifactorial sort of enterprise. So I hope all these studies are going to be translated into clinical success. It's very important what you said about prevention. Let's say we've got now over the last few years this SGLT2, not only treating heart failure patients, but also preventing high-risk patients in developing heart failure, yes. But hopefully...
Absolutely.
Well, I mean, a few things we have to also reflect how these ideas that we have about cardiovascular disease change over time. And let's start about prevention. We used to talk about primary prevention and secondary prevention. Secondary prevention is after someone has a coronary event or cardiovascular event. However, the last few years, there is a transition. We have another form of secondary prevention. People who have no event, but they have sophisticated imaging positivity. What I mean is high calcium score and abnormal CTA. And all these people have now, they're not primary because they have disease, but they're not quite the classic secondary because they never had an event. But I think that's a new horizon I think it's a new diagnosis of early secondary prevention, formerly primary prevention, that now we know these people. Before we just didn't know them. So that's another concept that
Prevention
I think broadens.
1.5, George.
That's right, exactly.
Primary,
that's a new diagnosis of
1.5.
prevention. That's a new
Yes.
diagnosis of prevention. So you hear people
Before you get an event.
coming left and right and say, oh, aspirin has no use in primary prevention based on some old studies. One has to pause a little bit and understand, how did you define primary prevention in those studies? If they were with the old criteria, then, that may not be exactly true by what we use these days. And the other aspect also is atheroma and arteriosclerosis. In the early days, I was always, as a medical student, a little blurry about what's the difference. Now I understand now that there's a vast difference. Atheroma is the lipids, and then we get rid of that. We can get rid of that. We can prevent it, but we cannot really eliminate it. We just transform it into something that is calcific, and that we see that all the time now in the cath lab. Then we're getting rid of acute events, getting rid of vein graft disease, getting rid of massive thrombotic lesions. When was the last time you saw a massive clot in a coronary? Not that often, unless there is an aneurysm, I have to say. At the same time, we have a surge of calcific disease. Perhaps we're transforming the plaques, all the great prevention things we have, but the plaque doesn't go away, it just becomes something else. That's a lot of calcium. We're talking about Lp(a), aortic stenosis. It's a calcific disease. Well, everybody thought it's a calcific disease. Yesterday we had severe aortic stenosis in John's case, and there was little calcium. Well, what was the pathology then? It's not calcific stenosis, it's maybe something that is precalcific, still stenotic. So there's a lot of research coming up now into exactly other causes of early diagnosis and understanding of aortic stenosis of high significance. That is not really that much calcific, but still quite a bit stenotic. And therefore, are these leaflets full of tissue factor? Is a Lp(a) interaction? If we wait enough, is that all, which is like fatty now, is going to end up being calcific and super severe in 5 years? Perhaps it is. Do we understand that? I don't think we do. So there's a lot of research to understand the valve disease progression. Along the side, we probably didn't have that much understanding of and prevention of classic coronary artery disease, I think. And we see where we are now, and I can't imagine where we're going to be into understanding and reforming our definitions of coronary prevention, secondary prevention, revised secondary prevention, early secondary prevention, aggressive prevention, and at the end of the day, all those are going to transform what kind of interventions we have. No more thrombotic interventions, a lot of calcific interventions, maybe later no interventions, but in a much larger population, so it's still a very big number, perhaps an even bigger number of interventions at a lower percentage. And that's a good thing for the patients or the population.
This is really intriguing and very interesting concept. And maybe, that's what you presented, Roxana, about the new iterations of all concepts. For instance, the self-injecting P2Y12 inhibitors and the CP2P3 inhibitors. So these are all really interesting. So thank you everyone for attending this session. So we're a little bit late in our program, but I think it was worth it. It was an amazing discussion. Just to remind everyone that a training, an echocardiographic training is coming up at 11 o'clock, and there's always the Medtronic training possibility in the educational capsule just outside of the Vienidio. It's an amazing place, and everyone should attend the workshops scheduled there. So there are 4 simulators there, so it's very interesting for anyone to be part of it.
Oh, absolutely. I think right outside in front of Sigru Avenue, the simulator reserved to try and practice on the computer simulated cases of aortic valve and other interventions. That's great. I think we move on right away to the next session on a very, very interesting tricuspid valve. Tricuspid is a forgotten valve. So this year, I asked John, well, instead of putting it at the bottom of the day, let's just switch it around and bring the forgotten valve at the top of the day, and we'll do mitral later in the day. So that's why we're starting with tricuspid valve intervention session. Let's invite Dr. Xavi from Shara Zedek Medical Center in Jerusalem to join us. Also on the panel, Doctors Niños and Niños, Grapsa and Bonios to join us up here. And I'm very pleased to invite a pioneer of heart valve, tricuspid valve intervention. Oh, there's a switch in the program. Dr. Dimitriadis, that's fine. It's a specialist in tricuspid regurgitation, edge-to-edge repair, tips and tricks for successful treatment, right after a very interesting topic of tricuspid valve replacement. Let's connect to Dr. Dimitriadis and also note that Dr. Koutsogiannis is a remote internet-based commentator.
So, good morning also from my side. Do you hear me?
Very well.
Oh, perfect.
What are the slides, though?
Thank you very much for the invitation, and thank you also for this change. It was important because we have a little bit of delay in the schedule, so I will go straight forward with the presentation. So, yes, so tips and tricks for the tricuspid. Of course, the most important part is the interventional part when we hear tricuspid regurgitation and edge-to-edge therapy, but I would like to present a few slides which, in my opinion, are very important also to understand a little bit better the tricuspid, because all of us in the meantime, we know how we have to implant a device in an edge-to-edge therapy after such cases with the mitral valve. But we have to understand that the strategy in the tricuspid valve is a little bit different. So first of all, as you already mentioned, the tricuspid valve is a forgotten valve. It's actually in black box. And as we can see here, the incidence of the aortic stenosis is about 2.8% in older patients, and in mitral regurgitation, 9.3%. But the tricuspid regurgitation is something in between. It's almost 4%. That's why I understand and can underline that the tricuspid valve, and especially the tricuspid regurgitation, is a forgotten valve. A few things about the graduation of the tricuspid valve, especially the regurgitation. We don't have only 3 grades. We have actually 5 different classifications. We have the mild, moderate, the severe, but in the case of tricuspid regurgitation, we have also the massive and then torrential. This is important to understand because the results are depending on this graduation. If we have a torrential regurgitation, something like free flow, so to say, to achieve a severe regurgitation after a therapy is a huge step. We cannot make a torrential, we cannot change the torrential regurgitation into a mild regurgitation after an edge-to-edge therapy, but we will see in the next slides also what's the outcome, the clinical outcome in such cases. The classification, the most easy classification depends on a few parameters like PISA, like ERWA, and vena contracta. The PISA is a relatively simple parameter to classify, to make the measurement in the echocardiography. We can make the calculation also automatically, but it's terribly inaccurate. So let's see an example here. For example, in that case, we have a PISA of 7 millimeters. The area, the calculated orifice is 0.4 centimeter. But what about that case? Actually, it's a case with, so to say, a free flow. It's a really torrential regurgitation, but we don't have actually any PISA. And this is the problem with the PISA. The PISA begins very low, goes up, becomes up to 7, 8, 9 millimeters, and after that, we have a huge gap in the valve. The PISA goes again down, so it becomes lower. And this is something we have to take into account if we base our measurements, our evaluation of the tricuspid valve, especially with the PISA. Much better is the vena contracta, but the biplane vena contracta, not only on one plane. As we can see here, we have regurgitation of the tricuspid valve, and we see the valve in 2 different axes, biplane actually. And as we can see, we have 2 different vena contractas. The one on the left side is 25 millimeters, the other is 9 millimeters. So a mean is about 17 millimeters. And that means that we have torrential, massive to torrential regurgitation. I go on with the complex morphologies for the edge-to-edge therapy to understand which parameters are very important to take into account before we begin with the procedure in order to optimize our strategy. As I say, the strategy is much important in the edge-to-edge therapy for the tricuspid. A lot of people means that the presence of pacemaker lead can make the situation much complex, can impact the results. Unfortunately, or thanks God, not. That's not the main problem. The main problem are the gap size, the gap between the leaflets, the tethering distance. I will explain that in the next slide what we exactly mean with that, and the tricuspid annular diameter. The bigger the atrium and the bigger the ventricular is, the bigger is also the problem with the annulus diameter. And this is a study from Lourdes, but we have the same results also from Taramasso and from other colleagues that present also the same effect of the coaptation depth and of the annular diameter, also of the tenting area. So that means this is some parameters we have to calculate, to take into account before we start the procedure. What's exactly the tenting or the coaptation depth? As we can see here, we have a valve with a gap and the tenting of both leaflets, as we can see here, the septal, and in that case we have the posterior one. So what we have to do is to calculate the distance between the ring and the coaptation point. This is the tenting, or this is actually the coaptation depth. And we can also calculate the orifice of this triangle between the ring and the 2 leaflets. So if we have an orifice that's bigger than 1.6 per centimeter, or a high coaptation depth that's bigger than 0.76, and we have actually not the best parameters to begin the procedure, we will achieve a good result, but we will not have the best result. And we have a high recurrence rate in such cases. So that means we are too late in that case. But on the one side, we have the interventional result, and on the other side, we have the clinical result. And this study shows very clear that maybe we will not have the best interventional result in such difficult cases with complex anatomy, but we will achieve at least a very good clinical result. So as you can see here, we have again the same patient with a 9 millimeter gap and a 28 millimeter gap from the other side. as we have already seen the other echo in prior slides. And on the middle, we have two panels. The upper panel shows the interventional result, the TR reduction after edge-to-edge therapy. And as we can see, if the gap is only 7 millimeter or till 7 millimeter, we achieve very good results. Almost 80% with mild to moderate regurgitation after the therapy. But if the gap is between 7 and 10 millimeters, only 40% of the patient has residual mild to moderate regurgitation. And then we have a huge gap, more than 10 millimeters, and only 1/3 of the patient achieve a mild to moderate regurgitation after the therapy. That means almost 70% of our patients with a huge gap, with a massive or torrential regurgitation, remain with the severe or severe plus regurgitation. This is the interventional result. But what means that for the patient? Because the patient doesn't matter about the interventional result, he matters about his dyspnea. So the same classification, the same patient, the same groups were analyzed. We have the analysis of that groups also according to the clinical result, according to the dyspnea. And we show that in the lower panel. Groups, the clinical result was the same. That means almost 50% of the patients had a good reduction of the dyspnea, almost NYHA 1 or NYHA 2 classification. In all three cases, also if we had severe regurgitation, but the severe regurgitation was before the procedure torrential. This reduction of 2 grades helps the people to have a much better clinical situation after the procedure. And this is, I think, the most important thing, not only the clinical result, not only the clinical outcome, but not only the interventional outcome, but much important is the clinical outcome. I will go on further with the complex morphologies for our strategy. So it's very important the pre-screening, not only to see the gap, not only to see the coaptation depth, but also the morphology of the valve. We say always tricuspid valve, but we know now that we have not only 3 cusps in this tricuspid valve. Sometimes we have 4 cusps and sometimes we have 5 cusps, especially if we have an indentation in the anterior and posterior leaflet. And the study shows again that the higher the leaflets, the worse the interventional result. So again, a study from Sigura, and we show here that patients with 3 leaflets, they have much better interventional result with almost mild to moderate residual regurgitation in 80% of the cases after the procedure. In cases with 4 leaflets, the mild to moderate residual regurgitation is about 60%, and the other 40% is severe or severe plus regurgitation if we have 4 leaflets. With 5 leaflets, the situation becomes worse. So that means the more leaflets, the worse is the interventional result. Some interventionalists means in that case we have to go with a transcatheter annuloplasty further, but we have other studies that shows that for the transcatheter annuloplasty, the number of cusps of leaflets doesn't play an important role. Here are the results of analysis of Corber, and we can see that if we have a more complex situation comparing to a normal situation, the reduction of 1 grade of regurgitation is the same in both groups, complex and normal, and the reduction of at least 2 grades in the regurgitation is again the same in both groups, normal and complex. So that means that annuloplasty doesn't play such an important role if we have much more leaflets, because annuloplasty doesn't work with the leaflets, it works only with the ring. Now, when we have to implant our clips during the procedure, we have actually 3 options: septal anterior, septal posterior, and anterior posterior. And this is very rare, and I would recommend to avoid that if it's possible. Why that? The experience shows that if we put a clip over there, we have a completely different situation comparison to the mitral valve. We have a much more difficult and strange 3D anatomy of the tricuspid valve. So if we put a clip there, maybe we optimize a gap in the anterior-posterior commissure, but we change completely the morphology of the anterior leaflet, especially of the anterior leaflet, because it's more mobile. That means we have more tension in the anterior leaflet, we pull the anterior leaflet, and that leads to a new gap between septal and anterior cusp. So we close maybe a small gap between posterior and anterior leaflet, but we open a new one between septal and anterior. This is an option we have to choose only if we have made a big cuspidization. That means if we close completely the gap and the cusp between, and if we close completely the gap between septal and anterior cusp, and then we put a third clip, a third device between anterior and posterior leaflet. So we have the bicuspidization, and we close also a gap between anterior and posterior leaflet without to have any problem to open a new one gap. As I say, avoid to put only one device in the anterior-posterior commissure. We already spoken about the bicuspidization. That means to put 2 or 3 devices in one of the commissures in order to close completely this commissure. Or the other strategy is the clover strategy, something we learned from the cardiosurgeons. They stitch, make 2 stitches between anterior and septal leaflet, or posterior and septal leaflet, and they close only the middle of the valve. So we have 3 openings, so to say, in the valve, and we try to minimize the reduction. The most used, of course, position is the anterior septal position. After that comes the posterior septal position, and as I say, at the end, the posterior anterior. Only in very rare cases and only in combination with other clips in the other commissures. Of course, the choice of the device plays an important role, and I don't want to speak between the 2 different categories of devices, the Pascal and the clip, but to analyze a little bit and to understand the importance of the different parameters of these devices. So we have the small devices with 9mm arms, both companies, and we have the large devices with 12mm or 10mm arms. Makes that a difference? Yes, of course, that makes a difference. The tension on the leaflets is bigger. And this is really important before we choose the device. Not only the length is important, the length of, especially of the posterior leaflet, of the septal leaflet, but also the quality of the tissue is very important. That means if we have a very teeny, very small leaflet, septal leaflet, please don't use the big devices. Also, if you have enough length. Why that? Because you have a lot of tension, and we saw cases that perfect, but after the implantation, after the releasing, we have the septal leaflet broke because of the tension. We have a scar over there, and this is a new gap that we create due to the tension. The bigger the devices, the bigger also the tension is. So if you have not good quality of tissue, choose a smaller device. Also, if you have enough length, because the tension is lower and the risk to damage the leaflet is also lower. Of course, the bigger the device is, it's much easier to solve the problem. That's why the tension at the moment is to use the bigger devices, especially here in the analysis of the clips. So the most groups and the most interventionalists, they use the XT and the XTW devivices with good results, as we see from the analysis. And I want just to mention that before we start, we have, especially with the therapy of the tricuspid, we have to know that we will use most common 2 devices, 2 different clips or 2 different Pascals. That shows also the Triluminate study. So they have an average use of 2.2 clips, and the Bright analysis, they saw also that in an average of 1.9, that was almost 2 clips in every case they needed to use to achieve good results. So to sum up, before you start, and I don't want, as I say, to analyze again the implantation technique, because it's the same with the mitral valve, but the strategy is different in comparison to the mitral valve. We need to take care about the 10th ring of the leaflets. If we have large gaps, we have to avoid maybe this therapy and go to orthotopic or heterotopic valve implantation. And if we have a large annulus diameter, we have to take into account the tension we use on the leaflets with result that we can lead to a break of that leaflets after the implantation. So if we have such parameters in the pre-screening, maybe we have to consider that we are too late with the edge-to-edge therapy and to change that in another therapy, especially in the new area with the valve implantation. Thank you very much for your attention.
Thank you very much. That was an excellent overview with tips and tricks. I think we're running behind, so we're going to move on to the next talk. Dr. Spargios is going to talk to us about replacement. Having seen all this data about TEER and the limitations, as well as the advantages, let's see if replacement, which is now a reality in tricuspid, has more to offer. Kostas?
Good morning. Nice to see you all here. Thank you for the invitation. And after Zis's presentation about clipping in the tricuspid valve, my talk has to do about replacement, transcatheter valve replacement. Practically after TAVI, that paved the way for transcatheter structural interventions, this is the first valve that becomes commercially available for use, the tricuspid valve, and not the mitral valve that probably a lot of us were waiting for a long time. Hopefully we'll have something good in the mitral also soon. Disclosures. So this is the first commercially available valve, the VOC valve, that it comes in 3 sizes. As you can see, there are 9 anchors, and this is the anchoring mechanism. It's based on both the leaflets and on the annulus. It's a self-expanding nitinol with pericardial leaflets, and you can see the design of the valve. And the procedural steps here, access, the valve is within a capsule, and then you retract the sheath. There are actually 2 sheaths inside, and gradually you release first the hooks, and then you deploy the valve. So what is the science behind it? The TRISCEND 2 trial that we've seen recently, and the approval, the CE mark approval, and the FDA approval was based on this data. From the first 150 patients in this trial, randomized trial between optimal medical therapy and EVOQUE. So from the 6 months outcomes, we see, first of all, the baseline characteristics of the patients. These are not young patients, they're elderly patients, mostly female. A high risk score for surgery, as you can see, 10% STS score. And almost all of them have atrial fibrillation, or almost 100%. And 1/3 of them had a pacemaker already inside. The main etiology of the tricuspid regurgitation was functional, as you can see, and small percentages of other etiologies. And all of the patients had significant tricuspid regurgitation, but more than half of them were in the massive and torrential grade. And here are the results. So initially, patients were in TR grade, massive or torrential, the majority of them. And as you can see, after EVOQUE, the majority of them were in mild or non-tricuspid regurgitation. So the valve eliminates the tricuspid regurgitation. It doesn't produce the results we've seen earlier by Zis. It's like 70% success to have mild or moderate or 50% success. We're talking about 98% success. And of course, much better than any optimal medical therapy. And then, of course, as expected, the symptoms were improved in a similar fashions in these patients, and the win ratio when you do the analysis on these first 150 patients, similar to the TRILUMINA study, statistical analysis was significantly better, and the results much better than they expected for this type of population. And these are most recent data from all the patients, or the majority of the patients. So you see the numbers go close to 400 patients, not all of them included in the follow-up yet, because the follow-up is still ongoing. And again, we see for all the outcomes that matter the same, better, the valve fares better than optimal medical therapy. And just to have an idea what to expect after implantation of the Evoque, so we had 3% mortality. As I mentioned, these patients were really high-risk patients. And then we had 10% severe bleeding, large venous access, but you should respect the venous aspect. It's not arterial, but it's still, you can still have a lot of bleeding events if you are not careful. And as you can also see, about 10 to 15% new pacemaker implantation after implanting the Evoque valves. So the Evoque valve needs a 28 French delivery system, as you can see, for the vein. And there are some specific qualifications that all come from the CT scan screening. So we need to have a perimeter that falls within these margins, 115, 160. And this for the 3 sizes we have available now, because a new size, the 56, will become available hopefully later this year probably, and then more patients will be good for this therapy. And as you would expect, the main reason for exclusion for screening failures in this study was large annulus. So that's why we expect the new valve size to reduce this rejection rate. So in our experience, this rejection rate is approximately 70 to 80%, which is much better than the Mitral study's rejection rate, which is vice versa, the opposite. So I think instead of talking a lot, I'll present you one case, and we'll understand together how and when we use this valve today. So this is a young lady below 60 years old with a history of dilated cardiomyopathy, myositis related, on immunosuppressive therapy, symptomatic for many years, and we did like 6 years ago, because of severe functional mitral regurgitation, M-tier, we're using 2 Pascal devices with a very good result, and she improved symptomatically for some time. Of course, as you would expect, she has CRT-D, COAD, hypothyroidism, paroxysmal mitral fibrillation, some severe degree of pulmonary hypertension from the heart catheterization. You see all the medications. She was taking all the medication you would expect a patient like her to be on. And here, labs with an elevated BNP. So she became symptomatic like the last 2-3 years. And we were in contact and waiting for some treatment for her tricuspid regurgitation that was moderate like 6-7 years ago, but was progressing gradually to severe. So this is her chest X-ray with all the hardware you would expect to see, the CRT-D and the 2 Pascal devices. This is the image, the transthoracic image of her tricuspid regurgitation. You can see the defibrillator lead there somewhere, so you wonder if this plays a role in the etiology. And you can see the vena contracta, as Zisi said earlier, very wide, and also includes the defibrillator lead inside. So this increases the suspicion that the defibrillator lead is at least related or also participates in the etiology. This is a transgastric view where indeed you see the defibrillator lead impinging on the septal leaflet, on the posterior part of the septal leaflet here. So even if you go with clips, you'll have to use multiple clips, and it will be impossible to take this part that is very close to the lead. That's why we're not proceeding with TEER all these years, and we're expecting the valve to become available for this lady, because she's a young lady. We didn't want just to reduce the tricuspid regurgitation, we wanted to eliminate. So you see the torrential nature of the regurgitation, arrow 1.3 here. Coronary is normal, as you would expect, dilated cardiomyopathy. So there was a discussion why to do the TVR, because we had the lead involvement, because tricuspid dilatation of the annulus was severe because it was torrential regurgitation. And then we had some worries about this patient, some concerns. First of all, we need to clarify that the lead is not the old bipolar type that has been known to interact sometimes with the anchors of the evoke. We checked and it wasn't that type of lead. These leads are rarely used today. And also that the right ventricular function was also impaired moderately, at least I would say, similarly to the impairment of the left ventricular function. So here you see an animation from the CT scan. You see the movement of the defibrillator lead. There is some redundancy of the lead, which is a good thing for the treatment we're planning to proceed. And this patient fall well within the range of the evoke. So this is the implantation of the large evoke, the 52 millimeter. This is from another patient, just to show you how we start the procedure, because we didn't record this part from this patient. So first of all, we go, it's very simple, you go with an Agilis catheter and you have to direct and advance a Safari, extra small Safari, through the tricuspid valve without using any pigtails or any swan catheters, because this way you know that all the curve, it goes through the valve and it doesn't go through chordae. This is a very important part at the beginning of the procedure. I would say the only important part for us interventional cardiologists. And then it's very easy to advance the capsule of the valve there with all the knobs that you have, and you can provide primary and secondary flex on the capsule. And once you are there, the procedure for the interventional cardiology is finished. Everything from now on has to do with micromaneuvering and with echo imaging. So echo imaging is the most important. So at the beginning, you have to go and be really coaxial to all planes of the valve. So the anterior, posterior here, you have to be coaxial, vertical. The septal lateral, you have to be coaxial, vertical. And the transgastric level, you have to be also in the center, the location, as you can see here. Once you achieve this position with the capsule, everything then becomes very easy from now on, again, for the interventional cardiologist, not for the echocardiographer. And so this is how we proceed. We start to exposing the anchors by pulling the sheath of the capsule, and then what we see at 45 degrees here on echocardiography, we use multiplanar reconstruction, as you can observe, for this procedure, 100%. And then we have to see the leaflets in relation to the anchors. We're using the anterior-posterior projection here, and then we rotate the calibers for each anchor to see exactly what is happening here with the leaflet. So we want the leaflet here to be engaged or ready for engaged or moving freely in and out of the anchor. We don't want to see the leaflet to be pinned outside of the anchor, because if it's pinned, when you release the valve, it's not going to be held there by something. So this is how we proceed. This is 90 degrees now, the anchor is exposed here, as you can see. And then here, you see you have flipping of the anchors, as we call it. So the anchors come completely back, and in this position is the most important to check again on MPR that we have the correct position and movement of the leaflet on each anchor. So we do this dialing around, all the rotation around for every anchor to check that the leaflet is engaged and is not pinned outside. So for every step of the procedure, we repeat this again and again. It's monotonous, but very, very important if you want to deploy the valve correctly. So here we have the ventricular expansion. So you see the ventricular part is now almost completely open. And then this is the full ventricular expansion. And at these states is the last point where you can change the orientation of the device in case there are some small deviations from the right planes, but normally you shouldn't have to do that because you are in the correct position for the beginning. And again, you check for the last time the leaflets that in the correct position, and then release is really simple. So this is how the valve moves. It moves with the annulus, and you can see that the lead is compressed, but because there was this redundancy, there is no problem, so it's not pulled back. And this is the immediate result after release. This is how the valve appears in transesophageal, and as you can see, there is zero leakage from this patient, and this is the clear view of the transesophageal, where you can see the valve sitting in the position you would expect it to sit with this excellent result. And the in-hospital outcome was unremarkable, no problems, and the patients were discharged on day 3, improved significantly after this. We're more than 3 months now after the procedure, and she's doing well. And this is the follow-up about 1.5 months after the procedure, transthoracic echocardiography. As you can see, the valve is in the expected position. There is no difference from the initial result. And if I have time, very, very quickly, I'll show you this in 3 slides. This is another patient with a lot of previous procedure, 89 year. He had a TAVI. He had also M-tier with Pascal in the previous years, but he also has severe TR. So he comes back. This is the TR, also symptomatic for some years. We were waiting for the valve also for him because we knew that we couldn't achieve an acceptable, good result with TR. So fluoroscopically, again, as you would expect, you can see the sapien, you can see the Pascal, and then here it comes, the 90 degrees of the hooks, full ventricular expansion and release of the valve, and this is the immediate result, again, in this patient, a very good result with no paravalvular leak and very good function of the valve. So this is the follow-up. By closing my presentation, I would like to this is my way of thinking, because a lot of you will come with this question, when to select TIR, when to select valve for the tricuspid regurgitation. So I think when you have major coaptation gaps, more than 5, 6, then the result is guaranteed with a valve, so you go with a VOC. If you have a lead involvement, like in the first case, again, I think you go with a VOC. You have bicommissural TR, where you have to put multiple devices, multiple clips in both the anteroseptal and posteroseptal. We know that the results are not good then. Again, I prefer the valve. When you have all these features of torrential tricuspid regurgitation with enlargement of the atrium, enlargement of the annulus, very wide vena contractors, again, you don't want to go with a clip and like 50% success rate. You go with a valve with a 100% success rate. On the other hand, if you have severe right ventricular impairment, these patients, theoretically, but also practically, especially after surgery when they replace the valve, they have a higher possibility to go into a low output state. So probably for this patient, similarly with a patient with severe pulmonary hypertension, I will probably go with TIR if I can achieve acceptable results. And the rare patient that anticoagulation therapy is strictly contraindicated, I would also go with TIR. Finally, we come to the patients that are younger or they have large prolonged life expectancy. This is the most difficult discussion, I believe, because for these patients, if you go with TIR, you don't implant a big device, a large foreign body, but you have likely 70% only possibility to have a good result. And when I say a good result, this includes moderate tricuspid regurgitations. If you go just for mild or zero, probably this will be like 30%. So do you accept to go for a procedure that will give you these results that are not the best, a young patient? On the other hand, if you go with this procedure, then you exclude this patient for EVOQUE in the future. So you are done, you're finished. Now, in the younger patient, if you go for a valve, you will eliminate the tricuspid regurgitation. You will implant a larger foreign body. We don't know exactly now the antithrombotic regimen for these valves, and we don't know the durability of the valves. But we do know that we can do a valve-in-valve in EVOQUE. It has already been done in the US in rescue cases, and it can work. So yes, you can do valve-in-valve in EVOQUE. And with these thoughts of mine, I would like to thank you for your attention, and thank you.
Great. I know that this was a terrific 2 talks on the repair and the replacement, and welcome to the new world of tricuspid valve disease and forward cardiac output heart failure, a very difficult concept. If you want to talk only about tricuspid disease, right heart failure in relation to that, you're talking about exhaustion with clear lungs. Welcome. You have to rule out lung disease. You have to work with a hepatologist to see how much the liver is involved. Often you may have to end up rule out other factors of cirrhosis, including perhaps a liver biopsy, and a lot of things that you don't intuitively talk about in the classic heart team. So we have more members now in the heart team. All of these people who never really wanted to receive a call from us, all of a sudden they say, okay, examine this patient and let us know from a liver point of view, is the liver going to come back or not? I'm not sure they welcome this call, but they are now members of our heart team, and we've got to figure out in our environment who are going to be these people who are going to be helping us with some interest in this. And of course, then you also have right side failure in relation to left heart failure. We saw some of the people, Kostas gave us already had the Pascal clips or mitral clips, this, that. So again, how much is left, how much is right? If we overcorrect the right, then we have too much volume going towards the left, then the 1 plus MR we left, maybe who knows, maybe it comes now 2 plus MR later, because we overcorrecting the right. A lot of things and a lot of, I think, combinations. Is it the clinical criterion that's going to help us? Is it the imaging that's going to help us? I don't know, maybe we can get some opinions from the panel and Dr. Xavi maybe, and then we're coming up with the imaging and a case right after that.
So definitely the tricuspid, the era is on the way. And of course, there's a lot of questions. For example, who should be in the heart team? And I think that in tricuspid cases, I think that electrophysiology should be also part of it. What is the fate of this pacemaker? What will happen if this pacemaker will get infected? What will happen to the valve? Do you get immediately also endocarditis on a tricuspid valve? Because we have the EVOQUE let us get excellent hemodynamic features, but still, as you said, it's a big valve. It is situated with pacemaker before and after. If you need to upgrade the pacemaker, if you need to change it, if it gets infected, if you need to take it out, those are questions that we don't really have a good answer at the time. And as you said, also, who should decide when to do the procedure? If the patient is already cirrhotic, should we do the procedure? Should we get the input of a hepatologist? I think that in generally we should try to do the procedure before the need of hepatologist view. Because when the patients become cirrhotic and they have this edema and ascites, most of the times the procedure is unfortunately maybe palliative, but not really change the course of the disease. So many questions need to be answered in order to really get the best treatment for our patients.
You are both spot on. While in aortic stenosis or even the mitral regurgitation, clinically we don't have a lot of questions or dark points. We know this is aortic stenosis, these are the symptoms, we treat the aortic stenosis and the patient becomes better. I think in the tricuspid patient is the most complex, perplexed patient, and we need to do a very good workup before we decide to intervene. Things are not always as clear and as you believe. You're both right.
And also, if I can make a quick comment, we have this philosophical question now in this brave new world of tricuspid interventions that we're blessed with many therapies. That on one hand, we have a very simple, very safe, simple is not, but very safe therapy, which is TEER, in a narrow selected population with a potential for residual TR, but safe. And on the other hand, we have the potential for elimination with a procedure that doesn't look that difficult. I don't have the experience, but you know, any experienced operator should be able to learn it, with elimination of tricuspid regurgitation, but with quite significant complication rate. I mean, this 27% is really striking. You have 10% bleeding, you have 14% pacemaker, and where do you put the lead? It's not just having the infection. You really shouldn't put the lead inside the evoke. You should put it in the coronary sinus vein, or you should put a micro leadless pacemaker, but that involves putting a 27 French sheath inside the evoke. So these are also lifetime management consideration that Kostas actually presented. So I think we have to put everything into perspective and make a very, very careful decision about how to manage these patients.
Another minor issue, we always talk about the coaptation gap and stuff. It's important to know that those features are often very dynamic. For example, if you have a patient with a very large annulus and coaptation gap, you can treat him for a few days, 3 days, with diuretic, and you get better results. You go to the procedure in a better situation. So I think that in many cases, it is treatable before in order to get a good result in the procedure. Because if you start with very torrential in a TEER, you won't get a 0 TR, definitely. But if you treat the patient before and optimize his medical therapy and maybe give him a few days before, and you get to the procedure in moderate to severe or severe TR, your results will be much, much better.
Great, thank you, Costa. Let's move on. Invite Dr. Ignos to talk to us about the imaging now. Right after, we're going to also show a live case, live in a box, I should say.
Thank you very much for the invitation. Thank you very much for the invitation. My topic is about imaging for tricuspid interventions. Is for the eyes ready for prime time? We gain more and more evidence about the possibility of reducing tricuspid valve regurgitation using our interventions. But we know that imaging can be tricky. And if we have a good and optimal imaging quality, then I'm afraid that the answer to the question if 3D eyes can replace TOE is negative. But the optimal quality of the imaging is not always the case. And we have cases with horizontal heart, with shadowing due to left-sided prosthesis and pacemaker leads or interatrial septum. And we know that tricuspid valve leaflets are much more thinner than the mitral leaflets. They have a greater anatomic variability. Tricuspid valve is far away from the esophagus, and we cannot really gain an fast view of the tricuspid valve. And talking about imaging modalities in the tricuspid valve interventions, so far, nowadays, vast majority of the interventions are done with fluoroscopy and 3D TEE, and only in cases of suboptimal imaging quality in some patients, then alternative imaging modalities come to the game like 3D TTE and the new player in the game, the 4D eyes. And that's how eyes evolves in the years, starting in 2000 with 2D eyes, the first introduction of eyes, and then 2007, the 3D eyes, until a couple years ago with the introduction of the modern 4D eyes systems. And we can use eyes to close an ASD or a PFO or a LAA, or even a PVL, perform a TAVI, or repair in the tricuspid or mitral valve. And we know that eyes improves safety, provides greater confidence in procedural success, and increases access to interventions in patients with contraindications to TOE. And both TE and eyes have strengths and limitations, but we know that eyes can contribute to avoid intubations, to reduce the cost, reduce the procedural time, and enable faster or even same-day discharge. We have 3 eyes platforms, 3D eyes platforms commercially available: Siemens with IQNAV Volume, Biosense Webster, New Vision, and Philips with VeriSight Pro. Each one has pro and contras, but in any cases we see we can gain very nice images with the 4D eyes catheter, our devices, and the tricuspid valve. And the last brand new paper about structural heart imaging using 3D eyes in JACC describes the way to reach the tricuspid valve. We have to go through the inferior vena cava, reach the right atrium, flex our eyes catheter towards the tricuspid valve, and then use the biplane modality and the real-time MPR, and of course combine it to the TOE, who preferable should be put in the stomach and have the transgastric views. And another field to use the 4D eyes is the annuloplasty of the tricuspid valve with cardioband. It increases the safety and reduces the time of the intervention. With 4D eyes, we can have fantastic images, 3D images from the atrial and the ventricular side. And another point to discuss is how is the ideal workflow with eyes. The imager should stay on the top of the patient near his echo machine after parking the eyes catheter, he can manipulate the catheter digitally. Alternatively, he can stay on the table next to the implanter so that he can optimize the probe, but he needs a second person for the TOE imaging. There are a lot of challenges for the 3D eyes. The main of them are the cost of the catheters and the software, the inferior imaging quality, the movement of the eyes probe through the procedure, and the greater learning curve. The interventionalists have to learn the standardized projections of eyes, the new protocols of eyes, the 3D advanced imaging principles and interpretation, and of course, he has to build an improved relation to the echo guy. But eyes can provide more consistent imaging because it is not dependent on esophageal position. Tricuspid valve anatomy can be more variable, and 3D eyes is an excellent alternative echo technique to TOE, and 4D eyes allows for the ability to park and image. We need more evidence required for establishing safety, feasibility, and impact on patient outcomes. We need standardized clinical imaging protocols We need guidance on training requirements and prospective data. In summary, there are 3D eyes options commercially available. There are remain a lot of unanswered questions. How is the ideal workflow? Which is the role of the imaging specialist? What's happening with the reimbursement of the 4D eyes catheter? In which procedures would benefit most from the use of the eyes catheter? And if it's adjunctive to TEE or it came to replace the TEE. Thank you very much.
Well, great idea to have additional imaging, at least that's how we use it at this point. And perhaps in the future with greater resolutions we get replace the TE, but now we use as adjunctive to TE for the tough cases. Let's move on to the live in box so we can see practically how all this imaging works. And, also I hope Dr. Athanasopoulos, Dr. Sparias may have something to say via the microphones, comments in the case, and that would have an interactive discussion. And we move on right on to the next session right after.
So good morning, everybody. It's a great pleasure to present a TEER case in a tricuspid valve. Okay. So this is an 82-year-old female patient with known COPD on inhalers. Patient had 2 hospitalizations within the last year with symptoms of right-sided heart failure, fluid overload requiring IV diuretics, NYHA class 4 by definition, atrial fibrillation, hypertension, previous TIA, diabetes on tablets, and some renal impairment. So for this, the Euroscore 2, if you calculate, is not huge, but it's in the moderate to severe scale, 4.4. But the tri-score is significant, and this is a more specific valve-specific score that we use in order to estimate the risk of having a tricuspid replacement surgically. Echo values, ejection fraction of the left ventricle within normal range or low normal, aortic valve is okay, mitral valve mild MR, and of course tricuspid valve, you will see dilated annulus in complete central coaptation. And also severe pulmonary hypertension. These are the values from the right heart catheterization. You can see that the wedge pressure is 22, so it's not that high, but systolic pulmonary pressure is quite elevated, without a lot of elevation of the pulmonary vascular resistance. Cardiac index is somewhere reduced, but not severely so. And the filling pressures on the right side are elevated with a V wave of 25. That is consistent with severe tricuspid regurgitation. No coronary disease, and pro-BNP quite elevated too. And I just have the transgastric view here because I wanted to focus on the technical stuff. So this is a quadricuspid valve. You can see here that you have, I don't know if that works, but you can see that there's a split anterior leaflet okay, that works. Split anterior leaflet. You can see that there's an anterior portion and a mid portion, a septal leaflet and a posterior leaflet. So, but there is quite significant coaptation, so there's no a huge gap. And we were quite happy that this is a valve that is doable. No leads, no tenting of the leaflets, as you will see on the images. So we attempted a TEER procedure. The quadricuspid might be an issue when it comes to repairing the valve. So this is how we do the procedure, direct femoral access percutaneous, like with most clip procedures, puncture with ultrasound, insertion of a stiff guide wire to the SVC, and then introduction of the steerable guide catheter. You can see removal of the dilator here with some aspiration, and then we will introduce the delivery system. You can see on the top right also the images of the valve. While we're doing all this, of course, the imager has to follow the position of the guide catheter. You can see there that the guide catheter is actually inserted. We need to make sure that it doesn't impinge on sensitive structures such as the atrial septum, because most of the IVC trajectory tends to send the valve, the assembly to the intraatrial septum. So this is now introduction of the tri-clip. XTW, the biggest size. This is 99% of the cases, this is what we use. And we want to just advance it a little bit further, steer away from the septum using the L knob on the guide catheter, and then achieving a straddling position. You can see that on the fluoroscopy here. And the next step will be to flex it down to the tricuspid valve. So we flex it. This is all in real time, so it's pretty fast, using the F function. And then we just want to achieve a position above the region of interest on the echo. So you can see that the clip now is above the tricuspid valve. We can see it on the biplane view, assess the trajectory on the long axis, make sure that we're coming parallel to the long axis of the RV, and also above the area of interest, which is where the collar is. And we should be able to see the collar. Very fast, we open the arms of the clip, and we assess the independent grasping feature. So right now we will drop one of the grippers, and as you saw, this was the septal gripper. So we know that if we want to capture independently, the septal is the one that has the marker on. And this is the region of interest. You can see that the clip is above the collar. So we're in the zone that we're interested to grasp, and now the main thing is to look at our orientation, the perpendicularity. The way to do that is get the clip above the leaflets and then go to the transgastric view that you saw before. So our aim was to get a clip in the anterior part of the valve and then move to more centrally to the second scallop of the anterior leaflet. We were happy that the orientation was okay. Then we close the clip, we move into the ventricle with the clip closed. So this is, we close the clip and we move in. We just want to make sure that we don't go too deep because there are dense cords. Tricuspid valve has got lots of cords, so we don't want to get caught in the cords because that can create some issues there. We're happy now, we're moving in, and then just below the leaflets, we will open the clip and we will try to come up again to confirm the leaflet insertion. We can fix our orientation on fluoroscopy. So on fluoro, we see that the leaflet, the discs, the arms of the clip are not seen as open, they're seen as a single line, but we confirm the orientation on the transgastric view, so we can see that we're perpendicular to the line of coaptation of the anterior and the septal leaflet in the anterior part of the valve. So once we're happy with the orientation, then this is leaflet grasping. We try to go for simultaneous grasping, so you can see on the top right that both the anterior and the septal leaflets are nicely flat on top of the arms of the clip. And if we're happy with they're relatively mobile, we will drop the grippers in a minute. Then we'll close the clip, we will lock. We'll just push down the handle, and this is the first grasping on first attempt. We try to do as little attempts as possible because there is always the potential of pulling the leaflets and creating some damage. Tricuspid leaflets are thinner than mitral leaflets, so we don't want to mess around with it. And then transgastric is always very important to ensure that the leaflets are nicely inserted inside the clip. So you can see now both the septal and the anterior leaflets there are actually curving inside the clip. And we always assess the leaflet insertion. So we have recorded all this, and we look at the leaflets, how they get in. So the interventional cardiologists have to be really patient. You can see I've got my arms crossed there. I'm waiting for Elias to do all this job. If you rush him, it's a recipe for disaster. Sometimes we've done this in the past, and you know, I think we have to commend all the imagers that are actually doing this job to be patient with the interventional cardiologist, but really the story of success depends on the accurate imaging, ensure that enough leaflet tissue has gone in, that while closing the clip, no leaflet has escaped. And once we're happy with all this assessment, then we're good to go and release the clip. I will remind everyone with a triluminate initial experience, the single leaflet detachment was up to 7%. Of course, BRI that had more advanced operators and more use of XTW, this went down to 3.5%. We tried to eliminate that as much as possible. So this is now deployment of the first clip. You can see now, we just released it and we took it out. and the clip is still in position. We always look on fluoroscopy if it's stable, and also on echo. And you can see that there, in the posterior part of the valve, there is a residual jet that comes from the central part of the tricuspid valve, the second leaflet. And this is something that we will confirm in a minute on the transgastric view. So second clip is inserted. This will be put more posterior to the original clip. So that means on the fluoro, it will come just below it. So we have the fluoro position of the first clip, so all we have to do is just by looking at the echo, follow the same steps, go for straddling, flex down to the valve, having the first clip as a marker, so that usually doesn't take too long. It takes a few seconds to go down. You will see that in real time here. So this is second clip going in, and always looking at it on echo, and then it will flex down in a minute. I can accelerate it a little bit more. So we pretty much follow the same steps. So you see second clip now is above the region of interest. And in a minute, we will open the clip like before. Septal arm is still independent grasping as before. And then we assess it on the transgastric. This is really critical. So what we want is to be in the region of interest, so the posterior scallop of the anterior leaflet, but we want to rotate it a little bit clockwise so that we're perpendicular to the line of coaptation. So if you look, the second clip is a little bit rotated with respect to the first one. First is single line. On the same view, this is a little bit rotated. So it's very interesting to have these fluoro-echo correlations. So you see now we're rotating clockwise, and we achieve a perpendicular position in this central aspect of the valve. And once we achieve that, then we are good to go in the valve as before. So we see we close the clip, we go inside the ventricle, just below the leaflets, and now we leave the leaflets to go in. There was a little bit more distance here, so we selected to first grasp the anterior leaflet, the lateral, which is the anterior leaflet, you will see in a minute. We'll just rotate, swing a little bit lateral here. The anterior leaflet is going in. Once we're happy that it's flat and relatively mobile, we drop the gripper right now, and then we can rotate clockwise to the septal part of the valve. So see, and now septal leaflet is coming in. So imaging has to be very precise, very stable, no rush. So septal now is in, and we're just closing the leaflet, the clip. Just make sure we don't have tension. So independent grasping on this central position, but you can see the contrast now on the right atrium here, which is a good sign. That means that the backflow has been eliminated, and voila, practically elimination of the tricuspid regurgitation, which is good. Again, we follow the same laborious process of ensuring that we have the leaflets correct, that enough leaflet has been inserted. And you will see here on the transgastric view that we want to make sure that the leaflets are curving in on the central clip, on the posterior clip. So you can see both the lateral, the anterior leaflet, as well as the septal leaflet are going in. So this is something that we have to do. And once we're happy with all these checks, we also look at the recordings. Here is the final leaflet position. Then we're happy and we release the clip. So clip is released now. And as you can see on the fluoro, the clips are stable. They're moving pretty much together. No rotations, no rocking motions, very important. And also on the transgastric views, we see the same position, the same curving in on the leaflet. And this is the immediate outcome after the case. You can see just trivial tricuspid regurgitation, mostly in between the clips from this little cleft at the anterior leaflet. You can see how stable the leaflets are on the anterior clip and the posterior clip. Actually, patient did very well. This is the safety and the efficacy of having a TEER procedure. Patient has been followed up to 15 months now. She's doing quite well. She hasn't been in the hospital, having good quality of life, no more hospitalization. Thank you very much for your attention.
That was like a Evoque-like result. Very good. Isn't that, Costa, Evoque-like result? I don't know if the quadrileaflet valve helped out to have a better result than the average trileaflet valve, because it's a little bit more square and the grasp, I think, better than this trileaflet valve. Is a little tricky, try to grasp together. We may need a little bit different configurations, I would say. This seemed to be a little bit more symmetric. So that was a great demonstration.
Usually quadrileaflets, tricuspid valves are disadvantaged because you've got more clefts and the potential to open them. I think the key here was that we have very good imaging. We have enough leaflet length and elasticity, so we didn't have tenting, we didn't have a massively dilated annulus, big coaptation gaps, but most of it, the imaging was superb.
Did you have eyes? No eyes.
We had the eyes of Elias Nino,
not
so
yet.
not eyes. Not eyes.
You had also a great approach to the ventricle.
Exactly.
Which
trajectory
helped.
was very good.
The
Moni.
trajectory
That's
is
an
perfect.
excellent point.
This is one of the most important parts in this procedure.
Yeah.
If you get rid of the weird trajectory,
The excessive septal hugging is a problem.
Right.
You have to
So-
use a lot of L, and then you're
So I
rotating.
think that
And
before the TriClip, we would do these procedures with the mitral clip device. And whenever you came as a septal hugger, you could not really get in a good position to the ventricle. The TriClip with the S and L knob allow us a better approach to the ventricle and make this procedure much, much more easier.
agree 100%.
Blasi, great job as always. Do we really need the residual tricuspid regurgitation because we have got this sort of right ventricular dysfunction?
I wasn't expecting any more difficult question than that. The answer is I don't know. If we look at the paradigm from the mitral, when we started doing these clips many years back, I mean, Moni Kostas knows all this, we were aiming for a 2+ residual MR. We were happy. Now we've learned the hard way that 2+ is not enough because there's a potential for recurrence. Now, tricuspid regurgitation, we're happy with moderate or less, according to the outcomes of the Triluminate, for example, the BRIDE registry. But having said that, Evoque eliminates it. So, you know, what is the optimal? We don't know. Clinically, patients get better, but what happens midterm, long term? My guess is that we need less than moderate in tricuspid too. But we have to customize it to the individual patient. So if you have a massively dilated RV with an impaired function, it's a problem. Afterload mismatch is a reality, and you cannot do much about it. RV you cannot support. LV you can do lots of stuff, but RV you cannot support. But exactly.
I like the comment of George about Evoque-like result. It's like surgical-like result. Congratulations to the Niños company. Great result. I think I would definitely also go for TIV in this patient.
Yeah.
I didn't see any sign of I would have low possibility to get a good result. Simple question. Do you think the first clip was necessary because it went to an area that there was no color? Do you think you will get the same result by just going in exactly the source that was in the center?
Good question. I don't know, but I always feel insecure with tricuspids of going with one clip, especially when there are multi-lobes. I think you get because patient was sedated. I didn't have access to the original transthoracic echo pictures when the patient was awake. The color jet was a lot wider, so the true nature of the tricuspid regurgitation was underestimated on the patient's sedation. Also, the patient was optimized. So really, we don't see the real picture. When we scanned the patient a couple of months before on acute decompensation, the jet was wide coming from all over the places. So I think that if we hadn't put the anterior clip, we would probably had an area that potentially we would have a residual tricuspid regurgitation. But that's a guess.
Because I moved to that concept lately, I would like to ask Michael, who is there, how he judges our results lately. because in most cases, when I see the pathologist in the center, I directly go with one clip Pascal in the center. So, Michael, how do you see this approach that we're doing lately?
Yeah, we usually start off in the septal anterior area of the valve. It's a classic, but I think more or less in the past few cases we moved on to more directly targeting the center of the regurgitant jet. Also, would like to point out that this is atrial functional TR. So atrial functional seems to be very amenable to edge-to-edge repair. The leaflets are closer together, less coaptation gaps. So it's ideally suited for edge-to-edge repair. Very nice case.
This is a triluminate case. I mean,
right.
Typical.
And it's very important to remember that sometimes the jet that you get in the procedure is different than the screening one, especially in the tricuspid, because there's a lot of variation. And I agree, I prefer to put two, anteroceptor, another one. There's also an impact of, I'm not sure that in this case, but there is also an annuloplasty effect. When you get two clips there, you decrease also the annulus, and I also prefer two clips if available, if needed.
I agree.
So I think that we'll conclude this session, and I am the bad guy that said that there is no break. So we'll go directly to our next session of hot topics in the mitral valve intervention. And Michael, can you join us? And also Dr. Anathopoulos. So we'll
Tips and tricks for mitral transcatheter edge-to-edge repair relating to anatomy and imaging. So,
Is Julia in the workshop?
okay.
So I'll go in then. Okay.
So, we move on to.
you're here.
Oh, no, ladies first.
So, welcome, Julia.
In English? In English, yeah. Yes, I think in English. So thank you so much. It's a great honor to be here. I will try to keep the time. I'm really grateful for one more year to Dr. Yakovo and Onassis Cardiothoracic Center. And practically, it's important, you know, when the imager is hand in hand with the interventionalist when we are dealing with mitral clip. And for us, the imaging, the echocardiography is important in pre-procedural, intra-procedural, and post-procedural. And as we know, the mitral valve is rather complicated. It consists of anterior and posterior leaflet, 3 scallops for each, and it's even the annulus has a different shape when compared to the tricuspid annulus. It's more saddle shape, and actually we know that there is the posteromedial papillary muscle and then the anterolateral that actually has ruled a lot of dynamics on the leaflets and together with the LV. But practically, when we visualize the mitral valve, we use all our senses, and this is because it's important to precise the location of the involved leaflets and scallops, then describe whether there is any calcification and the extent of that, and of course, to detect anatomical changes, and also even for the interventionalist, it's important to identify indentations or whether it's cleft, which is very different. And as you will see, we have a classification of mitral regurgitation depending on the Carpentier classification, like type 1 is coming from the dilate annulus, such as atrial fibrillation, which is quite common now in our patients, or previous endocarditis. Type 2 is usually what we see in Barlow's valve, and then, or if it is, there is a papillary rupture. And type 3A is the rheumatic, and type 3B is also when we started putting the first mitral clips, ischemic heart disease. And then starting from the basics, I will just show for those that they are interested in the basic imaging that we follow 4 different approaches from the TOE. And this is actually, we did a course last week at the Brompton under Professor Lucier, and we were teaching how to image better the mitral valve. And here, for example, you see that we start from 0 to 20 degrees, the mid-esophageal 4-chamber view, and we see different scallops. And then we go to 60 to 80 degrees, which is the commissural view. And here's the trick is to align to make sure that you see the whole extent of the papillary muscles holding the mitral scallops. And then we move to 90 degrees, which is a fundamental view that we usually see the whole extent of the anterior leaflet, and then P3. And then we go to approximately 120 degrees that usually we see P2A2. And here it's also a fundamental view because we may, when, for example, we have P2 prolapse, we see that quite distinctly. And then, of course, we calculate the prolapsing height. This, for those that they're wondering, is a typical Barlow's valve. That's why you see the excess of tissue on the mitral. But also fundamental is, and all our guiding is actually from this 3D surgical view, as we call it. And we, of course, we call it surgical because it's the first thing that the surgeon will see when they go into the valve. And here you see all the scallops and the excess tissue, of course. And we always put the aortic valve at 12 o'clock. Now, it's important, and this is what we have been discussing next door. It's when we have, for example, functional MR, the direct assessment of the vena contracta area depends on the complexity of the jet. And many times the quantification with the regurgitant volume or the PISA can be very difficult, especially if the jet is very eccentric. So it depends. We use semi-quantitative methods, for example, the vena contracta width, as you will see, we always correlate the 2D with the 3D, and then we do multiplanar reconstruction with the 3D vena contracta. And you see we have a threshold on 2D echo more than 8 and more than 40 millimeters with the 3D vena contracta. Of course, other signs such as the pulmonary venous flow systolic reversal. And remember that we may have blunting when we have elevated left atrial pressure or atrial fibrillation. And then, of course, the continuous wave Doppler, whether it's dense. And, of course, the limitation is whether we have eccentric MR. We may have difficulty in getting the complete envelope. And you see that we have clear guidelines on how to quantify severe mitral regurgitation. Now, I want to go a step further, and we know the 4 different fundamental steps for mitral clip deployment, and of course, starting from the transeptal puncture up to the mitral clip deployment. And I will go through quite quickly because imaging is fundamental in all these steps until we reach a successful clip. As you will see here, this is important. We have the green patients that they are anatomically suitable for edge-to-edge repair, and you will see that, for example, mitral valve area is important, more than 10, tenting height, flail gap, flail width. And of course, when we start having especially calcification or a complex mitral valve with multiple jets, or for example, in those patients that they have a deep regurgitant cleft, then we may consider that this is a very complex edge-to-edge repair, so we may consider that this is more suitable for replacement. Then, as you see, we do the pre-procedural TOE, and in order to have an idea about the jet, and we then are responsible to tell the interventionalist, look, this is our impression of the jet, where it's coming, the orientation, and whether it's suitable for a clip. And then an important step to start with is the supervision and guidance of the transeptal puncture. As you will see, we go to the posterior superior aspect of the fossa ovalis, and we need to be ideally more than 4 centimeters above the mitral annulus for the generative MR, and now like 3 to 4 for functional MR. And they are doing, Francesco Maizano is doing a lot of courses, and he has also a course every year at a regular base for transeptal puncture. So it's amazing to see how he uses simulation to get successful transeptal puncture, which is, of course, the first step towards a successful mitral clip. And as you will see, the 3D TOE actually, for us is important in order to visualize the real anatomical aspect of the interatrial septum. And then we measure the distance, and we follow the interventionalists as they cross the interatrial septum, and in order, of course, to avoid any complications and to make sure that there will be enough distance from the mitral valve. So here is an example of transeptal puncture, and you see we follow not only the septum, and here the secret is depending on how you feel more comfortable, we use a lot the X-plane on that side, and we switch between 3D and 2D to make sure that it's safe passing of the guide wire, and of course that there, as I said, no complications. Then we insert the system. So again, we follow through 2D X-plane, and then 3D is very important. And here the multiplanary construction is fundamental, because you will see everything is related to the great understanding of anatomy for us. And we make sure, for example, it's placed centrally, and then we, as you will see here, we have a proper alignment. We always use the aortic valve as the guide to avoid any complications or coming quite close to the LVOT. And we choose first the guiding wire, and of course then the whole mitral clip system to be perpendicular to the mitral coaptation line. And then depending on the leak, we use the clock in order to turn together with the interventionalist the mitral clip device that, of course, my colleagues will discuss later. But you will see that we use a lot the LVOT view and the commissural view, and as I said, it's important, without confusing the interventionalist, then to switch between 3D and MPR to understand the anatomy. Then here you will see how we optimize the leaflets, and then we start after we make sure that the leaflets are opening nicely, because mistakes can happen. Then we start grasping first the one leaflet and then the other. And now this is the deployment of the system, and then if there is any adjustment, then nowadays we have the opportunity to open again the discs and then close again, the grasp again. And then what we are doing is we have to assess the leak, if there is any residual leak or any complications. And here is, for example, one of the very first cases that we published at Jack Case reports about a patient who had 3 clips and then a plug, meaning that, and then this is the final outcome, the initial outcome, and then the final outcome with regurgitation. But we have here to assess the mean gradient. Depending on the age, you don't want to leave the patient with a significant gradient across the valve. Now, as you will see, we have certain guidelines about assessing the residual mitral regurgitation after percutaneous repair or replacement. And of course, we use the vena contracta. Here, the multiplanary construction is very important, because we have to assess, as you know, a jet around the device. So we need to try to assess the vena contracta, if, of course, there is any pulmonary vein signal, if there is reversal. But as Francesco, again, it was very striking what he said last week, is that we have hemodynamic data here that are very important, and we can discuss that further, that practically you have the LA pressure, and you see that it's dropping immediately after the mitral clip. This is the first objective measurement that your mitral clip has worked and there is not enough mitral regurgitation as residual. So that was a summary of the most important imaging tips. And the most important is we act as a heart team. We are imagers, we'll give advice to the interventionalists, then we are guided by the interventionalists inside the cath lab. And it's important to forget that these are complex jets, It's important to use all our senses, oral modalities, MPR, which is important. And you know, there is a rapid evolution of technology. Every month, every day, we have a different paper that gives us another information. So it's important to keep up to date. With that, I would like to thank you so much for your attention, and thank you for the invitation to be here.
Julia, thank you very much for this very beautiful overview. Indeed, the collaboration between the interventional imager and the interventional cardiologist is very, very important for them to be on the same page and have a very good communication. The echocardiographer needs to understand the procedure very well, all the procedural steps, and be able to guide all procedural steps. Do you see any role for ICE in mitral valve interventions in general speaking?
So they started actually mentioning a lot of the ICE. Practically, it's in these cases that it's because it's very expensive. We personally, we do not use it in London because there is no justification of the extreme cost in order to say we need to use ICE. And it's usually in those patients that you will have a very difficult imaging of the leaflets. I'm not sure if you have used that and you have seen the imaging. But it's a very different temporal and spatial resolution when compared to the traditional TOE probe. I saw that on many workshops. It seems that it's promising, but I cannot say from my own experience.
I think I like your mention of multi-planar reconstructions in real time. It seems to be the way to go in the future for mitral interventions, to be able to have both the commissural long-axis views and the 3D image all in the same plane. In the same image, so we're limited sort of with frame rates and spatial resolution, but it seems that more and more people are using it.
And there is always optimization of the TOE probes, like not only, for example, to use ICE, but we optimize our TOE probes more and more to get high temporal resolution and so on.
Thank you.
I couldn't agree more regarding your comment about the hemodynamics, especially in residual MR. I think it is essential for evaluation of your result. I think it's much more important than the color. So if you decrease the LA pressure, and sometimes the LA pressure in the beginning is not very high, so it's not a good sensor, but if you go for the pulmonic vein flow, and you see that you have a significant improvement in the pulmonic vein flow. If you get a good systolic flow, I think this is the most important part of the procedure. We recently published it that the most strongest predictor for outcomes of the procedure is a systolic vein flow pattern after the procedure. So I personally look much more on the hemodynamics rather than the color.
That's true.
Thank you very much for your very elegant and informative lecture. I fully agree with the comments by Dr. Savi. I think we have overestimated all these echo indices of quantification of MR. And I think that we should decide to degrade them. They're useless.
Yes.
Especially during the intervention, there is no reason to try to spend time to measure vena contracta or PISA or anything else apart from the pulmonic veins flow. And another issue which is of paramount importance, according to our experience, is that quite often we have a residual MR after the first clip. A critical decision is what will be the next step? What will be the position of the next clip? It is something which has not been properly commented in practice. Also, in our experience, we have this problem quite often. And there's a critical decision, Mike, I think.
Yes, I agree with you. And that's the reason we tend to rely heavily on optimization of our first device. We try to get the best maximum reduction of MR with our first implant. So we often will reposition and optimize leaflet insertion, which is very critical.
I couldn't agree more about the echo parameters. And when we are in an MDT meeting and someone says, you know, when there is a device in and says, what's the PISA, I immediately say it's not relevant, you know, because it's already known that it's not valid, the PISA or the vena contracta, when you have a device in and you want to assess. Look at the general picture, look at the patient. I was thinking as you were talking, look at the patient, he's telling you the diagnosis. So as long as there is symptomatic relief of the patient and you achieve a reduction in mitral regurgitation, I think that's all that counts, and the LA pressure, that dropping. That's your biggest evidence.
Yes, I believe that we suffer from this overload of literature using this useless data, and especially taking into account that there is a lot of dynamic changes on the mitral apparatus in the performance of the mitral valve, especially on the functional issue. We have faced the scenario of having a fully studied person with functional MR, and post the anesthesia, there is no MR.
Mm-hmm.
So you see, there is a lot of functional things, also in organic MR, quite often with additional functional component.
Perfect. Thank you so much.
Thank you, Julia.
Next, he will present patient selection for mitral valve intervention.
So, who are the ideal patients for TEER? Because I'll limit it to TEER since this is a TEER session, and then we have a TMVR session. And it is TEER mostly because we have coronary sinus annuloplasty, direct annuloplasty, and coronary replacement, but really the majority of the interventions when it comes to transcatheter repair is TEER, right? And we have the mitral clip that is now 21 years out, and we have the Pascal. And initially, this was our data, the Everest trial. So we wanted to meet the Everest criteria. But the Everest criteria are no longer contemporary. We almost never look at it. But before we go into the technical aspects, let's see about which patients benefit from that. And the only really positive trial that we have, massively positive, of course, is the COAP trial that at 5 years it shows consistent benefit in this population of functional mitral regurgitation, poor LVs, and you know, it is quite consistent in terms of death or hospitalization. Of course, quite a few people died after 5 years, but these were patients with severe MR and severe heart failure. But it has been incorporated in the guidelines. The recommendation now is higher compared to surgery, isolated mitral surgery. Mitral surgery has never showed any benefit in this population. So I think when it comes to patient selection in terms of clinical criteria, an ejection fraction between 20 and 50%, and systolic diameter less than 70, and systolic pulmonary pressure less than 70 millimeters of mercury, these are the patients that will benefit from TEER. And they are highly recommended, both in the US and European guidelines, exactly the same. And we can be quite happy and proud that we completed the Reshape HF2 trial. I'm looking at the EA colleagues and friends. It will be presented in ESC, and hopefully it will be published simultaneously at the same time. So we've been there. We did a lot of work for this trial. Let's hear it out. It's a different population, though. Less MR, a little bit slightly bigger LVs. So it will be quite interesting to see what this trial will show in terms of patient selection. But it works. I mean, this is a patient 11 years later with dilated cardiomyopathy that survived to take additional heart failure medication. So when we did this procedure, there was no ARNIs, there were no SGLT2. Now the patient is alive and had the benefit of these therapies, and he's still doing well. And this is the residual MR after 11 years. And we have, of course, bigger sizes, and that has enabled us to extend to expand the criteria. This is the EXPAND G4 study that shows now that if you put the bar to 1+ or less residual MR, you're actually doing quite well. In the functional cases, you get up to 95% at 1 year. In the degenerative cases, almost 90%, a bit less. But if you go to the more difficult cases, that proportion goes a little bit down. You can see what we mean difficult cases. So when you're looking at lateral or medial jet, more than one jet, slightly smaller valves, some calcium. Calcium is an enemy of TEER most of the times. If you have a coaptation length that is less than 2 millimeters in the functional cases, or if you have big widths and big gaps, that was the initial exclusion with Everest, but we're doing it. Of course, with lower chances of success. Still quite high success rate, but we're doing it. And if you compare, if you put this into perspective, COAP trial gave you 1+ or less residual MR 67% and was still positive, very positive. Expand G4 now gives you this proportionate above 90% most of the cases, with safety. Safety is very, very important. And of course, all-cause mortality in this Expand G4 population has been lower than the COAP population. Of course, it has been a different population. And we have more devices. Pascal is here and is working and is being used for some time. We have Dragonfly coming from China, Gemini 1 maybe. So more tier devices will come into the market with additional features. Some of them will be useful, some of them will not be useful, but we'll have to see. So where are we now in terms of selection criteria? We have the straightforward green patients, we have the prohibitive red patients, and we have the in-between patients. And the green patients are the central pathologies with mitral area more than 4 square centimeters, with minimal calcification, and with enough fabric to grasp. So posterior leaflet length of more than 10, tending height less than 10. These are the traditional Everest criteria, and you can see what I'm talking about. These are the patients that you expect to get 1+ or less in more than a residual MR in more than 95% of the cases, in less than 5% of the cases to have more than 1+ MR. And we have the yellow patients, so commissural jet, multiple jets, a little smaller valves on the other hand, shorter leaflets, posterior leaflets, tending height more, width more in terms of prolapse. These are the yellow zones that we have variable results, depending on the expertise of the center, depending on the individual parameters. And of course, we have the red light. The red light is, Carpentier 3A, so patients with rheumatic components or MAC, with the mitral area less than 3.5, with a lot of calcium, especially in the grasping zone, and inadequate posterior left. We still do some of these cases because we cannot do anything else for these patients. Surgery is prohibitive. TMVR is still investigational, so you have to do something about these patients, but you're set up for potential complications. I mean, I wouldn't dare to do, for example, the patient on the top left corner. I think whatever device you put in, it's quite likely you will end up with stenosis. And we do see that whenever we extend our grasp into yellow or red zones, our success rate goes down. You can see that here in the complex versus non-complex, the acute procedural success was significantly less, still high enough, but significantly less, and also the potential for residual MR. And that the same went to be seen in the Pascal 2D results recently, that although Pascal achieved very good results in terms of MR reduction in the main cohort, in the difficult cohort, the results were not as good. So we've come a long way achieving incredible results with MTR, and MitraClip has been a game changer generally, pushing the boundaries of the therapy. However, the more complex the anatomy, the less successful the results. That's 100% sure. And right now, the complex anatomy are being attempted due to the lack of alternative transcatheter therapies. And hopefully, this is the time for TMVR to step in and cover this unmet clinical need. Thank you very much for your attention.
Vlasis, congratulations, a beautiful presentation and overview. I just would like to comment about the patients on the right side of the spectrum of eligibility. We occasionally will try to help them with edge-to-edge, but we need to understand the limits of this therapy, and it's not for everyone. It's one tool, we try to apply it, but it's not for everybody, so we're really looking forward to valve replacement therapies that are coming up in the near future. So.
That's absolutely true, and one thing we always have to remember is if you put a device in there, then your future options are limited because you cannot replace the valve if you have a device. If the surgeons intervene, they cannot repair the valve in case that the valve should have been repaired because usually you have enough tissue that they cannot repair. So it's a lifetime management consideration, especially as we move on to younger populations.
So thank you once again for your excellent contribution, Vlasis. A practical question, especially with the scenario of functional MR. How would you judge ideally, the importance of functional regurgitation, would you be based upon echo criteria alone, or would you proceed with a right cath?
ECHO is very important in terms of technical eligibility and clinical eligibility. You've seen the guidelines is the mainstay of patient selection. I always do right heart cath in my patients because it gives you an idea of the physiology. Sometimes you get surprised. You find discrepancies in the pulmonary hypertension, for example. Sometimes with the echo you overestimate, and you get a better idea of the patient when you do right heart cath. On the other hand, you also have the opportunity to evaluate the cardiac output, the cardiac index, and you know that you can draw a line in terms of futility in some of these cases, for example. And it's a heart team decision, so I think the heart team has to take all these parameters into consideration: clinical parameters, heart failure perspectives, echo parameters, as well as hemodynamic parameters.
I make this point because quite often, especially in functional MR, during the intervention, we are skeptical about the outcome of the intervention itself. Once we had the previous hemodynamic data, it would be much more easy to compare the effect of our intervention just on time.
Agree.
Glasis, congratulations for your excellent talk. You are a connoisseur of method and of the methods for relieving the mitral regurgitation. And I would be more practical and ask what knowledge should we disseminate to the private doctors or the secondary hospitals or the tertiary hospitals that do not have the facilities for the TR therapies. What are the simple methods that we have to disseminate to them for patient referral?
I think once you see significant mitral regurgitation of any etiology, investigate further. Let's start with that. So don't sit on it, say, okay, we can use some diuretics, especially in the functional cohort. Medical therapy and CRT therapy is the mainstay of treatment. It should be optimized before getting into leaflet therapy or any other device therapy. However, if you sit too long on that, the patient may miss the boat, and then it might be too late to do anything. So have a low threshold of referring the patient to a center with expertise for further assessment, and then have an open communication. I think that's the key in my opinion.
So there's need for networks.
Absolutely. Heart failure is network, and
heart failure is a network, but
management.
we need networking for that. Even we rely on private sector sometimes. The two most profound centers for this are private in our country, but we should overcome hurdles of health system, our health system, and disseminate the knowledge and disseminate the therapy and to more recipients.
I agree.
Okay, we have concluded the session. I have to thank Diagrams and Niños, and there is a live case. The session concerning the lectures.
Okay.
Okay. So on the next step,
I have another lecture later.
Oh, I'm sorry. So it was not properly.
Before?
Yeah. Okay. Yeah. I think it's better to do your lecture before.
Whatever you want.
Okay.
Sure.
Yeah.
Okay. Okay, so let's see. Okay. So, okay, good afternoon. Thank you very much for the invitation. And I will speak today about MR in patients with yellow, red zone, and even with new indications. So let's start. I will present several cases and try to explain some learning point of each case. So we know that the conventional TEER indications include patients with functional MR, mostly the co-opt eligible patient, and also patients with degenerative disease. We have the most valid data on those two populations. We know that the procedure is safe and effective in improving the quality of life and even improving the longevity of patients with functional LMR, which are co-opt eligible. However, that we know that TEER has many additional advantages that suggest that maybe other populations may benefit also from TEER. We know that the procedure is minimally invasive, doesn't require any surgical approach. It is considered very safe, and the most important part that we often get immediate hemodynamic improvement. And those three advantages of TEER make it a very a procedure that should be considered in many patients in order to overcome decompensation or even to allow them better quality of life. So this classification was presented before. We know that the ideal patient of TEER are those that are the non-complex patients with enough with central pathology, with long leaflets, without any flail gaps. However, we see that in the course of last year, with the advancement of the TEER devices, we now have the ability to do independent grasping. We have better imaging. Many cases that was considered before very high risk and procedures we cannot really get a good result, we can get a very good results now. For example, the flail width and the flail gap, which were previously a major limitation of the procedure because we needed to grasp the leaflet simultaneously, became a non-issue now. I really don't care about the flail gap because I can do independent grasping. So this anatomical suitability is good and very useful. However, we need to know that even very complex cases, we can get good results with a good safety profile of the procedure. So this is a paper that we published recently about evolving indications for transcatheter mitral edge-to-edge repair, which means in addition to the conventional indication, we have more and more data that we can help more patients even out of the current indications. And I will present most of those cases now. So the first case is a post-MI MR. This is an 80-year-old patient that came at 8 a.m. in the morning to our cath lab. He had 10 days of chest pain while he was in vacation. They didn't really know what to do. And the day of the presentation, he came to the cath lab with severe shortness of breath, and he had ST elevation in the inferior wall. He was a grade diaphoretic. His blood pressure was 80. He was acidotic, and his lactate level was 10. 80-year-old man with a lactate of 10, and on TTE, we saw moderate LV dysfunction and severe mitral regurgitation. So 8:30, he's in the cath lab. We can see here occlusion of his left circumflex artery, and he had reperfused immediately with no issues. However, the patient continues to be very symptomatic in cardiogenic shock. The patient, the interventional cardiologist put in an intra-aortic balloon pump, and inotropes are started. And then we order an immediate echocardiogram, and you can see here complete rupture of the papillary muscle with torrential mitral regurgitation. We can see here that the papillary muscle goes up and down from the ventricle to the left atrium. This is 9 a.m. in the morning, and we considering the options for this patient. So we know in general, when we're talking about acute mitral regurgitation in the setting of MI, we have the more subtle presentation, the rapid remodeling, although those patients can be also in cardiogenic shock, and we have the very acute presentation of papillary muscle rupture, such in this case. So the patient was in cardiogenic shock stage 4, mechanical complication of acute MI, and his EUR score was high, and we asked the surgeon to come, and he said that he's too sick for surgery because he was also 80. And fortunately, in this day, we planned some elective mitral intervention. So we decided to go immediately and to perform TEER. So the TEER team replaced the PCI team, and we continued the procedure immediately after the PCI. This is 9:15 a.m. We can see here after the transeptal, very high LA pressure, V wave very prominent. So the blood pressure in this case was around 80, and the V wave was very high. The patient was tachycardic, and we decided to go to the mitral clip procedure. So we know that in those cases, the procedure can be really tough because you have the leaflets that go up and down the papillary muscle head from the ventricle to the atrium. And in many cases, you require more than one clip. And in many cases, you can have also leaflet detachment because the grasping is not really good. One tip that I've learned from several cases, that in some time, in general, when you're doing TEER, you're going immediately to the place of the valve that is the more diseased part. With the flail, you go to the flail and grasp it. In this condition, I felt that it is sometimes better go not to the tear area, but just cross it to stabilize the leaflet, the valve, prior to the grasping of the papillary muscle part. So in this case, we went a bit laterally to the area of papillary muscle rupture, and we put the first clip there, and then we have some stabilization of the valve. When you have some stabilization of the valve, you can add some more clips, and we added additional 3 clips because one of them also had a single leaflet detachment, and we got the result in the end. So it's not a zero MR. You can see here, you have residual MR, but it's much better than what you started. And this is the end of the procedure. So you can 4 clips, and the blood pressure, now it's 11:20 in the morning. The patient came at 8 a.m. with cardiogenic shock with papillary muscle rupture, but now at 11:20, he has better hemodynamics. He's not well, he still has a long way, but his better hemodynamics. So his lactate level went from 9 to 1.6. His creatinine became normal. However, after we removed the intra-aortic balloon pump, it was 10 days later, we evaluated again the MR, and it was considered to be more severe. Therefore, the heart team recommended an MVR and CABG. The patient went to surgery and died there from IRA tear. However, although the end was not very good, we showed that urgent mitral clip is feasible, and it allows you to buy some time in those patients and even act as a bridge for surgery. So this is the first presentation. The other one, the next case is patients with advanced heart failure. We also see those patients, and we also think, should we go for a clip on those patients? Is this too late in the course of the disease? So this is a 37-year-old man with dilated cardiomyopathy, with several heart failure hospitalization, that was a candidate for LVAD and for transplantation, but he didn't want to. He didn't want to have a transplantation. He didn't want to have LVAD. We know that he has poor LV function. His MR gradient was fine, but he had moderate to severe mitral regurgitation. We can see here severe mitral regurgitation. We can see the dilated left ventricle, and we see the tethered leaflet on this patient. And we decided that although according to the book he should go for maybe for a transplant, we should try and do a TEER on him. In this case, you can see here the hemodynamics. We can see the central jet. We see the blunting of the systolic vein flow in the pulmonic vein, which is, as I said before, our most important parameters when deciding when to do and how to do the procedure. And in this case, we decided to use a Pascal P10 because I feel that in those patients that they have severe tethering of the leaflets, Pascal, which is many times is not causing much of a tension of the leaflets. You can see the movement of the Pascal might be a good solution of patients with very tethered leaflets and functional MR. And we got a very good result on this guy. And we delayed the need for procedure in this guy. He's not cured, of course, but now we have 3-4 years, but he didn't go for heart surgery yet. Importantly, in those patients, we should always remember the possibility of afterload mismatch. Those patients also are on the edge, and sometimes they need the flow of the MR to maintain the blood pressure. We see high hypoperfusion in those patients, maybe for 24 hours, even 48 hours after the procedure, but then they get to a new equilibrium. So you need to just pass the first 48 hours with hemodynamic, with inotrope, sometimes with some fluids. But if you get the good results on the clip or the Pascal, those patients are better later. So it is very important to go for the first 48 hours because they will benefit from the procedure. Okay, so this is another thing that we published recently. This is 68 years old man with Hocken for several years. He has SAM-related severe mitral regurgitation, and then his disease became worse and worse, and he got into a condition that his LVOT gradient at rest was 115, and during Valsalva, his gradient almost reached 200. He was treated with medication, and he didn't want to go for surgery, and we decided to try and help him with a TEER procedure. We can see here that the mechanism of the LVOT obstruction is mostly, only LVOT obstruction due to the SAM. You can see the systolic anterior motion of the anterior leaflet causing the LVOT obstruction, and of course you can see the SAM-related eccentric mitral regurgitation. You can see here huge regurgitation, deep reversal of the pulmonic vein flow pattern, and the procedure, I must say, was very easy. You have long leaflets. You just need to grasp in the area where the SAM is more prominent. You don't go where the jet, you just ask your echo guy, show me the area where the SAM is the most prominent. And you go with an XTW in this case, and you grasp the leaflet, and you get mild MR, and you get improvement in the LVOT. You can see here the pulmonic vein flow immediately, systolic dominance, no gradient, and this is the hemodynamic during the procedure. We can see here the LVOT obstruction. You also see the Brackenborough effect after a VPB before the TEER, which was done, and immediately after TEER, we can see that the LVOT obstruction was disappeared immediately. So this is another option. Of course, we should just, I want to two comments about those patients with the SAM-related MR. First, during the procedure, the MR is acting oppositely than regular MR. When you do a TEER on a regular MR and you want to see how much MR do you have, how much residual MR do you have, you ask the anesthesiologist to increase the blood pressure, right? Opposite here. You need to ask him to lower the blood pressure because the SAM-related MR is more prominent during low blood pressure. So this is one of the issues. Another one, target the SAM. Just go for the SAM and make sure that you don't have residual SAM. So this is, of course, a new area, new option, but we recently published our experience in the Canadian Journal of Cardiology, and we are looking forward for collaboration in this specific area. So another issue is failed surgery. Sometimes we get patients after a ring, mitral ring, and you have residual MR after the mitral ring, and patients are often very symptomatic. We can see here residual MR originating from the ring, and we can see here in the 3D TEE, you can see the ring below, above the valve, and we can see the mitral clip going in the P3 area, and you go down, and you're able to grasp. You can get good results. Limitations of this are two limitations. One of them, sometimes the ring shadows the grasping area, so you need to have an excellent imager during the procedure. And another limitation, sometimes the gradient. You need to make sure that you don't have too high gradient to start with, but if the gradient allows it and you have good imaging, you should go and get it. You can get excellent results in TEER post-surgery. Last one, complex anatomy. You see, this is a patient that had flail of P1, P2, and P3. Unfortunately, this guy had big valve that could not suitable for any TMVR. As you know, 90% of the patients that we are considering for TMVR are not really candidates. It's a theoretical TMVR. So in this guy, we go and we put four clips, 4 XTWs, and we got a good result. You don't get a zero MR in those patients. You never get a zero MR, but you get hemodynamic improvement, you get a systolic vein pattern, and you have decrease in the LA pressure. So our conclusions are that TEER is the most versatile technique in wide range of indication. Further clinical application of TEER are being explored. There's also a TEER in congenital that I didn't present yet. So the field is very big. However, further prospective research is necessary to reach any conclusive data on this procedure. Thank you very much.
It was an impressive introduction to the new era. Actually, you inspired us with the potentiality of the clipping in a spectrum of pathologies which are not that rare.
Right, right.
My conclusion is do not do this at home. Yeah, especially the last one. Moni?
Okay, so thank you so much.
Okay, there's a question.
Oh, yes, a question. Yes, please, thank you.
Thank you very much for this great potpourri of cases with mitral TEER, and I had two questions actually. One is for the HOCM cases, right? You said just find the SAM, and in my mind it would be mainly A2, P2 grasping. Did you have any cases that you had to put more than one clips for SAM, or you go more medial, more lateral?
Okay.
That's the first question, if you like.
Okay, so first question is important, because you need to remember that there are some forces that are bigger than a regular bottom. There are forces that are bigger than a regular clip. There's a lot of tension there. So we had one clip, and we put it, and we got good result, and the day after it was detached. And when it was detached, it was further occluding the LVOT. So we put another one, and we stabilized it. So I think that the most important part is go and grasp the most prominent part of the SAM, and make sure that you have a good grasp. And if not, add another one. Technically, it's not very difficult. because you have long leaflets with good imaging. So technically, it's not a difficult procedure. The post-op sometimes can be challenging because those patients, where they don't have the MR, they have suicide LV many times. So they need a lot of fluids after the procedure. Again, 24, 48 hours, excellent result later.
Thank you very much. And the second
Can I make a small, just a question in the same note? So, Moni, what's your approach? Do you have a systematic approach for the single leaflet attachment, detachment? So when you have a detached clip, what do you do? So you have the follow-up, patient
So
is doing,
SLD,
but you have a relapse or whatever?
SLD is rare in clinical trials, but more common, unfortunately, in real life. You can never solve this paradox. So SLD occurs. If it occurs during the procedure, most of the time, what I'm doing, I'm adding two devices, one medial and one lateral, to stabilize it, with the knowledge that sometimes I will have some jet through the detached clip, but many times I'm getting good results even after detachment. The most frustrating part is late detachment, that you, day after, 2 days after, see detachment. Still, in those patients, I bring them back to the cath lab and adding 2 more clips if it is feasible. In most cases, it's feasible to do it. When you have clip on the leaflets, one of the limitations of it is that TMVR is often excluded. There are some cases that they do, they cut the leaflet and immediately implant a tendine. Still not there.
Okay, since we are running late in time, I think it's the last question, please.
Same question about residual mitral gradients. And you put the clips, and what is the solution? Elastomer to put a new valve or other options? And what is the cutoff value for the residual gradient for you?
Okay, I think that the last 4 words that he said, it's the most, I think that all operators face this issue every day in the cath lab. What is the gradient? Is 4 is good? 6? What about 7? So we don't have the answer for this. We really don't have the answer. I rely on hemodynamics. If I get decrease in the LA pressure, hemodynamics pattern, pulmonic vein flow pattern improving, the gradient is not an issue. We recently published in the International Journal of Cardiology that the most important part regarding the gradient is not the absolute number, but rather the delta in the gradient. We showed that patients that increase the gradient, let's say you start with 1 and you finish with 6, this patient won't do well. However, if you start with 4 and go to 6, this patient has no issue with it. So there is required additional data to validate the importance of the gradient. But personally, I also look not just on the absolute number of the gradient, but what happened to those patients. Especially patients with degenerative do not tolerate well high gradient, especially if they started with 1 or 2 and you get to 5 to 6, this is not good. Patients with functional, you start with 3, 4, you get to 6, 7, 8, it will be fine. That is my perspective on this issue.
Okay, thank you so much. We have to proceed to live in the box cases. The first one will be given. Well, always Kostas Parias provide us with excellent overviews and practices.
Thank you, George. I took the liberty to change the case I'm going to present. So this is a case of yesterday. I thought it would be very interesting to show today. We did we did it with Michael, and we lost our sleep for the night before the procedure, thinking a lot what to do with this case. So that's why I wanted to share it with you. So it's about a doctor who is 76-year-old male, normal shape, as you can see. And he underwent a thoracoscopic mitral valve repair, one of the cases we've seen earlier, with 3 cordae and a physio-2 ring number 32. That was just 10 months ago, so towards the end of last year. Initially, he had an excellent immediate result, but then the last few months he started getting tired again, exertional shortness of breath, and he came back with a relapse. Corneal angiography from before surgery was okay, ex-smoker, hypertensive, normal ECG, a high-pitched pansystolic murmur indicative of relapsing MR, normal blood pressure, and this is his drug regimen. So this is a transthoracic echo. When he came, initially it became obvious that there was a problem, and you can appreciate that there is some degree of mitral regurgitation, and you can also appreciate the long leaflets. And here you can see some degree of aortic regurgitation also, but it's probably mild to moderate, not more than this. Some also mild to moderate tricuspid regurgitation without pulmonary hypertension. And going to transesophageal to explore the mode of failure, it is obvious that some cordae are broken, have failed, and that part of the posterior leaflet that was DMR with posterior leaflet prolapse is prolapsing again. So this is what we see here. This is the pathology in the middle and a little medially. The other thing you can see is the fibroelastic dysplasia appearance of the leaflet, so very long anterior leaflet, as you can see, extremely long. And again, the color of the pathology, a large PISA, that is not going as you would expect anteriorly, but it's going mostly laterally, and you'll see in a moment why. And also you can see here the color of the aortic regurgitation in diastole running just below the anterior leaflet of the mitral valve. So take a look at that color, because we'll need to make an assessment later. So here we cut the valve in the middle. We don't see the prolapse of the posterior leaflet. We see the very long anterior leaflet. And we can see there is some distance of the anterior leaflet from the septum on the other side. And some other views. So this is a 3D appearance. So you can see the pathology is here, but you see the flail, it is going a little laterally. That's why the color has a direction lateral, anterior and lateral direction, not the pure anterior you would expect from a posterior prolapse. So some more 3D imaging from Michalis to see better the etiology and the anatomy. You can see the color on live 3D with color. And here we see all the measurements. So it was torrential MR with an ERO of 1.23 and a mean gradient of 1. That is good, I guess. And then we also got CT angio exam information for him. And what we found is what we would expect to see. So we have a rather appropriate and large angle between the aortic and the mitral curtain. The area of the ring is 537. and we did all the simulation about going for a valve in ring there, and we found that we had sufficient neo-LVOT in case we decided to go for that treatment solution, depending on how deeply in the atrium a Sapien 29 valve would go. We had a neo-LVOT of 2.8, 2.9, so more than sufficient. And then we looked at the anatomy on these videos to see what is happening with the anterior and the posterior leaflet in diastole. As we said, and as we noticed from the transthoracic, the anterior leaflet was really long. So despite that the neo-LVOT was more than enough, there was a worry about the behavior of that anterior leaflet once you go and you implant a valve. And so according to the application we all use, that ring is amenable to valve in ring with a 29 millimeter Sapien valve, and some more imaging to see that anterior leaflet. And you can imagine if you put a valve there where that leaflet would go, it could create some blown by the systolic blood flow, or if it overhangs over the valve we're going to implant there, it may actually cause some dysfunction of that valve. Both have been described. So we had a lot of discussion about what to do to this patient. We thought about just to prevent this issue of having some, after implanting a valve, to perform a tip-to-base lampoon. As you can see here from other cases, but we know that this is not always, as described, a perfect procedure. Just from this study, you can see that 10% of the patients, 2 of the 20, underwent surgical procedure, operation, for a complication or for something not completely corrected. So in summary, we have an elderly patient with early DMR relapse from failed CODI, severe MR, symptomatic patients, and we have these options. Send him back to surgery, redo surgery, with or without stenotomy, whatever. Do a valve in ring TMVR, do again a valve in ring TMVR, but with tip to base or rescue in case we implant the valve and we see the problem later, lampoon, or go to empty through the physio ring. So what would your approach to this be?
Nice case. I'm glad you changed it. Nice case. I'm glad you changed.
Okay, thanks.
I would go for a repeat tear because there's enough length, acknowledging the difficulty in anatomy, but you have enough length of the posterior leaflet, and you've got a great imager too, so you're going to go spot on, head on, and fix it.
That's the issue. You have a great imager.
However, if you couldn't do that, there is an option of doing valve in ring with either lampoon or even preferably with Batman, and my next case is going to show that. So you can implant the valve inside the anterior leaflet, and you can do that transfemorally. Paolo Denti presented 3 cases, right. And it's something which is not that difficult to do, actually. But tear is the first option, in my opinion.
I'm glad we had exactly the same way of thinking. So after a lot of discussion, initially the problem was that the patient didn't want to have a repair. He was fed up with the repair. He said, I want a valve. I want to eliminate my MR, so I don't want a clip. Just put me a valve. So there was a lot of discussion between us, what is correct, what is not, and a lot of persuasion to him to accept that we would make the decision for him. So this was exactly our strategy.
And he's a doctor, right?
Yes.
So even better.
Yeah. So this was exactly our decision to go and try tear. My fear or my anxiety for tear was that the leaflets were very long, especially the anterior. So we would just clip the tip of the anterior leaflet, and I was worrying about a lot of motion and of mobility of SLDA. So that was my worry. And then if I had residual MR or if I had a SLDA after that, I would have no other option just to go to surgery. But anyway, after a lot of discussion, although he wanted this, we put him to sleep and we went to this. So this is just from yesterday. So this is the tending on the septum. This is the height. And this is a safe sept wire through. This is the SLO, 8 friends through. You can see the safe sept and the SLO through. And this is how a Pascal catheter is going through the guide. This is the appearance of the guide after the removal of the dilator. And then we're coming again down to our pathology, reassessment, and then MPR. MPR, and as you can see, Michael putting the calipers in the correct position, you can see the red line. It shows exactly where we want to go. What kind of leaflets we're going to see there in the grasping view, and also what kind of rotation we need to have for the device. So this is the Pascal ACE. This is directed towards the valve, and then we open it and we do the clasp check just to make sure which is anterior, which is posterior before going down. And then we position it, the clocking of the device before we go down, and we check again after we go down. And then, because the physio ring brings the leaflets closer, the anterior posterior, usually there's no difficulty. And as you can see, once you go down, the leaflets are sitting on the paddles immediately. And then we see that we're not medial exactly to the area we want to go. So Michael told me, no, this is not a good position. Don't try there. But I said, I'm there. I want to try to see what I'm doing. So I did it. So this is open. And you'll see now the clasps are down. And we are closing the device here. So the device is closed. And as expected, and Michael predicted, there was color from medially because the pathology was there. So, okay. So we're opening the device, and as you can see now, the device is moved medially. The leaflets are always sitting, no problem with the leaflet sitting. And you can see how the device going higher and the clasps falling down. Immediately by looking at this, I don't like the anterior leaflet, how much is in, so we do optimization of the anterior leaflet immediately, so the clasp is up, device is going higher, torque anteriorly, and then you'll see towards the end of the sequence, the clasp is falling, and immediately now you see all the bouncing of the anterior clasp that tells you that you have the entire leaflet inside. So the device closes, and now we have a better result, but there is still some color from somewhere. So not a lot, but there is some medial and from the posterior, as you can see here. So what we do then is we check the clocking, and we decide that we need to be more counterclocked. So we open the device, and we just rotate like less than 5 degrees counterclock, because there is the pathology. And then we go up again. You see the anterior leaflet, how is probably curling in the device, but it's so long that it would almost certain that it would curl there, because it was extremely long. So we do immediately this optimization again on the anterior leaflet. So you see how the clasp is going up and then down again. And then you see this bouncing, that when we see it, we know we have the maximum of the leaflet inside. You see how it bounces. So we close it. And we have good result, very little color on the medial this time, but you see both leaflets are well pulled in. We have a mean gradient of 3, which is good, no problem. And as usually we're restless. When we're using Pascal, there's no limitations to how many times you open, you close the device. You can have like 100 attempts on the leaflets because it's a traumatic. So we open to make an assessment, and we wonder, should we optimize the posterior? Although at the initial clasping, we're sure that it was inside, so say, okay, let's optimize the posterior. So this is the optimization of the posterior. You see how the clasp is now up, and wait for the right timing. When the leaflet is going down, then we drop the clasp. So we did, we optimized both. We closed the device. And this time, well, we were happy earlier, but this time we are happy that we're not going to have an SLDA, because SLDA in this patient will be a disaster. So we close the device and we do this. This is something we like to do in most cases. We like to measure the leaflet length in the area we put the device from the baseline. So you see the posterior leaflet length was 1.3, and then we measure how much of this leaflet is outside of the device when it's closed, so 3 millimeters. So this means that we have 1 centimeter of the posterior leaflet in the device, which is the maximum you can have. This is the paddle of the ACE, 10 millimeter. You cannot get more than this. So we're very happy, and now we are releasing the device, so this is a release. And this is our final result, which is excellent. And any color you see is the color from the aortic regurgitation. If you notice, that's why I pointed out to you earlier, some color you see there in the anterior leaflet is the diastolic phase from the aortic regurgitation. So this is how we entered the case, with just 1 ACE there in the middle. And this is the final gradient, mean gradient of 3, and this is the final 3D imaging with 0 color coming back. You see it's quite rotated because we respect the anatomy of the leaflets in this area. And this is a little of PFO anatomy there. This is the sound. We have the very little flow from left to right after removing the device. Thank you for the attention.
Well, impressive result with such a difficult scenario, and this very thoughtful approach. You did the right. Any comment, Blas?
Can I be a little bit provocative? Ottavio Alfieri used to say that the Alfieri stitch doesn't work by itself unless you put a complete ring. So the surgery was a bridge to tear, right?
This is another way of seeing that.
And also just a clinical comment. In this scenario of residual MR post-surgery, usually the LV is not that dilated as you expect conventionally, because there is a functional component. If you apply exercise on this mitral valve, you will have impressive results. So at rest, the LV is not that dilated. But if you perform exercise, then you see the dynamic result of the phenomenon. So congratulations once more, Kostas.
Thank you.
So we shall proceed to the next one. Vlasis Niños, with his great expertise, who shall provide us another scenario in the MAC.
So I was asked by Yannis to present a case with valve in MAC, and I had one case that we did. So MAC is difficult for surgeons, it's difficult for interventionalists, TEER is difficult with MAC, TMVR is difficult with MAC. Valve in MAC is used with balloon expandable technologies, but doesn't have the same results as valve in valve or valve in ring. And there are anchoring factors. The most important limitation usually is MAC cases have got narrow LVOTs. So this is a lady that she's 78 with severe mitral stenosis, very symptomatic, and also lots of pulmonary issues, pulmonary fibrosis, restrictive pulmonary pattern, home oxygen. And the echo shows preserved ejection fraction, preserved LV size. The mitral mean gradient ranges from 8 to 10 millimeters, and these are the values. So there's a systolic pulmonary pressure, but it's driven mostly by the elevated wedge pressure. So initially we thought maybe it's the respiratory issue, but there was definitely an element of gradient between the wedge pressure and the LVDP. And this is how it looks here. You can see that the leaflets are immobile. There is a flow acceleration. This is, of course, during sleep, so the gradient here was, I think, 8. And the analysis was that there was circumferential MAC. There was a little bit less MAC on the medial part of the valve, but generally, on the lateral part of the valve, sorry, but generally there was quite a lot of MAC. And the area was in the order of 6.8 square centimeters. And the projection for different balloon sizes, balloon valve sizes for the LVOT was hopeless. But we were lucky because the septum wasn't that thick. And you can see how the valve, the projected valve, protrudes into the LVOT. We had two issues. First, the length of the anterior leaflet was 28 millimeters, so that's a bad prognostic sign. The second thing is that the good thing is that the AVS thickness was only 11 millimeters. So most of the LVOT occlusion would come from the leaflet. So what if we could implant the valve into the leaflet? And this is a procedure called Batman that was introduced by Tarek Helmi in the transapical cohort, whereby you perforate the anterior leaflet close to the base of the leaflet, but not at the base of the leaflet. And then you create some balloon dilatation and you implant the valve inside the leaflet and, of course, inside the annulus. And this way you translocate the leaflet to the posterior aspect, thereby taking it away. The other option, of course, would be to lacerate the leaflet, doing a tip-to-base lampoon. But we thought since there was some calcium on the leaflet, it would be difficult to do. So this is how we did the procedure, and this is the actual recorded live case. So the transeptal puncture we try to do inferior and posterior. Posterior gives you height, but inferior gives you a good trajectory with respect to the valve. And this is different to the TEER procedures. We, of course, implanted a thromboembolic protection, a sentinel device. You can see here the orthography, because we don't know what ballooning the leaflet with this calcium will do to the debris, and also implanting a valve inside this calcified annulus. Usually MAC calcification is a lot more than aortic calcification. You can see here the implantation of the sentinel device that was somewhat challenging, but we were able to deploy both baskets in the right and the left side. So once we did that, we had the transeptal and the sentinel implantation, then our setup was to put an LV catheter through the left femoral artery. We had it also prepped for potential balloon pump implantation or hemodynamic support. So this way we had simultaneous pressures from the LA and the LV and also from the LV and the aorta. So you can see that baseline, there was no gradient for pressure calibration purposes. The LV was slightly higher than the aorta, and we took that into account. Then the next step would be to put a stiff wire inside the left atrium and then exchange for an Agilis steerable catheter in order to direct our trajectory to the base of the anterior leaflet. So this is the Agilis catheter being inserted, and in a minute we'll just take the wire out, the dilator out, and just curve the Agilis catheter to the anterior leaflet. The aim now is to get a good position above the anterior leaflet in the A2 area, not very close to the base, but also quite far away from the tip, somewhere in the middle. And this is where imaging is very, very important. So you can see here we're working in the commissural and X-plane view. You can see on the right of the picture here, I don't know if I can show this there. We're trying to get above the leaflet. It's a laborious process. It took us 20 minutes to get orientated, but here you can see that the Agilis catheter is going above the middle of the leaflet there. And by being very specific, we debated whether we should go more towards the base from this calcific node or towards the tip, but we didn't feel that there was enough tissue if we went towards the center of the valve, so we just directed it here. You can see we went straight with the wire. The wire is the back end of an 035 wire. And once we were happy with this position, then the plan was to electrify the wire and cut through the leaflet. So you can see the final position on the 3D echo here. We were happy, and then we just electrified the leaflet. You will see in a minute the movement of the wire towards the LV going through the leaflet. So we're happy with the position now, and then we will cut through in a minute. We're measuring the distances between the tip of the leaflet. We're just spend our time trying to make sure, and this is, I think, the cutting. See, there were some bubbles, but you can see how the wire moved towards the LV now. Of course, not very far. We had a multi-purpose catheter in, and we exchanged for the multi-purpose catheter. But we are happy that we went through the leaflet, multi-purpose goes in, and then we just exchanged for a 7 French JR guide catheter, and then we put 2 Safari wires or Innovi wires, supportive wires, inside the LV. I'll just forward that a little bit because we're running behind. So the 2 wires now going into the LV. And the plan is to use both wires, to use 1 wire to put a balloon, a 14 millimeter balloon, Atlas balloon, high pressure balloon, to prepare the septum and the leaflet, and on the other wire to have the balloon expandable. We used MyVal here, 29 millimeter. So the initial assumption was for a 30.5 millimeter valve. We undersized a little bit. You can see the LV angiogram, how the wires go through the leaflet. And then this is MyVal on 1 wire and balloon on the other wire. So body wire, body balloon technique. And this is, we're now inflating the 14 millimeter balloon inside the leaflet. You can see the waist. So we took our time here. The leaflet is tough, I can tell you. So it took about 8 or 10 atmospheres on the Atlas balloon. And then here is the ballooning. You can see the blood pressure of the patient being a little bit compromised. We deflated, we pulled back the leaflet towards the septum to do septostomy in order to facilitate the passage of the balloon expandable valve. Here is the septostomy here, you can see. So blood pressure settled. I mean, it's about 80. It's not too bad. We didn't have to rush into some drastic measures on that. So balloon septostomy. What is interesting is to look at the color on the anterior leaflet. So there's now a big hole there with some acute MR. But it was quite easy to control that. So we pushed the balloon in, we blocked the hole, so there's no MR now. And then over the other wire, we just advanced the MyVal, 29 millimeter. It was actually very easy to go, having the support of both balloon and the wire. And now we spend a little bit of time to identify our landing zone, because with TAVI it's easy. You put a pigtail catheter, you go with the pigtail here. We had our marker with the calcium, but the zone is a little bit wide. So we relied a lot on TE, and you can see that we want to be 20-80, so 80 in the ventricle and 20 above the ventricle. So Elias helped a lot here to identify where the valve is, and also looking at the fluoro. And of course, once we were happy with the position, we removed the body balloon and the body wire, and we just inflated. We did also a ventriculography to have another idea. Sorry, I think I advanced it. Oh, sorry about that. I just messed it up, I think. Just give me 1 second. And this is the inflation of the valve. You can see that here now. Deflation. And while we were assessing the immediate echo and hemodynamic result, basically what we wanted to see if there is a valve stayed in position, which it did, if there was any major PV leak, which there wasn't. So you can see on the echo on the top left. And of course, reconnect the LV and the aortic pressure. And initially there was a gradient, but the anesthesiologist gave some catecholamines. But as the time went by, there was no gradient at all. And you can see on the echo, there's actually, the valve is protruding inside the LVOT, but there's no leaflet. So actually the flow is going there without much of a hurdle. There's some turbulence from the frame, but the frame has open cells. And if you see second by second, the gradient between the LV and the aorta is getting lower. The patient was hemodynamically very, very stable with that. So we just removed the wire and we did all our hemodynamics. And this is the echo result. So you can see there was some trivial paravalvular leak on the lateral end. But the valve is working pretty well. There was no gradient in diastole. Here is how the valve is actually protruding inside the LVOT, but you can see the aortic leaflets are opening nicely. And there was no LVOT gradient. This is how it looks on the 3D, and this is how it looked the following day. You can see it's protruding, but this part of the valve has open cells. And this is the case. Thank you very much.
Okay. Thank you so much. You extended the Dr. Savi's introduction for the yellow and red zone. It was a red zone, Dr. Savi.
I think it was an excellent case, really. An excellent case, beautiful result. Do you use routinely 2 wires when you are doing valve in the mitral or any intervention in the mitral?
We use 1 wire, but we have used 2 wires for valve in valve, particularly when our trajectory has been difficult. So transeptal puncture for valve in valve cases or even valve in ring cases is very important. You have to go inferior posterior puncture in order to have an optimized trajectory. And if you cannot achieve that, then having a second wire or even a body balloon can help you achieve that trajectory. But here, it was very important to have 2 wires because first, you didn't want to put a balloon in and take the balloon out and then take your time to put the valve in because of this hole in the acute hemodynamic effect, which was unknown. This patient was not conditioned for mitral regurgitation, so we had initially physiologically mitral stenosis and then acute MR. Patient tolerated quite well, but when you put the balloon, the deflated 14-millimeter balloon into the hole, pretty much you plugged the hole, so there was no issue. So you had your time to push your valve in. It was our first case. We plan to do 2 more. These are, of course, patients that have no options. And it's compassionate, really.
So, may I ask a small question? So, Vlasi, would you wait for these patients to have a specialized valve like Intrepid or?
I think with this LVOT, from the TMVR devices that I know, the only device probably that could work is AltaValve because of this unique supraannular fiction. But right now, AltaValve cannot accommodate stenosis with small annuli and heavy calcium, only regurgitation. So really, I don't see that we have any other option.
If the patient had a less complete calcification, less round calcification, would you still do it?
Well, that's, as you understand, we went through this case after having lots of email exchanges with Tarek Helmi, Paul Soraja. Paul Soraja did a case, and this is why I took the initiative. And he sent me the case, and then I sent this case to him. He said, don't do it, there's not enough calcification. But speak to Tarek Helmi. So I spoke to Tarek Helmi. Tarek Helmi, do it, I think you can do it. So we discussed with the patient, we agreed to do it. But the problem is, if you don't have enough calcium, you don't have enough anchoring, your valve can embolize because the closing forces on the mitral are higher than the diastolic forces on the aortic. So you really have to have good anchoring. Potentially, however, implanting the valve into the anterior leaflet can give you extra anchoring because you've got an additional sealing skirt. And what was interesting, because this case came from our surgeon, the following day he had a surgical endoscopic replacement with MAC, and he said, I'm going to do the same concept endoscopically. So instead of removing the anterior leaflet, he cut it in the middle, he pushed it to the right, and he implanted the valve with stitches, of course, inside the leaflet, and he liked it a lot. So maybe there's a concept there. I mean, it's very early to say. I mean, it's just one case.
May I remind the people that were here last year that Nikos Pilias presented last year in this conference the Batman technique, so he has an excellent result. So maybe this has been. Yeah, exactly. Yes. So that was good.
So I think it's only the very last questions. Once again with you, we are running behind the time. I think it's please.
last question, but I make a comment. Vlasis, thank you very much for this excellent case, but I want to alert and take into account about the aortocomitral train.
Exactly.
This is very important, and sometimes it will be very dangerous if you haven't got a complete ring, and if you do tip to base to lampoon. This is why base to tip lampoon is recommended. With MAC, for this case, really, I think you make a lot of effort and think about the balloon size, etc. Maybe it will be a concept. But if we inflate the balloon in the anterior mitral leaflet, if we cannot predict the tear which go to the aortocomitral train, that will be catastrophic. Batman, for me, very safe in patients with complete ring. But for the MAC, I think it's the first case maybe, and we must think about it.
That's absolutely right. All the cases that I've seen were with a hard stop, either a prosthetic valve or a complete ring. This is probably one of the first cases that is done in MAC, but the concept is there. Of course, it's a big concern. The reason, in order to avoid this potential, we undersized the valve. So we went to 29 instead of 30.5 because we didn't want to overexpand it. But you're absolutely right. We have to explore this field and see if there is any future in it.
Okay, we have concluded the session. Thank you, all of you, for the participation. And we're running behind 10 minutes more. Yeah, okay.
You know, where everyone can take and grab a coffee and then come back here in. So it's 5 minutes, okay? So I understand.
I'm leaving.
So it's 5 minutes. Επανάσταση.
Η Ματίνα, άμα πατήσει πότε η Ματίνα δεν γλιτώνει στη λίγα.
Επανάσταση. We need to commence the satellite symposium. So the topic is changing, but Vlasis remains the same.
Yeah.
So he will talk about the MyVal. He will specifically describe the results of the landmark trial, which maybe is a practice-changing study, a randomized study that very recently was published and announced, and he's going to provide also the global clinical updates. So, Vlasi.
So it's a talk that has got two presentations. The first is the evidence from the landmark RCT and some ongoing studies and upcoming studies, and the second is tips and tricks using MyVal in different positions. So this is the MyVal that we're using. It's a balloon expandable valve with open cells towards the open part of the valve and closed cells covered with internal and external PET cuff. The interesting thing about the valve is, first, the frame is a little bit shorter, but the most important thing is that it comes in many, many sizes. So apart from the standard sizes 20, 23, 26, 29, you've got the intermediate sizes, the 1.5 sizes, that the rationale is to customize and fit the true anatomic needs of the patients. And we'll see that this is quite important. The other interesting feature of the valve is that it is inserted through an expandable sheath, which is 14 French, same size for every implant. Third is that we have two extra large sizes, 30.5 and 32, and I know the company is preparing a 35 one as well, which is quite important. All of them can be accommodated through the same sheath. And there is, of course, a navigator delivery system, which is flexible, steerable, quite soft. The fourth most interesting thing is that the valve is always pre-mounted on the balloon, so you don't have to assemble and connect the balloon and the valve inside the patient. It is pre-mounted, pre-assembled, and introduced straight to the patient. So, for example, if you cannot get the valve in position, you can take it out, you can adjust your strategy, for example, put a body wire or put a stronger wire, a stiffer wire, and you can reinsert the valve. So what was the landmark trial that was presented in EuroPCR, the short-term results, and also published in The Lancet simultaneously? It was an attempt to compare MyVal with the two contemporary valves, the Sapien and the Evolut THV series, and it is very important because it's a head-to-head comparison with a large number of patients, and usually these studies are very important, first because we expand our data and the knowledge if a new device is equivalent to the old ones, but also if we have some incremental value with it. These are the countries that participated. Greece was part of it, and we're very happy and proud of that with 2 centers. And in fact, Greece participated in the top 10 recruiting centers. So I think it was very important for the ethics of having major trials in our country as well, and more are coming in other fields. So one-to-one randomization between MyVal THV and contemporary valves. The randomization was done centrally, and the one-to-one was maintained irrespective of what the relative contribution of the other two valves was, but it was also one-to-one in the other balloon expandable Sapien and Evolut platforms. And of course, as we see, MyVal and Octacore, which is the new iteration of the valve that I will allude in a minute, was used in this study. And you can see the sizes that have been used compared to the Sapien 3 sizes and also to the Evolut sizes. Interestingly, no 23 Evolut valve was used, only 26, 29, and 34 was used only in one patient because by definition the valve was up to 29 millimeter. But there is an ongoing Excel nested registry of 120 patients that completed about 60% recruitment. We're still continuing to recruit patients that utilize the extra large sizes, 30.5 and 32. And so the hypothesis was that MyVal THV series is non-inferior to contemporary valves. And these are the numbers, so assumed event rate of 26.1, non-inferiority margin of 10.44, and some statistical things that I do not understand because I'm just a doctor. What is interesting, however, is that the intermediate sizes were used in a significant 48%. So half the cases we used intermediate sizes, which shows that actually having intermediate sizes was taken into account in the practice of the physicians and was actually applied to the patients. And this is in keeping with across the board for every studies. Now, these are the demographic of the patients. There were no differences between the cohorts, and these are typical cohorts. So elderly patients equally distributed between male and female. The symptoms, NYHA class 3 or 4 was over 50% of the patients. And you can see most of them had low score, STS score, but intermediate score was also there and high score was also there. Probably these high score patients come from Greece because we're not allowed to go to low score. But nevertheless, this is typical of the contemporary status of the patients involving intermediate and low score patients now in Europe at least. And these are the comorbidities of the patients. So about half of them had significant renal impairment. And of course, there was an element of other comorbidities that we commonly see in this population. So all of these patients had severe aortic stenosis with mean gradients around 40, peak gradients of 65, valve areas of 0.7, and you can see the annulus mean was 471 square millimeters, and the mean perimeter was 80 millimeters. And there was a significant proportion of bicuspid valves as well, because really there was no exclusion criteria for this randomized trial. That is also quite significant. It was almost an all-comer study in that if you had aortic stenosis and the heart team thought that you need to have a TAVI, you were going into the trial, and that's it. No exclusions there. So the non-inferiority margin was taken into account at this statistical value, and the one-sided upper 97% interval was calculated at 3.8%. So you can see that this cohort, these needs were actually met, and if anything, there was a trend towards improvement of the outcome in the THV series by a non-significant, of course, 2.3% in the MyVal cohort. But definitely the non-inferiority objective was met by a significant p-value, and this was heavily discussed by Dr. Capodano in the EuroPCR, and he agreed with the methodology and all the statistical values of this study. So this is the primary endpoint, and if you break it down to different secondary analysis, you see the non-inferiority point was met in all aspects, stroke, bleeding, the BARC3 endpoints. What is very interesting, and in the deep dive session it was discussed further, is the mean valve area that you're getting from the MyVal series. So depending on what size of valve you're putting in, you're getting certain area. And we all know that balloon expandable valves notoriously have got smaller areas compared to supraannular self-expanding technologies. And this is probably the Achilles heel. And we've all seen the recent SMART trial, particularly in small annuli in women, that actually the performance of a balloon expandable technology is inferior to a self-expanding supraannular technology. But look at the valve area on this randomized, independently adjudicated core lab echo analysis. There is a significant improvement in what you're getting in terms of area from the MyVal series to the Sapien series. And you almost see that the previous intermediate size is giving you the same performance as the higher absolute size from the Sapien. So you get, for example, with a 29.5, 1.55, you get what you get from the 23 Sapien valve. And even more interesting, if you compare the valve areas you're getting in the 26th and 29th Evolute, the valve areas you're getting on the balloon expandable MyValve are equal. So basically, you can dare to say that you're getting a supraannular performance by a balloon expandable annular valve. So you're getting both good size of the good things from both sides. So you can see the valve areas you're getting. So this was published in Lancet, and of course, it's very important, and we're hoping in the next year's EuroPCR to see the one-year outcomes of this population we're continuing to embark. So why is this important? Because this is the first head-to-head trial comparing two balloon expandable valves from one self-expanding technology. This establishes the non-inferiority of the MyValve THV at 30 days. And of course, the availability of intermediate sizes enable precise and appropriate matching of devices to an individual patient anatomy, and were used in half of the patients. I want to skip these smaller studies because I think we're running out of time, but there is a lot of work that was published, especially MyValve in low-risk population, the EVAL registry. I think we're running late, so I think we're going to skip that, but we have some evidence for treatment of bicuspid valve disease, quite favorable. Let's not forget that Landmark incorporated a 6% bicuspid patients, and there was no signal of adverse outcome in this population. And I will just focus on the four studies, investigator-initiated studies that are coming. So baseline trial, Nicolas van Meehem is there, balloon expandable versus self-expandable trial for patients for a head-to-head analysis, the baseline trial between balloon expandable self-expanding valve. The STB trial, which is surgery or transcatheter aortic valve intervention for bicuspid aortic stenosis. This is a field that we need more evidence, and this population has been underrepresented in the trials. The direct TAVI that investigates whether doing an invasive coronary angiography before plays any role, so you can randomize patients into not having invasive coronary angiography and having directly the TAVI or having coronary angiography. With MyValve, the rationale is because you have a short frame valve and performing a commissural alignment function, your access to the coronary should be very easy afterwards, so you can defer any coronary angiography after the implantation of a TAVI, unless, of course, you have indications patients have got coronary disease, such as unstable coronary syndromes. And then the young study that addresses really lifetime management consideration issues. So any patients that are aged 65 to 75, they can go to a head-to-head comparison between MyValve THV system and SAPIEN 3 Ultra. So this is a very ambitious program that is being executed in an investigator-initiated study. So as a conclusion, in this first part, MyValve platform has already demonstrated non-inferiority in a short-term randomized comparison with contemporary valves. It has exhibited, however, superior hemodynamic performance, being the only balloon expandable annular technology at the moment with supraannular hemodynamics, at least in the 26 and 29 millimeter sizes. And of course, the presence of intermediate sizes in theory offers the closest option to a customizable TAVI, personalized TAVI implant in the market. And of course, we're still awaiting the mid and the long-term results. However, this offers the potential for durability and lifetime management consideration options. So that's the first presentation. And we can
Blasi, in the meantime, so while you prepare your next presentation, so can you speculate on why do you have this difference, the larger effective orifice area of MyValve for the same valve, for the 26, for 29, why do you have as compared to the other balloon expandable valve like the Edwards?
It's a manufacturing issue. So it was discussed heavily in EuroPCR. I happened to be the panel. Patrick Sirois gave the explanation. It's an engineering explanation. It has to do with the way the leaflets are sutured inside the frame. The suture material, the leaflet processes, and also the quality of the frame. So you've got less cells in this, both in the conventional MyValve and the octa-core. The frame is thinner, although it still has the same radial strength. That's why you can actually incorporate it on the balloon and have it pre-mounted while you're going on the 14 millimeters. So it's purely engineering.
Do you think a comparison with the Resilia would yield the same result?
Actually, there is unpublished data that I have seen. I haven't got access to them that shows that the hemodynamic performance is similar. So Resilia has got superior hemodynamic performance to SAPIEN 3 Ultra, but not superior to MyValve. Of course, there's no direct comparison. It's just looking at the valve areas you're getting from.
Good. Good, excellent. So let's see.
So, tips and tricks of how to put the valve in various scenarios. So this is how you implant it to begin with. So you've got your pigtail. This is the contemporary, the conventional MyValve. So not the octacore. Unfortunately, we haven't got octacore in Greece yet. We hope we get it, but even so, this works very well. So you can see that there are two dense zones to the bottom of the valve, to the ventricular part. One is ventricular and the other one is a little bit more aortic. And what you really want is the middle of this dense zone to be at the bottom of the pigtail where your annulus is. And once you have this position, you know that you end up 20, 80 or 10, 90 ventricular atrial. So you will have a high implantation as you should for this implant. And actually it's quite straightforward. You do rapid pacing, it starts inflating, you remove the pigtail, sometimes you leave the pigtail, and then you inflate, and that's it.
And it's interesting, sorry for interrupting again, it doesn't foreshorten like the Edwards, right?
And octacore actually foreshortens even less. So you do get some foreshortening. You can see if you look at the bottom part of the valve, it comes up a little bit here, see, but not dramatically so. So if you follow these rules, you will end up having a very good height of implantation. And actually what you get is trivial or no PVL. So it's very unusual to have more PVL than that, which is 0, or trace. And this is our normal outcome. So we've been very happy in using this in various scenarios. So this is a valve-in-valve case. This is a Magna 27. And these cases are actually quite fulfilling in that sometimes, this was an extreme case scenario. Patient was hemodynamically compromised, and we had to pre-dilate because really we couldn't cross even with a balloon. You see, we used a Landerquist wire, and then we just used the MyValve. Same way, the dense zone, second dense zones at the bottom of the annular ring, and then just inflate. And you can see how you can use it. We had some failure of pacing at the end, but it didn't affect us, luckily, and this is the result we have on this patient. Because of this is a 26 millimeter MyValve, it's a valve-in-valve situation, but you do get a lot of valve area. So it's almost as if you put a 26 millimeter Evolute. So this. Well, it's work in progress. Certainly our experience with a few cases we've done has been very favorable. We have done as low as 19 millimeter trifecta because we didn't have any other options for this patient. But generally we are going for valves above 23 millimeters for balloon expandable. Yes, either before or after. Yeah, it's the same as with any other technology, yes. Exactly. So this is an interesting case that we presented in EuroPCR. So this was a patient that had been operated twice for coarctation. You can see that there is a double lumen aorta. First there is the graft, and then there is a narrow part, which is the old coarctation, that there's still some flow in there. But obviously we wouldn't want to go through the old coarctation. We thought that we would be able to go through the graft, but there is acute angulation and some calcification. Of course, severe aortic stenosis with tricuspid valve and a lot of calcium in there. So we thought we'll transverse this graft with 2 wires, having a body wire option. You can almost see this there, shadowing the calcium where the graft is. And we were able to go in with a balloon and pre-dilate, but then going in with a valve, it was very difficult. So we went through the first bend, but going through the second bend, it wasn't possible. But the beauty of this valve is you can take it out, you can change your wire. And in this particular case, what we did, and this was advice given by our vascular surgeon who was present, take the wire, estimate 40 centimeters from the tip and use an acute bend. So we bended the wire. We were lucky that the bend actually happened to go to the place that we needed it. So by negotiating the bend, we were able to transfer the pivot point of the valve, and we were able to actually cross. And you will see that this took a little bit, but we went through the first, the second bend, and then gradually the third bend over the bended wire. and then it was horizontal, but that's not a problem because you can use the bend of the system. There was some tension. We took our time to implant it. We just pulled back a little bit because we dived into the LV, but you can control that and then just went in for this and inflated. So some challenges there, but the result was very good. There was some mild or trivial PVL, but the patient did very well. And also another case of coarctation. This is a trifecta that degenerated with the AR mostly. And the patient had a previous operation of the coarctation with an S-curve. There was enough lumen there, but of course the tight angulation was an issue. Some sizing issues here. And here you can see negotiating the bend. So again, body wire, but the system is quite flexible and it's soft, so you don't have a lot of pushability, but it is quite flexible. So you're able, by negotiating the bend and also pulling and pushing the wire, to actually go through. So that shows, you can see we're pushing quite a lot and eventually it went through. The interesting thing is that there are some stoppers on the balloon that actually secure the valve position. So these stoppers are quite strong, and we never had a case that the valve had to come off the balloon so far. And this is just inflating on the 25, this was a 25 trifecta. So I think that was a 24.5 MIVAL. And again, very good result on this patient. Horizontal aorta with aneurysm of the non-coronary cusp. So some challenges here. You can see the aneurysm of the non-coronary cusp that actually changes the trajectory a lot. So, and you can see that how it looks on the aortography. So we were able to cross initially with a wire. We used the Safari wire, but Safari didn't support that. We took the valve out and then we just used the Landerquist. So effectively, once we got the valve into position, it wasn't difficult to actually inflate the valve. And you can see we had a very clear landmark zone with the calcium, so we didn't even use the pigtail here. And again, very good results. So you can see the aneurysm, but the valve is in position without any PVL. And the beauty of having very large sizes is that you can address anatomies that are very difficult. So this is a patient with pure AR. And you can see the perimeter derived is 29.7, the area is 675. And patient had also hypertrophic cardiomyopathy, reduced ejection fraction, pulmonary hypertension, MAC with severe mitral regurgitation as well, and was very, very high risk for surgery. And we thought that the only option for the predominant problem, which was the IR, was to go for a balloon expandable valve, but oversizing it. Usually we oversize by 5 to 10%. The oversizing here was 20%. And we put a 32 millimeter valve. Actually, we used an extra 3 cc's here. You can see there's a lot of AR. And this is how we took our time inflating. So we went pacing up to 200 beats per minute. We tried to get as coaxially as possible. We inflated very, very slowly. And we just took our time with the deflation as well and the pacing. And we were holding our breath, of course, because we didn't know if the valve would stay, but it should stay with oversizing. So it's a long process. Actually, it was a very good result, and the positioning was very good. And patient improved a lot after that. I mean, even mitral regurgitation went down, pulmonary hypertension went down. But you can put it in other places too. So this is a mosaic tricuspid valve on a young patient that degenerated. This would be his 4th surgery. And you can see how the tricuspid degenerated. This was actually one of our very early cases during the pandemic, and we were remotely proctored. The challenge with mosaic is that you can see only the posts with these rings. You cannot see the lucent annular ring of the valve. So we had a Landerquist that was placed in the right lung, and our pacing, which we don't need pacing really, but we put a coronary sinus catheter in order to avoid trapping the pacing wire. We were able to get coaxial, and of course, by just injecting inside the left atrium, we were able to get our position there. You can have a suspicion of where the annulus is, this lucent zone over there. But actually, with 100 beats per minute, we were able to inflate, and we had good. Of course, this came from the injection from the right atrium, so we cannot assess the regurgitation, but we had TE in place, so that was easy. So you can see very nice fit, very good hemodynamic performance as well. And you can use it in pulmonary position. So this is a Magna 27 with free PR, and actually getting MyVal 27.5 in this position is very, very easy, surprisingly easy. Having worked with Melodies, in this case, sometimes it's very difficult to get, but this delivery system, without even deflection, was able to go up without any problem. You can see inflation is very slow without rapid pacing, and this is a valve-in-valve situation that went very well with 27.5 MyVal. Mitral, you've seen before with the MAC, so this is a mitral valve-in-valve. Again, you can see 90-10 or even 0-100 in a mitral flow. We had a very nice neo-LVOT on this patient, over 350, no issues, so this patient is actually doing very well. We measured the diastolic and systolic gradient, and 2.5 years later, patient came in for another reason with a TE just to document it. And you can see how it looks 2.5 years later. So, and valve in ring with my friend Theo, who's sitting, he helped us to do Lampoon. You can see that the protrusion is such that the new LVOT is borderline, but we were concerned about the length of the anterior leaflet. We put a sentinel. It was very easy to, after transeptal puncture, to get a safari wire into the LV, then to create a loop. Theo is the loop man. He's able to do loops in everything that moves. So he helped me with that. I learned a lot on that case, then rendezvous technique, and then we put the Astato and the flying V. That was hard, I'm telling you. You see how the catheters are moving away. We didn't know how to hold it, but eventually we did it. You can see on the third picture, Lampoon actually worked quite well. And you can see the laceration of the middle of the anterior leaflet and some acute MR, and then just putting the valve was the easy thing to do, really. You can see the inflation on the complete ring. We just take our time with this. We don't want to malposition it. We want it to be coaxial. I think it's the right thing to do. And this is how it looked on fluoro. This is how it looked on the echo. Very good result. And this is the LV angiogram. No LVOT obstruction, no mitral regurgitation, and no stenosis. So there was stenosis before, no stenosis after. And surgeons have taken advantage of MyVal as well. You can see this huge MAC. So before we showed the Batman valve in MAC, but actually surgeons prefer to do it. This is my colleague Adonis Pitches in the OR. What he does is he takes out the anterior leaflet. Now he's inspired to not take it out, but translocate it to the posterior part, but we'll see. But actually, once you take out the anterior leaflet and he uses a cuff here with a Teflon, you can inflate this valve in position without any problem at all. So you don't need to rush. You have all the time in the world because you've got extracorporeal circulation. And not only you can implant the valve, but you can also implant it a little bit towards the atrium because you've got this cuff around the base of the mitral prosthesis. The water test is very promising, and some 3 pairs of sutures there that he can ties in. He's already got the sutures in, so he ties them to the skirt. And you can see this very funny picture that I cannot explain, that the valve is actually floating in the air. So you can see there is this echolucent zones there, but no PVL. I think it's the skirt. But nevertheless, very nice hemodynamic performance. Of course, that means that the patient can go into bypass and can withstand this endoscopic procedure. So it's a versatile platform, and we have been able to address the needs of implanting it in different positions, wide size matrix, intermediate sizes, flexibility, steerability, and the system is preloaded on the balloon, so you can put it in, take it out, and change your strategy halfway through. I think that's the beauty of it. Thank you very much for your attention.
These were amazing tips and tricks. How did you do that in the double descending aorta to, with the quotation? I mean, it's amazing.
Professor Papazoglou, who is a master in EVAR, and he helped me a lot. I wouldn't know this trick, but we always do them with vascular surgeons. And Well, he told me you need to put a bend because this is how we put our grafts when we cannot navigate. I said, how do I calculate the bend? Oh, come on, calculate it, about 40 centimeters. So I took one Landerquist out, I just created a bend and put it back in, and I was lucky because it was there. Of course, you had some slack you could push in and out, but it helped. It changed the track, 100%.
Outside of the view, but yeah, but these were really excellent cases. So it's very versatile valve, and maybe Elias, who's our research coordinator, you know, now that baseline includes, apart from Edwards, this valve as well. My valve will be a good alternative for us, and this was very good. And we have a follow-up. Maybe we can show now, Thano, if you want to do that. We're going to show a live-in-a-box case as a continuation, in a normal case, just depicting that if you have a lot of sizes, you can be accurate in finding the best solution for the patient to have a personalized approach. Do you find it easier to have this? That makes your life as an operator, you know, easier.
Absolutely, because
have, you know, so many.
Yeah, because really, there's not a lot of science in putting 2 or 3 extra cc's or less when you try to match roughly the sizes that are 3 millimeters apart. So there is an index that they created as part of the landmark trial that, of course, needs to be validated and published. It's the ratio between the expected area that the valve will cover and the index area that you have on the CT. Okay. And we have shown that, or they have shown, the investigators, that actually you've got a much more accurate coverage of the area when you use the intermediate sizes. And the fact that you have such good results, and 50% of the implants almost in real practice are intermediate sizes, actually show that there's a need for that.
Yeah, this is really interesting. So, Thano, you want to...
So I will present the TAVI case. Yes. It's my valve case. Here we'll talk about a male, 79 years old, with NIHA class 3 classification. The cardiovascular risk factors were arterial hypertension, dyslipidemia, diabetes, had also sleep apnea syndrome, and normal kidney function. The Euroscore 2 was 2.65, and the CTC score was 1.8, and the logistic Euroscore 5.48%. This patient had a coro, and he saw here that he had an intermediate lesion in the LAD. But since he was a diabetic and above 70, we decided to do an angioplasty. We placed there one stent, 3.512, with a good result. The pump function in the echocardiography showed like normal function of the LV and severe stenosis with a mean gradient of 65. We see that it has a very nice left ventricular ejection fraction, normal sizes, very, very calcific valve here, with no dilation of the annulus as long as it's described. Here we see also that it has a small trivial MR, but not something important. I apologize for this signal here. It's not the most correct because it comes after an extrasystole, but we can appreciate that still the mean gradient is high, and there's no doubt that there's a severe stenosis of the mitral valve, of the aortic valve. So this is the coro. Actually, you have a good RCA. And the problem of the LAD was here, so that was actually nicely treated with one stent, as I said before. There was no problem here. The rest of the vessels were actually nice, not big calcifications. So honestly, after Dr. Niño's presentation, I don't have a lot to say. It was an impressive presentation. So the first India 18, 19 in Europe. The design was already described. The size range is a big one, and this also helped here in this case. That's why it was actually chosen, and the studies were already presented. This is the valve, and it looks actually very stable here. We have this skirting, which is very special in it, and as I said, we have plenty of sizes to choose from. It is actually, what is the novelty of this is the ease of delivery, and we have less vascular complications, better precise deployment, especially in small annuli, and it is actually more friendly for the operator, has the stent and the balloon inside, so it's just delivering an implant. Paravalvular leak, the reduction because of the skirts, and hence hemodynamics, and as I said, the studies were actually described. This was also described as second dense band that helps the operator to see where exactly is the height of the annulus and annular plane and place the valve. The positioning is also better then. That is the CT angiography of this patient, and the measurements. We have the area delivered 24.1, and since we have also calcification, but it's asymmetrical calcification, we can see it here, 24.2 is delivered in the TAVI protocol, and there is calcification of the tricuspid valve, and we go actually to the access. The access enough good to do the TAVI through the femoral, although there is a diffuse calcification on the vessels as it's expected from a diabetic patient. So we proceed to the video, which shows to put a 24.5 millimeter, which actually in this patient, according to the CT measurements, would be very precise. Go to the video. Yes, I will go a little bit fast forward. Here we go through the right femoral artery. We use always ultrasound guided puncture to reduce complications. First is the local anesthesia, of course. Here's the puncture. Nicely made is the preparation. We do the pre-closure devices we used here to ProGlide. Here is the preparation of the valve. Here we do the delivery system, the seat first. This is the pre-closure. We do like two of them. Same time, valve is prepared. 14 friends then will follow. So the city is inside, and this is the Python 14th friends.
So, Vlas, in the meantime, how often do you predilate when you use the MyVal?
I like predilation, personally. I'm used to it because I use other platforms as well that require predilation as mandatory. So if I see, I would predilate this valve, for example. There's a lot of calcium in both leaflets.
Even with the MyVal, despite having
I think
balloon expandable valves.
It makes your life easier. You don't have to agree with me. I know Theo disagrees with me. He's done more MyVals than I have, but in Turkey, for example, they do lots of direct valve positionings, and I've seen that. But
so Theo, you predilate a lot?
Actually, I'm still with the issue that predilation in bicuspid aorta, every time predilation, horizontal aorta, predilation. And if the amount of the calcification on Hockey puck are over 2/3 of the circle, predilation. But the beauty of the MyVal in the other platforms compared to the other platforms as well as is very clearly underlined in his cases, it is partially retrievable valve because you inflate the balloon, and if you don't like the position, you can pull back the valve inside the sheath. Or, for example, you cannot pass through the valve, and then You didn't make a predilation, you cannot pass through the valve. You can take the valve inside the sheath again and make a predilation and put the valve again.
Okay. So it's versatile. Good.
So yes.
And I think we just predilate it with the dilator, right?
Yes.
So
Yeah, for large sizes, you have to use a second dilator of 18 French that is in the package. 24.7, probably you can get away without it.
So here it is the valve.
so it's a normal cribber, right? Or there are
It's standard crimping process. It's
And
actually
here-
very fast
yeah.
to prepare the
And
valve.
here we use the Novi wire. Do you use a different wire? Do you use a Safari? Would make a difference?
I use the Novi most of the cases. If I need more support, I change to Landerquist.
Okay, good.
We use the Novi actually. So we advance the valve actually.
So this is the balloon?
The balloon, sorry.
So this is a different balloon than the ones that we use, the Numets and the Sipkas. Grigori, do you have experience with the mammoth balloon?
Mammoth.
The mammoth. It's a different kind of balloon. It looks like an atlas, but it's not. So it's yeah.
It behaves quite nicely,
Yeah.
stable in position, inflates and deflates fast, and there's this middle marker to facilitate your positioning as well. Well, that's the interesting thing, though. The valve
here-
is pre-mounted, and you can just push it in.
Yes.
Yes, pre-mounted.
And most of the times you need to perform the Kocaeli maneuver, named after Theo. So it's.
You make me very honored here again every time.
I think I have coined the term for you. So it's actually when you have some difficulty in advancing the valve, you give maybe 10 to 15 cc's of propofol, and everything is smooth after that. Do you use propofol inside the sheath, Greg?
Well, we used to use it in the early version of the safety.
Yeah.
We couldn't go through. Then we have abandoned it, haven't used it for a long time.
Yeah.
Now it's
Yeah. So it's a new name, a new iteration of the old method. So it's good.
So it's done.
You see a good result.
It's small insufficiency.
I think you had some central AR there from the wire.
But I think it's the wire inside.
Yeah, zero
so,
implantation.
But then we predilate, we post-dilate. We pass through the wire.
One tip that you can do if your valve doesn't cross is inflate, give 1 cc to the balloon of the valve, and that smooths your tip. Because usually there is this abrupt border between the frame and the nose cone. But if you inflate your balloon a little bit, then it makes it a lot smoother. In our cohort of the landmark trial that we implanted, in the MyVal cohort, there was 0. But we predilate quite a lot. Yeah, in the balloon expandable cohort.
So it was a good result. I think it's very interesting that you have all these sizes, especially when you treat your younger populations, when you have this annular valves, be it like the MyVal, the Edwards, especially the Resilia platform, and also the Navitors. If you have, maybe we discussed in the morning with Finkelstein and Roxana Meran. So maybe, of course, we talk about we were talking about lifetime management and its and the patient's preference. All this should be taken into account because there's this critique about the TVT registry that a lot of these patients, younger patients, undergoing TAVI procedures. So, but maybe it's a lot of these patients in the in the TPT registry, the less than 65 years old, these are other, they have other comorbidities as well. It's not like only their patient preference, but still, if you are 65 and you're talking about lifetime management, maybe you can proceed with an annular valve, and the second valve would be supraannular.
The big advantage of having all these options now, it's the financial issue. You don't mention it, but it will, just put the pressure on the companies to drop the price. We already see this in Europe, like in the US is a fixed price, that's it.
Yeah.
You put one or the other, but if we have more options, then we can just, we can see it. So that would be another benefit for the healthcare system and also the patients who pay.
Okay, so since we're talking about valve competition, and Elias Kosmas is going to proceed to the next Live in a Box, another different balloon expandable valve.
So we're going to tell about the case in the younger patient. I think, in my opinion, I think that there are two main concerns when you have to deal with younger patients. The first is the durability, and the second is the coronary access in the future. So our case here is a male 71-year-old with gradually worsening effort dyspnea and arterial hypertension dyslipidemia and left nephrectomy due to kidney cancer, prostatectomy, pelvic radiation with elevated risk scores. So the screening coro didn't show any significant coronary artery disease, while the screening echo revealed an AVA of 0.8, good preserved left injection fraction and high aortic gradients. Here you can see the screening echo and the elevated gradients here, and the screening coro. You can see the left and the right coronary artery. From the CT angiography, you can see an annulus area of 481.3 and an annulus perimeter of 79.1. Here you can see the calcification in the aortic annulus and the angle. And we have a promising femoral access from both femoral arteries. So our choice here is the Edwards Sapien 3 Ultra Resilia 26 millimeters. You can see now the video from the live case. So we start here with the puncture of the femoral artery with echo guidance, always near hospital. Here you can see the ProGlide system. The preparation of the valve, it's a Resilia valve, Edwards Sapien 3 Ultra Resilia 26. Where we're going to use is the Safari Small, and we start with a predilatation with an Osypka 2040 balloon. Here you can see the gradients. And the predilatation.
Actually, balloon expandable valves are really fast to implant, right? So for a busy program like yours, it comes handy, I think. What's your take on that?
Well, I think so. I think you are faster. You are faster if you have the most experience. But in the Evolut platform, we're really fast because we have been doing a lot. So it's in most of the patients, it's like 35 minutes work. So I think it's very important to have a proper pathway, and people are accustomed to what you do. The nurses, well, most of them, and the first, the second operator has to be a collaboration. So if something, impedes this pathway, you have a problem. But maybe some temporary delay. But it's what you are getting used to it.
So you can see the valve now, the delivery system.
So compared to the other live in a box that we saw, we see it's a different kind of preparation. So the valve is aligned inside the descending aorta.
Okay. The angiogram and here the orthography. And now the delivery of the valve. You can see here no peak-to-peak gradient. Good result. And now it's time to pull everything back. And close.
So it's a standardized approach. We do it in in many patients.
So you've already brought the next case, right?
Yeah. So it's.
I think both of them are very high quality products. I mean, I have to say I haven't got experience with SAPIEN technology, very limited, but I think the centralization relies also on your wire skills and, and you have the knobs. Yeah, I think in most cases, both of them work very well.
Good result. You can see here the echo. And that's all.
The only issue is if you cannot cross for some reason with the SAPIEN, then you cannot take it out, right?
Yeah.
That's the problem. That is, it's very unlikely to happen for most contemporary.
Actually, yes.
Yeah.
But actually, it never happened to us. And,
Sure.
I suppose in the majority of the operators, but it can happen. Maybe in the older days, Greg, if you remember, it could happen from time to time. I think that these are very, very, very nice valves. The hardware has been developed so much, and it's easier to place the best valve for the best. Yes. I think the idea is to have a personalized approach. Yes. And to do the best you can to place the proper valve for the proper patient. If you have a small annuli, there are certain valves, maybe they are better. And as I said before, to have a lifetime management for every patient, you have to give the correct information. So while we're waiting for the next session to begin and for Francesco Maizano to log in, maybe we can start again with classes on patient selection for TMVR interventions.
So I think I've got this talk and another one, and then because you probably are fed up of me by now, but sorry about that. Okay, so we move on to the TMVR and how to select the patients. And do I have to go full screen myself? Okay. So we discussed about TR before, and it's very effective, it's very safe. Certainly it is a game changer, but if you look at the data, and this is the most conservative version of that, whatever you do in the context of trials and very experienced centers, you get double-digit residual mitral regurgitation at 1 year, more than 1+. And that may be detrimental for some patients, DMR patients, FMR patients. So the rationale is, why can we not just put a valve in there and get out of the way? I mean, you know, we've seen that with TAVI, it's a game changer, so why can we not do it with mitral? And, you know, you've seen cases like that. This is a mitral stenosis. We put valve-in-valve balloon expandable. It works very well. And also valve-in-ring with lampoon. So all this can be done. Or even valve-in-mag with a crazy Batman, that it worked in one case or in others in different scenario. But mitral disease generally is a problem, is a complex. This is how aortic valve disease looks. This is how mitral looks. And, you know, clearly we had issues in the past, and TMVR has been the forbidden fruit of interventional cardiology. Do not touch. Whoever touched it either failed or went bankrupt. And the reason for that, and you see all the old devices that started in 2012 with the cardiac Q, Tiara, Fortis, most of these are dead now. We have 12 that is now Intrepid, and you know, it's there in the trials, going very, very slowly. Tendyne is the only one commercially available in Europe, but not the case in US, and I don't know if Abbott is actually willing to pursue that route. And we have HighLife that now has evolved into a new version, but really out of these 9 technologies, only 3 are still alive with some modifications. So I think we went there with incorrect clinical assumptions, with incorrect anatomical considerations, with wrong modeling in our brain to size the valves that we were manufacturing, and also wrong engineering, because really we designed whatever we designed based on the size of the anatomy, and we failed. We also went with big catheters that we could only deliver transapically, and transapical is not good for these patients. And of course, we hit a dead end because of specific anatomic problems with the mitral valve. That is the MAC and mainly the LVOT, and the size of the annulus, of course. The LVOT is a big issue you've seen before with TMVR in balloon expandable technologies. And this is the reason why in real-world population, most of the patients referred for TMVR are screen failed. And these are the reasons why they're screen failed, mainly LVOT obstruction, annulus size, and MAC. And 50% comes from the LVOT obstruction, and MAC is another 20–30% of this. And actually, in this modeling, the rejection rate goes as high as 90%. In the referred population. This 65–85% includes pre-screening of the patient. So I see patients in my clinic, and I screen fail myself quite a few of them that I think that they're impossible to do, and then they submit, and out of the ones that submit, screen failure rates go as high as 85%. So what have we done to overcome this? Well, we tried to get to new technologies that shift the paradigm and see the thing from a different perspective. So these are some of the names that came over the last, 5, 6, 7, 8 years maybe. Some of them are still in the early phase. Some of them have progressed into pivotal trials. And let's discuss. What is the new concept? The new concept is we go transfemoral. Forget transapical, it doesn't work. So in order to go transfemoral, then you have to undersize the sheaths. And ideally, you need to go fully percutaneous like TAVI. So Intrepid from 35, and these are internal diameters, so OD is more than 40, right? Is going now down to 29. M3 is 28, which is good. HighLife stayed in 30, which is acceptable. Cardiovalve is now down to 28 and reintroduced, and AltaValve is 29. So with this, we believe that we can go fully transfemoral, and also we need to expand the size matrix, go up to 54 in order to be able to expand our selection criteria. And all designs are being redesigned. So HighLife is now becoming Clarity with an open skirt in order to expand the neo-LVOT. AltaValve, I'll show you a live in a box case, but it's a totally different concept with atrial fixation, supraannular. So LVOT is practically never an issue. And of course, we have InnoValve with a twist approach. So it's a twisted approach. That means that you focus on the subvalvular mechanism, but has a different concept around it. We have Sophia from Abbott, again being redesigned, they reintroduced with a wide size matrix and a smaller 32, I think 31 or 32 French introduction. And the approach incorporates concepts like the flow of blood inside the left ventricle and towards the LVOT, like with a twist approach, or the fact that you need to transfer all your gear into the LVOT, into the left atrium, like AltaValve. Naturally, the selection of the patient is modified according to your technology. So you will have different selection criteria for a subvalvular mechanism that is twisting the cords. Naturally, rheumatics and calcifieds are out of the way. Different selection process where you're talking about an atrial fixation device. You don't care about the LVOT, but the left atrial size matters. And what is the landscape of the trials that will incorporate? So Tendyne finished the recruitment for the MAC arm in global, US and Europe. So we're waiting to see the MAC results. The randomization is still ongoing, but I don't think it will ever end because it's really very difficult to randomize TMVR versus TEER in such a narrow selection population. Apollo is working still with the Intrepid in both US and Europe with a new iteration. Apollo is used slowly, very slowly enrolling, but it's still there. Encircle finished both arms, so both the main cohort and the MAC cohort. So SAPIEN M3 may offer a solution in the future. We still have to wait. People are optimistic about it. Again, selection proportion is not very impressive, and there is a dual stage implantation process. So you go transeptally, you create a docking mechanism by surrounding the cords, and then you just implant a fully covered SAPIEN M3. But it may work. And the operators that are working with this technology saying that there is a learning curve, but once you go through this learning curve, it's not that difficult to implant. So TMVR is on a promising path with many steps remaining to take place, but obvious advantage of having a commercially available device to cover this unmet clinical need. The future is transfemoral, fully percutaneous, and in terms of patient selection, device specific is very important. The main limitations are still LVOT size, annulus size, and the presence of MAC, but there might be a light at the end of the tunnel. Thank you very much for your attention.
Great talk, Vlasis, and it's disappointing to see that after so many years we don't really have any meaningful, although we have to wait for the M3 results, that might be different. Very quick question and comment. Do you think that we have been trying the yellow and the red zone with a TEER, mostly because we don't have a valve? And what's going to happen if we do have a valve like the Evoke in the right side? Do you think that some of those extra effort that cases will probably be replaced by TMVR?
That's an excellent question, and I think this is the important point that we need to emphasize as we recruit for this trial. So right now we don't have a commercially available option pretty much, and we have Tendyne, but in a limited number of patients. So, when you see a patient in the yellow or even in the red zone, you, as physician, you're trying to do something about this patient. So, okay, let's try a clip, let's try Pascal and see what happens, But that's not the right approach, because if you have a suboptimal result, then you end up with a TEER device that you cannot do anything about. You have to remove it and put something else that you don't have. So I think as we try to recruit for this trial, and Greece is participating now, NAS's Heart will participate in the AltaValve pivotal that we just got approval, by the way. So as we are going to recruit for this, I think we should shift our attention to the yellow zone more towards TMVR. We really need to try and get as many patients as possible and as fast as possible to these trials in order to see our limits and to see our efficacy. Because really, if you don't feel as a heart team that you're going to have a good result on the TEER, don't do it, because you may have a good option in the near future, and it's really pity to waste.
Exactly. So I think, of course, it's a trade-off. You need to push your limits, but not at the expense of the patient. And of course, health system, because all these therapies might be expensive, especially if they are outside of the clinical trial. So this is very important. And there are many issues that are coming up because you have all this TR that they are relapsing. You have single leaflet detachments, maybe after maybe 100,000 TR, people that survive they will be coming up. So you need to find the solution. Do you think that there is a TMVR solution for these patients?
Well, there's certainly the option to combine technology. So I know there are a couple of startup companies out there. AMX is a very promising one that Paul Soraja is kind of the inventor of the therapy that removes the device in a minimally invasive transeptal function without touching much of the tissue of the leaflet. Of course, it's in a trial phase, but if you combine this with a suitable technology like Tendyne or AltaValve, because it has been tried with these technologies in a compassionate setting, then that might be an option for these patients. But it's still very early days. And of course, there's tear failure and tear failure. If your tear failure is recurrence of MR is one problem. If your tear failure is mitral stenosis is another problem. We have hemodynamic considerations and phenotypes that may not fit.
This is extremely important because, again, we're trying these new valves in the extreme risk cases, and then the results are very disappointing. If we, as you suggested, include patients in the yellow zone, then the results might be different. And then the technology might move, in a different way. So I think we have, not us only, as a community, to redefine the target zone and then, just get more clinical trials. That's what's going to give us an answer.
Yeah, I agree. Definitely. So thank you, Vlasi. So the next talk will be... Yes. Yes.
Yes.
You have a microphone over there somewhere. Sometimes the answer is in front of us and we don't see it. It's
Always.
not like the mitral valve.
Directly in front of me.
Press the button.
My name is Andreas Bombas, and I am coming from the engineering spectrum of the transcatheter therapies. I would like to ask, do you believe that the next generation of TMVR therapies are prone to restrict the selection of some TAVI platforms in the near future? And if there are some advantages for TAVI platforms, are they going to be in favor of self-expandable or balloon expandable?
That's one, okay. That's a good question. It might do. For example, if your valve protrudes a lot into the LVOT and creates an unfavorable angle towards the LVOT, then by putting, for example, a valve that is customized, you can customize and control the depth of the implantation, like a self-expanding valve, may be a better option compared to putting a valve that has a fixed position and that's it. And we do see that with surgical mitral valves. Sometimes there is a very narrow space between the annular ring of the mitral valve and the level of the aortic annulus, and then you only have 2 or 3 millimeters of depth that you can afford to put in before you disrupt the surgical option. So that should be taken into account. But the reality right now is we're really trying to find out a platform or a few platforms that may actually work and solve the problem of the mitral disease of the patients. And then, of course, we have to think about the future TAVI.
Okay, good. So thank you, Vlasi. So the next speaker is Dr. Lerakis from New York. So unfortunately, he's not here with us, but yeah.
Yep.
Hi, Stamati, how are you?
Yeah,
nice
great.
to have you here.
Thank you very much. Thank you very much for the invitation. It's a great honor and great to see you all. You are seeing the slides?
Yes, very good.
Great program. I will talk to you about the anatomy for imaging for transcatheter mitral valve replacement, mitral valve repair. Many modalities, echocardiography is the main modality for diagnosing of the disease and for most of the planning, especially with transesophageal echo and 3D TE. CMR is, of course, the modality, the gold standard for LV function volumes, and also very important for all the transcatheter therapies today, the CT, and mostly for planning. So, as we know, and all the previous speakers alluded, what is the problem with transcatheter treating mitral disease with transcatheter therapies? And as all of you said before, it's very difficult because mitral valve is really a different animal than the aortic valve. So that's why after a lot of efforts, and Dr. Niños brought me memories of the Q valve, the 40s, the 10-dyne, and that I imaged about 10 years ago when I was in memory, and still we're trying to, very difficult to find a valve that can solve the problem as we did for the aortic valve. The images show why it's so difficult and different than the aortic valve. Many structures to deal with completely the muscle, the chordae, the leaflets, and that makes this procedure to find what's the best very difficult. And as I tell to our fellows, and as Dr. Neo said, the solution is not transapical. Transapical has been a problem for both the aortic valve, but also for the mitral valve. And for the mitral valve, most important because most of the time the ventricles are already diseased. So if you do another insult to the ventricle, that makes things more difficult. So I think, as Dr. Neo said, and all of you know, the way to go with treating mitral valve disease will be the transeptal approach. And always I say to the fellows, you cannot do a transcatheter mitral valve therapy without to cross to the left atrium. A transeptal puncture, as all of us know, is very important, especially for the mitral clip procedure, for the other procedures. So TE, especially with the 3D modality, the X-plane, is very helpful to see the septum and see where you should do the transeptal puncture. As you can see here, where you see all parts of the septum, the superior, inferior, anterior, and posterior. And all of us know that always we have to look, and the images are the eyes of the procedure. As you see in this case, before a clip, you can see the thrombus on the catheter, and you should detect this and tell the interventional cardiologist to try to exchange and take the catheter out to prevent this thrombus going to the left side and causing a stroke to the patient. As you said before, Dr. Niños, many devices, and I'm glad I have to say that I have been part of most of these devices, which most of them are not available today, but I will present you the mitral clip, how to do a mitral clip, and I'm sure most of you know, but mostly for the fellows, how to use imaging for a mitral clip. And also, mitral clip has become part of the guidelines now for the mitral valve therapy for both primary mitral regurgitation in high-risk patients. It's a class 2A indication, but also for the secondary mitral regurgitation after guided medical therapy for ejection fraction less than 50%, meeting the COAPT criteria. Also, the transcatheter edge-to-edge mitral valve repair is a class 2A indication. So this case, as you can see, is a flare posterior leaflet, and the X-plane has made things easier. I say to the fellows that the first clip that we tried in memory long time ago, more than 10, 15 years ago, with Peter Block, it took us about five hours because at that time we had not only 2D, so it was very difficult to see the device, to see the clips and the graspers of the device. So today things are much easier. We deliver a clip in less than 5 minutes, as you can see. So what we do, we use the X-plane and we go across from one side to another, and we try to see where the MR is coming from, and we try to measure the leaflets, because the length of the leaflets is very important as you alluded before, to prevent dislodgement of the device. And we want to see at least 7 millimeters length of leaflet for the small clip and at least 9 millimeters for the big clip before we go ahead and to do this procedure. And also valve area is very important, and we prefer to have a valve area of more than 4 centimeters, and we do this with 3D, but also gradients. We want to see low gradients, and it's very important to know the gradient before you start, so you will know when you finish and compare. So this is a case here. As you see, we move the X-plane from one angle to another, just to see where the most of the MR is coming, the location of the MR, and at that point to see the length of the leaflets. And most of the time, the posterior leaflet is the problem. As you see here, again, the same, now we're in the lateral part, and you see in that area, the leaflet is a little bit short. So very important to know this and plan this before the procedure, so you don't have to deal with it during the procedure. And 3D has made things very easy for us today. It was difficult when we started in the Everest trial. There was no 3D, there was all 2D, and this is the surgeon's view. As all of you know, lateral is the left lateral appendage. Just to remember, you put the aortic valve at 12 o'clock, the anterior leaflet with A1, A2, and A3 scallops, and the posterior leaflet with P1, P2, P3. And of course, today we are able to talk the interventional with the imagers to know exactly the anatomy and the location. So this makes things move very fast in the operating room. Another thing that we always do is we check the pulmonary vein flow, and this is the left upper pulmonary vein, because you get some objective evidence after you do the clip and see if this flow is better, and this change in flow before with after the clipping gives also very prognostic information. This is systolic reversal in the right upper pulmonary vein that you see here. Also, we try to use fusion imaging, not very often, because it's not, to our experience, therefore it's supposed to be. It takes actually more time to use this, but just for meetings, as you can see here, is for a transeptal puncture, makes things easier between the imager and the interventionalist who does the procedure. So again, very important, the transeptal puncture here, crossing with the catheter, guiding the delivery of the clip, as you can see here, to prevent any injury of the walls, and then bringing the clip down to where you think is the mitral regurgitation. Sorry for this. Again, we use a 3D just to make sure that the clip is perpendicular to the commissures of the mitral valve. We want to make sure that the clip is on the mitral regurgitation. And then when we come into the ventricle, we decrease the gain on the 3D just to be able to see the clip below the valves in the ventricle and make sure that the perpendicular to the commissures position is maintained. You open the clippers, and now I remember when I talked to the company when I was in Emory, that they have to make the clip to be able to work this independent, to have the clippers work independently one from the other. So if you have a good grasp to one of the leaflets, then you keep that and you try to reclip with a better clipping of the other leaflet. So this also has made things much easier and also less painful, less time. You clip one if it's good, then you try to clip the other one. So very many improvements on these devices to help us do these procedures faster. As you can see here, a second clip lateral to the first clip because of residual MR. Sorry for this, this in zoom view. And then we measure the gradients before we release the device. We don't like to have more than 4 to 5 in the orifices around the clips. But of course, this is always, you have to see what the patient, you have to know the story of the patient. And, but about 4 to 5 is what we usually accept. Sometimes we have to, not deploy the clip if the gradients are higher, and we, as you said before, you develop mitral stenosis trying to treat the mitral regurgitation. So this is before deployment, 2 clips in this case, improvement of the pulmonary vein flow, which, as I told you, has prognostic information for, and it's also you get some objective evidence. If you see the flow better, then you know that you really did something good for the patient. This is another case with FLEL posterior leaflet, severe mitral regurgitation. Important, very 3D, very important to see the anatomy of the, and this is after 2 clips, minimal mitral regurgitation. Very good effect of the clipping on these primary mitral regurgitations, with high surgical risk, prohibitive risk for surgery. Actually, if you clip the FLEL part, usually the mitral regurgitation is gone, and we have very good results in these cases. So moving to the transcatheter mitral valve replacement, as Dr. Niños precluded before this, very difficult, and the problem is that it's a complex saddle-shaped anatomy of the mitral valve, the proximity to the left circumflex, and most important, the proximity to the LVOT. Apollo is a trial that we do here, and is now transseptal, and also now we're part of the smaller delivery system, and we will have few patients for this smaller device, 2 sizes at present. And this is a case of severe mitral regurgitation that underwent the same interpreted therapy with the Apollo trial. Based on the CT measurements, the size of the device that was selected was 42. This CT, as I told you, is very important, especially for the transcatheter mitral valve, to check the LVOT and to predict the neo-LVOT size. Also the artomitral angle, in this case everything was favorable. Artomitral angle, you want to be wide, more than 120 degrees. In this particular case it was 154, and the LVOT, neo-LVOT was 525. No risk for LVOT obstruction. Again, transseptal function is very critical. This is a safe device to cross the septum. Crossing of the septum, ballooning the septum. And this now is the valve. Ready to be deployed. Here is deployed. Sorry for this, too many movies. But anyway, a great result, and this is the gradient through the LVOT, as you can see, 3, mean gradient of 3, peak gradient of 7, and as per the neo-LVOT was no risk for LVOT obstruction in this particular case. What about the valve-in-valve? This is a case that we did last Tuesday, actually with Professor Dangas. So in this case, the angle was, as you can see, 109, which is not a preferable angle. You want, as I told you before, to be more than 120. And also the neo-LVOT here was 81 millimeters. So very high risk for obstruction, as you can imagine. And we used the Lamboon procedure. As you can see here, the catheter in the anterior leaflet. This was prosthetic mitral valve. The patient had a prosthetic tissue valve. As you can see here, And you can see the catheter for the Lambeau procedure. Again, this is the leaflet, the anterior leaflet, very easy to see. This is explained trasohageal echo to see the catheter going through the anterior leaflet of the prosthesis. And you can see here the laceration with the color Doppler of the leaflet. And now is rapid pacing, 26 millimeter Sapien Resilia was deployed. Great result, no MR, no paravalvular leak. As you can see, this patient, laboon was critical. Without laboon, would have been a hemodynamic collapse. And we know that because the neo-VOT prediction by the CT was 80. And as you can see here, what keeps the laboon procedure made this possible. You can see the flow through the anterior leaflet on this case. Without this, it would have been catastrophic. So, very good prediction by the CT. And this was a gradient, P gradient of 20 after the procedure. Thank you very much for your attention. And as you know, in your places too, this is an effort of many teams to make this happen. But it's a very rewarding field, and all of us are glad to be part of this field going forward. Thank you very much for the privilege to be part of this meeting.
Thank you very much, Dr. Larakis. It was great to get step-by-step guidance of the echo contribution and measurements. Any brief comments before we move to the next?
I think it's very important to emphasize the role of imaging, both in the selection and the procedure itself. Without eyes, you cannot see, and imaging is the eyes, and multimodality imaging is very important, especially when it comes to mitral valves. So I think this lecture highlighted everything. That's it from me, really.
Any other comments? No? Well, thank you very much. I appreciate your contribution from New York. Thank you again.
Thank you, thank you. Thank you very much. Have a great rest of the meeting. Thank you.
Ο Μαϊζάνο είναι συνδεδεμένος.
Δεν θα μπει τελικά. Okay, we continue with Dr. Ninos. We have an interesting TMVR with the alto valve. Vlasis, please.
Thank you very much. So it's a recorded case that we did in April. And this is a male patient, 68 years old, with ischemic cardiomyopathy, previous posterior lateral myocardial infarction, and functional mitral regurgitation with some degenerative components. Severe MR, these are the risk scores when it comes to STS. Not very high risk, but there was some morbidities on these patients, and the main one was COPD, and also the fact that the patient had mostly functional mitral regurgitation. So the 6-minute walk, the pre-test was, you can see, I don't see the distance, 288 meters. Pro-BNP was elevated. Other than that, the previous medical history showed inferior myocardial infarction, multivessels, coronary disease, and he was the maximum tolerated medical therapy for heart failure. So you can see the transthoracic echo. So you can see there is an element, there's severe MR. So there is some prolapse or pseudo-prolapse of the anterior leaflet. So we're not sure if there is some excess tissue there or it's just restriction of the posterior leaflet. But at the site of the regurgitation, there is a speckle of MAC that actually is there, potentially interfering with the potential TEER procedure. You can see that from the 4-chamber view, regards and fraction 46%, regards and volume 82 mils. You can see the 3D, this speckle of calcium from the ventricular end here. And you can see the hypokinesia of the lateral wall due to the previous myocardial infarction. Aortic valve is okay with some trace of AR, mild tricuspid regurgitation with not highly elevated PE pressure. Right heart cath showed the systolic pulmonary pressure of 50, but elevated wedge pressure with a V wave of 43. So it's a post-capillary pulmonary hypertension with a cardiac index of 2.1. So not too bad, but this is consistent with the mitral regurgitation. So this is the alta valve that we previously mentioned as part of the early feasibility trial. The patient was screened. So this is a supraannular device that is atrially fixated. It has this nitinol cage that is passively opposed against the left atrial wall with white cells that can accommodate 24 French of catheters. The bottom part of the valve is opposed against the mitral ring and is covered by PET scare to mitigate any PVL. And the three sizes that come is 40, 46, and 54. The valve itself is positioned in the center of the implant. It's a bovine pericardial valve, 27 millimeter, and is the same size for all implants. The true ID is 27 millimeter. In terms of sizing and patient screening consideration, we use the mitral annulus as size. You can see from the CT the calcified zone on the MAG, which is in the region of interest. And you can see that the diameter is about 44 by 40. It's a relatively circular diameter, which is good. And we thought that the 54 millimeter annular ring, the biggest annular ring, is the appropriate one, oversizing to the anteroposterior diameter by 37% and the commissural diameter by 27%. We look into the LV, but mostly we look into the annulus and the MAG. You can see the MAG that it dives inside the LV from the profile view, but it's a mild MAG if you look at the MAG score. And the most important is the left atrium, so we look at the size, height, and width, and we look at the anterior tilt angle. Also, volumetric changes during the cardiac cycle, which is 9.2%. If it's more than 20%, we steer away. And also, we look at the mitral annular motion, which is 6.3 millimeters. Anything above 15 millimeters, we steer away, at least in this particular stage of the development. So looking at all that, we decided about an implant of a 54 on the annular ring and 75 by 80 on the cage. That will give us a height oversize around 15% max and width oversize about 20%, which is just about what we need for an implant. Transeptal puncture needs to be above 3 centimeters. We have a projected between 3.5 and 4 centimeters. We go posterior and inferior. And the procedure is quite straightforward, really. It's a single stage. So transeptal puncture, inferior posterior location, balloon septostomy, introduction of the steerable guide catheter, steerable sheath, then the delivery catheter through the sheath. The catheter is flexed down to the mitral valve, and the deployment starts from the mitral annulus level to the top of the left atrium, and then release. The important thing to say is that up to the final stage of the procedure, before actually detachment of the delivery system, the valve can be resheathed and repositioned up to 3 times. So it's a versatile procedure. So the setup is primary access right femoral vein, fully percutaneous, left femoral artery for arterial pressure monitoring, and also to be ready for hemodynamic support, left femoral vein for temporary pacing, because you use some fast pacing, not rapid pacing, right radial for LV pressure monitoring, and of course 3D echo, fully percutaneous approach. So you can see using 2 proglides and a figure of 8, we have obtained access from the right femoral, inferior and posterior puncture, and 3.8 centimeters height we achieved. So this is transeptal puncture, a Landerquist wire advanced into the left upper pulmonary vein, and then balloon septostomy. We only use an 8 millimeter balloon because we just want to facilitate passage of the steerable guide catheter, nothing more than that. Then we pre-dilate the groin with some dilators up to 24 French, and the 29 French steerable guide sheath is actually inserted and advanced through the atrial septum. You can see very clearly on the echo on the top left. Once we achieve this position, we put it on the stand, and we take out the dilator and the wire, similar way we do for the TEER procedures. So wire comes back, dilator comes back, and we just aspirate and we take it out. Then the delivery catheter is introduced under flushing, and the aim is to advance it to the tip of the steerable guide catheter, so align the inner catheter with the outer catheter. So the interesting thing is that there is a dual catheter design. So you have the outside catheter, which is a steerable sheath, and the inside catheter, which is the inner catheter. So when you unsheath the valve, you unsheath both catheters, one after the other. And that gives you excellent control of the position of the cage. But first you have to go down to the valve, and that is done with the flexion of the system. So first you just put the tip of the inner catheter, the implant actually, just outside the sheath, the steerable sheath. Then we flex down to the valve in a pre-specified RAO position that you get from the CT scan. And then we just flex down. The flexion is actually quite easy because you don't have to push your inner catheter out. Like, for example, the straddling you do with a mitral clip. All you just have to do is just flex down and observe your tip to be away from sensitive structures. And then once you're down to the valve, you put your imaging to the commissural and the multi-D position, explain, corresponding long axis view. And all you have to do is to go down to the mitral valve, below the annulus, at the depth of about 10 to 15 millimeters in systole. And this is exactly what we're doing here. You can see on the left picture, top left, the position of the frame, which is below the annulus, below, and we measure in systole 10 to 15 millimeters. Once we're in this position, then we unsheath first with the inner catheter and then with the outer catheter. The plan is first to expose the annular ring, which is done, then to expose the inner valve, so the chimney. That has a height of about 25 millimeters. So go just above the tips of the chimney, which you can appreciate on fluoroscopy. You can see the annular ring is already bulging a little bit on the right side, on the top right, on the fluoro. Once you achieve this position, so now the outer sheath is withdrawn and we're being directed just above the tips of the inner valve. Once you achieve this, you shift everything laterally, so you achieve a lateral engagement that you can appreciate on echo next to the appendage. That gives you some stability, so you're rubbing against the lateral part of the annulus. By controlling the height, you can adjust your height, and then all you have to do is open up the valve by 50%. So now you can see there is a function, there's an inner wire that is attached to an inner 6 French catheter. And once you push this wire, which is like a loop, a snare around the valve, you release the valve. So now the valve is fully functional. You can see on the echo, the leaflets are actually moving in the long axis view. So the patient is actually maintaining hemodynamic stability, even though you're just blocking the mitral valve because the inner valve is working. At the same time, we'll just start pacing. And what you see now is in real time. So we are unsheathing the nitinol frame, and there's no editing on that. This is as it's happening. So by removing the inner catheter and the outer catheter and adjusting the positioner, which is this little 6 French catheter in the middle of the assembly going down to the valve, you're just able to deploy your valve. You can see the progression of this deployment on the echo. You can see the cage opening and filling up the left atrium. And actually what we have found, once you open about 60% of the cage and you engage on the lateral and the wall and the atrial septum, the valve remains very stable. So we reach to the top, we push the insertion catheter to the rooftop of the left atrium, and now the cage is fully deployed. And you can see the valve is functioning. Still the valve is snared, so we still have another 50% to deploy. And needless to say, we can resheath and reposition quite easily. But we are happy with the position. The hemodynamics are good. We will stop the pacing in a minute. And right now you will see on the fluoro, we will deploy the inner valve. So here I'm just pushing the snare and you will see the inner valve being deployed fully in a minute. but still we have the opportunity to retrieve, to resheath. Once we're happy with the position, then we have to deploy in 2 stages. First, remove the inner catheter, the positioner, which we will do in a minute. By pushing in the snare, we have to be extra careful because if you're too fast, you may yank it out, you may snare it out. And of course, you can still resheath, but why do that? So you see, in a minute, we will take the inner catheter out, the positioner. That adds additional stability when we implant the valve. So it's actually is putting a lot of internal push towards the left ventricle and is maintaining the stability. So that's out. And then in a minute, we will unscrew the valve. So device time on this was 15 minutes. So it's pretty fast. Most of the video is unedited. That's it. And then we'll just take the sheath out. You can see on the echo how the valve is already working. Spacing is stopped. There's no LVOT gradient. You can see simultaneous pressures of LV and aorta. And we're just taking the sheath back. And of course, we need to assess the outcome. So this is how it looks on echo. Supraannular valve functioning quite nicely. Elimination of mitral regurgitation. At worst scenario, you will see some trace of PVL. Left to right shunt. We left this shunt. We didn't close it. There's a big question whether we should close this beforehand or not. No gradient across the mitral valve. These are immediate images from the procedure. So you can see the LVOT is widely open. One interesting feature of the valve is, as you see in systole, is moving actually away from the septum. So it's not protruding at all, but it's actually moving away because there's a work in progress by Joao Cavalcante that shows that this frame is actually moving with the native mitral annulus. So it's actually falling, you can see that even here, he's moving in systole away from the septum. So the paradox for this, which is a pleasant thing, is that the LVOT area in systole is bigger than in diastole. Not only you maintain LVOT, but you get a better LVOT area. Thank you very much.
Thank you, Vlasi. Impressive. And how many cases have been done so far?
So I think we're over 85 cases worldwide now, starting from the transapical and moving into the transfemoral. Of course, the transfemoral cases now have accelerated since Germany, France, and Spain joined. In Interbalkan, we've done 10 cases, but we're lining up for another 5 or 6 as the pivotal start. And pivotal will start in Onassis Heart Center too. So Dr. Iacovi is PI for that. And hopefully Ioannina University Hospital as well. And maybe other centers in Greece as well. Will be nice.
So this is, a really interesting technology. So initially someone would think that maybe it's, why do you bother with the left atrium and not, directly approach the mitral insufficiency? But it's a different kind of concept. So we are not trained to, for that, because we always believe that you have to reach, your target is the solution. So, but this is an indirect method, but with very interesting results up to now.
Well, the interesting thing is that the recruitment rate in the EFS that we reported in EuroPCR and also CSI recently is 77%. So this is way too high compared to any other technology out there. So not only is it feasible, but it's actually realistic. So you can treat a broad range of patients. LVOT is never an issue. LA size is an issue, but really you have to have LA diameter of more than 80, 85 millimeters. So it's not for the small LAs still. MAC is not a problem. So if you look at the pivotal, there's a main cohort, which is the ordinary mitral regurgitation patient, whatever etiology, but there's also a MAC cohort, dedicated MAC cohort for 100 patients. So overall, 450 patients in total.
Except of mitral stenosis, of course.
So far, no mitral stenosis. So the minimum diameter that you need to have on the mitral annulus is 29 millimeter, between 28 and 30, 29 is an average. If you're below that, this current iteration doesn't work. Another company is preparing a mitral stenosis iteration as well, but it's not out there yet.
So this is going to be really interesting to see. So Elias, so you are doing the echo in these cases. So do you have a special challenge in imaging these procedures?
No, I think imaging is simple. It's very simple. It's not a problem.
Yeah.
It's more easy than for a mitral clip. But last, I had a question. Why to prefer that valve if you can put a mitral clip? I mean, which is the criteria?
I think
Which
if
are
you
the
have,
criteria?
I mean, that is a very good question. It's following what the conversation we had before. So if you have a green zone mitral clip patient, I think you should put a mitral clip or any TEER device because it's safe, it's effective, it's proven, there's a lot of experience. But what happens if you have a red clip, a red zone TEER, then you cannot treat. So you should try and see this technology or others. What happens in the yellow zone? That's the big question. I mean, do you still go for a TEER device, accepting a suboptimal result? What will happen in a year's time or 2 years' time as we move to younger people? I mean, this was a young patient. We could have probably put a TEER here and be okay with it. But this is the discussion that we had before. I prefer to steer this patient to TMVR, and we had a very good result. The patient came for a follow-up at a month and a half, and his 6-minute walk was 440 meters from 280.
Yes. Do you have any data on thrombosis or?
It means lifelong anti-thrombotic therapy.
No, not really.
Not really?
The regime that we follow and we recommend is 6 months of vitamin K antagonists, interferon, warfarin.
Right.
But then we just move to whatever anticoagulation patients were taking. So that means if the patient is in AF, we move to NOACs, DOACs. If the patient is in sinus rhythm and the EFS, there was a 20% population that was in sinus rhythm, we just move to aspirin. We're not worried at all about the frame. Everybody says, oh, there's a lot of metal in the LA. It's nitinol. I mean, it will endothelialize. It's thin struts with big openings. We put ASD, PFO devices day in and day out, and we don't worry. What we do worry is about the valve itself, which is a biological prosthesis in the mitral space, and that may thrombose unless you give proper anticoagulation as for any other valve. We haven't seen any thrombosis yet, at least not worrying signal.
Is there a plan that in case that you have a deterioration of the valve in the future, you know, especially if you go to younger population, to do a valve-in-valve procedure?
So actually putting a valve-in-valve there is easier compared to putting a valve-in-valve in an annular position because you don't care about the LVOT. I mean, this is a 27-millimeter valve. You can easily put, and it has been done on the bench, transeptally to go through the struts that are very wide, 24 millimeters, and put a balloon expandable 26 up in. It has happened in the bench. It's never happened in real life because it's only just started the experience. But it can be done without any issues, and actually the LVOT will not be affected.
And you think the struts will be dilatable? It's 24, but you know, with the current technology.
Well, 24 means that any 14 French device can go through, but you can also dilate with a balloon and then close. One issue is how will you revisit the left atrium for any other procedure like Watsman or LAA, for example, or PV ablation, if you put an ASD device. So that's why now we're discussing about putting a cardioform device that has more fabric and less metal in order to be able to perforate it and balloon it, as opposed to other nitinol-based devices.
Good. I don't know if Stamatis is still there. No, I don't hear him. Yeah. Any other comments from the audience? Theo?
I have a question.
Yeah.
Thank you for the excellent presentation. Really, we are learning a lot of things from your presentations and the new technologies. My question will be like the other questions, but you know that atrial functional mitral regurgitation is an issue. During the follow-up periods, when the left atrium gets smaller, is there an issue for the device, or what is your opinion about it? Can we use, for example, this device for atrial functional mitral regurgitation also?
So that is an excellent question, and there are two answers to that. First is, if you look at the cohort, I didn't show it because it wasn't part of the presentation, but the cohort of the EFS was mostly women with atrial or degenerative mitral regurgitation. So small LVs, preserved ejection fraction, big LAs. The reason is because this valve came late in the process of getting into trials. these patients have been rejected, especially in the US, by other technologies and recruited by AltaValve. So it's very interesting. If you look at the cohort, there is at least 20 or 30% of this population have been rejected because of narrow LVOT, and that has not been an issue. Now, when it comes to the left atrial behavior, there is work in progress, and Nadira Hamid should be publishing that soon from Minneapolis Heart, that the left atrial actually remodels in this population. So you get reduction in the volume, and whatever wall motion was there is actually maintained. So it doesn't freeze the left atrium. The left atrium still, and there's tissue Doppler and other methods. I mean, I'm not familiar with exactly the paper that she's publishing, but it shows, if you look at the curves, the left atrium remodels because the nitinol frame is actually quite soft. So it allows wall motion, as mitral annular motion, it allows wall motion. So that's promising.
So this is very interesting. So thank you very much, Vlasi. You did a lot of talks today.
Thank you. It was a privilege.
This is because you are doing most of the TMVR work here in Greece. So, so thank you for that. So we'll have to make a small break, and then we'll commence in 15 minutes to watch another satellite symposium with Professor Duncan in another TMVR technology. So thank you. Start to another where we are going to satellite lecture. So Professor Duncan will present the innovations in TMVR and Intrepid trial updates. So Professor Duncan, we are all ears. Thank you for being here with us, even remotely.
Thank you very much for inviting me. I'm delighted to join you, and I hope you can hear me and see me okay.
Yes, definitely. Very nice.
Fantastic. And my slide hopefully is now in full presentation mode, so good job. Thank you very, very much for inviting me. I'm delighted to join you, and I've been listening into the conference so far. It's fantastic, and I've learnt lots already, so thank you for that. So my remit is to talk to you about about TMVR and innovations in the Intrepid Apollo device. But before that, I just wanted to talk briefly about we need to do this. And I've been listening already, and clearly for patients who've got degenerative mitral regurgitation or functional MR, who are not surgical candidates and who have anatomical criteria for edge-to-edge repair, then this is an indication now. And a good repair is the treatment, the first repair strategy. So a good repair is better than a replacement. But we do need to have TMVR devices available for patients that are not surgical candidates and that are not good anatomical candidates for edge-to-edge repair, because a transcatheter mitral valve replacement is better than a transcatheter mitral valve repair. And for that reason, we now have lots and lots of different devices available that we can use on the market. And I think you've been hearing about some of these during the course of the morning already. So the anatomy that we're talking about are patients such as these. So the patients who have got calcification in the grasping zone with significant small mitral valve annuluses, the patients who've got very dysmorphic, dysplastic mitral valve leaflets with very large indentations or clefts, or certainly tissue deficiency where grasping will be a problem. The very dysplastic looking mitral valve leaflets, or particularly patients that have had healed infective endocarditis. The rheumatic valves that are very hard to get a symmetrical coaptation with edge-to-edge intervention. The patients with mitral annular calcification and again small mitral valve annular areas. And even then the patients with functional mitral regurgitation who have, if I can get this to move, who have significant functional mitral regurgitation and a coaptation gap all the way along the coaptation line. So when if you just forgive me just for a second, because I can't see my slides, I can only see, I can't move my mouse anywhere. I apologize. Give me a second.
Yeah, no problem.
My mouse seems to be frozen, but never mind. I hope I can, because I can't see one half of my screen, so I hope that I remember what's on the screen. But in any case,
we can see your slide, but maybe it's not moving.
Yeah, no, I can see my slides. It's just I can't see my mouse and I can't move the panelists from my screen, so I can't see half of my slides.
Okay.
But it's okay. It's okay. We will we'll manage. I'll manage.
Well, the TMVR is a difficult business, maybe.
in every way. But actually, so when we look at a large registry for patients who are screened for transcatheter mitral valve replacement, there is some lovely studies looking at all devices, so the Tiara valve, the Intrepid valve, high life, cardiac, and Tendyne, and obviously excluding the Alta valve, which is not worried about necessarily LVOT obstruction. There are three main reasons for screen fail for TMVR, and the majority of those are for annular size, that's either the annulus is too big or too small, or the predicted neo-LVOT is going to be a problem with possible LVOT obstruction and systolic anterior motion of the mitral valve, or in some cases the LV size is just too small to accommodate the sometimes rather large TMVR devices that are currently available. And so the questions that always arise for me is, when we're measuring the mitral annulus itself, is again, is the annulus too big or too small, but particularly what part of the cardiac cycle do we need to measure that mitral valve annulus? When we think about neo-LVOT, we often show static still frames, but obviously the LVOT is a dynamic structure and it changes throughout systole, and it's very dependent on multiple things, and not one of these is particularly more important than the other. They're all codependent, so it obviously depends on the baseline LVOT size, the anterior mitral valve leaflet length, the angle between the aortomitral continuity, any basal septal hypertrophy, and again the the LV size itself. And again, when do we measure the LVOT? Is it in early systole? Do we take an average throughout systole? Is it at end systole? Or maybe even better, do we look at a percentage area reduction? For patients who've got mitral annular calcification, the two questions really that come to me each time is, do we need to pre-dilate this valve? And if we are putting in a device, how much oversizing does it need without causing encroachment or distortion of the transcatheter mitral valve device that we're going to be using? And then, of course, each different TMVR device comes in different sizes. There's different anchorings, there's different hemostasis, there's different methods of access. So, you know, there's a range. So to cover screening for TMVR is complicated. But nevertheless, I think we've worked out now that really what we know is that the mitral valve annulus is at its largest at about 40% of the cardiac cycle. So if you are screening for these patients, you do need a multi-phase CT scan, in particular look at the end systolic dimension of the mitral annulus. But again, we can easily do this on transesophageal echo. So with a nice X-plane, we can see the mitral valve annulus in its anteroposterior dimension and the intercommissural dimension. We can take rough measurements so we can screen out patients whether we think the annulus is not within range of the particular transcatheter mitral valve device that we have got access to. Of course, we can do this now on 3D quantification, but better really on MPR multiplanar reformatting imaging, where we can look at the any phase of the cardiac cycle, any phase of systole, but really just looking in this particular phase at sort of early systole, looking at the AP dimension, the intercommissural dimension, and the mitral annular area. So again, this is sort of pre-screening before we need to go on and perform the definitive CT scan. With particular emphasis on the Medtronic Intrepid device, we have now got ranges for the two devices that are available, which I'll talk about a bit later on. At the moment, currently available is a 42mm device and a 48mm device, and you can see the ranges of annular sizes in terms of orthogonal dimensions and in terms of area that are the cutoff. So clearly the patient on the left is a patient with Barlow mitral regurgitation, and this annulus will be too big for the currently available Intrepid device with an AP dimension of 53. And this patient on the right, who's got rheumatic mitral valve and a very small anteroposterior dimension of only 21, will be too small for the currently available device. Just moving on quickly to try and predict the likelihood of neo-LVOT obstruction. Again, this is really difficult because this is a dynamic anatomy, and also it clearly depends on fluid status as well. So if the fluid status changes as well as all of these anatomical criteria, you know, it really sometimes is quite hard to predict with complete certainty what the LVOT will be like. But clearly the LVOT is dependent on the LVOT size itself, whether the anterior mitral valve leaflet is long and calcified, its support, the basal septum, the angulation, and whether or not there's any fibrosis or calcification in the subvalvular apparatus. So, for example, on a transesophageal echo, it's very easy to sort of screen these patients very bluntly. So the patient on the left has a nice wide open LVOT compared to the patient on the right, who's already got a small LVOT and therefore is likely to develop outflow tract obstruction. The patient on the left here has got a fairly long anterior mitral valve leaflet. It's 3.1 centimeters, which is a little bit on the long side. And again, using 3D reconstructions, we can measure whether that's A1, A2, or A3, and actually measure the lengths of all of those scallops to get an idea if there's any particular very long scallop of the anterior leaflet that could end up in the outflow when a device is put in the mitral valve annulus itself. But I think sometimes more important is not the absolute numbers, to look at the actual dynamicity of the anterior mitral valve. So you can see on this particular patient, the anterior leaflet is again about 30 millimeters, but it's very tethered and pulled towards the posterolateral wall, and therefore it's keeping itself way out of the LVOT. Whereas this patient has got a similar LVOT dimension and a similar length to the anterior mitral valve leaflet, and for that matter, a similar aortomitral angle. But this patient does not have caudal support at the tip of the anterior mitral valve. The very tip of it is prolapsing. And you can see that it's unsupported in systole. It's actually almost touching and sometimes does touch the basal septum. So again, a static picture may not necessarily tell you that, and it is useful to see the motion of the anterior leaflet throughout the cardiac cycle. clearly the more obtuse the aortomitral angle, the more likely it is to not develop outflow tract obstruction. And the patient who's got an aortomitral angle less than 120, certainly less than 100, is likely to develop outflow tract obstruction. And I think this is quite a nice image. I think this again underscores the sort of dynamic nature of the LVOT. So this is now us sitting in the left ventricle looking up at that blue structure, which is the aortic valve, and you can see the structure coming in and out of the screen is the anterior mitral valve leaflet, and you can see it's way away from the basal septum, and the LVOT area is maintained more than 2.5 all the way through the cardiac cycle. So again, this would semi-quantitatively suggest that the patient would not develop outflow tract obstruction, whereas this patient is a still frame, is a patient that would be likely to develop outflow tract obstruction. The native LVOT is small. The anterior mitral valve leaflet to basal septum distance is only 3 millimeters, and their aortomitral angle is narrow. So this patient is very likely to screen fail. And hopefully then you can see here, this is again a similar picture of the LVOT looking from below. You can see how the anterior mitral valve leaflet is billowing into the left ventricular outflow tract and causing turbulence all the way through systole. So again, a nice semi-quantitative way of suggesting this patient's not likely to screen pass. And the final thing is just looking at the LV size itself, because particularly with some of the devices, they can be a little bit bulky in the subvalvular apparatus. And obviously this patient, again, I'm not sure why the images are not moving, but the LVOT image, the left ventricle may not have the capacity to accommodate the transcatheter mitral valve implant that we are expecting to use. I'm sorry, now my slides are not advancing at all. Okay. Pardon me for 1 minute.
No problem.
I can't even find my mouse. I'm afraid I can't see my mouth moving at all. There's something wrong here. I can't stop sharing, and I can't come out of this.
So the technicians here is telling me that maybe if you have a second screen, maybe you moved to the second.
I don't. I don't know if it's possible, because I sent my presentation to the technicians as well, whether they could maybe start the presentation again.
Can we just scroll through the slides, and maybe you can talk to us and instruct us when do we need to proceed?
Yeah, exactly. If you could bring up the slides.
Okay, that we will do.
But unfortunately, I can't stop sharing, so I might have to switch my computer.
It's okay, no problem. But yes, we need to get the slides. Yes, we need to get the slides.
Could the technician stop my sharing? Could he do that, and then I can try and reboot my computer?
Yes. Maybe we can.
Thank you.
We can get you. Yeah. Okay. Okay. Yes. So you good. So, Πέτρο, χρόνια πολλά λοιπόν. Okay, can you go back? I think yeah. Πιο πίσω. I think here is fine, yes. We have seen the slide, but maybe we can. So, if we can make a new connection. Έχει κολλήσει γενικά.
Έχει αποσυνδεθεί.
Ωραία, εντάξει, θα ξαναγίνει λοιπόν αυτό. Ωραία. Οπότε, we can discuss with you, Greg, and also Theo has extensive experience in, No, in TREPID, no. Do you have experience with TREPID? No. Okay. This is a difficult work, and we have in the previous session we have Vlasis Ninos talk to us about TMVR, about patient selection, which is not that easy, and we have a lot of these patients that we screen are actually excluded by the majority of the companies. So I don't know which is the rate of the acceptance rate of the Intrepid. Vasily, do you have an idea what's the acceptance rate?
It's less than 50%, maybe. 40, 30. It's less than 50%.
The acceptance rate of the Intrepid
The screening
patients.
and people who are enrolled. It's about 30%. Correct. Yeah. Yeah.
So that would be really interesting because it will expand
Still
the
is
number
a
of cases.
low thing, and it's because of the LV outflow track. Actually, what we're correct. Yes.
Okay. Which is the main driver for rejection? It's the neo LVOT or it's
LVOT and size
Yeah. And then you do your measurements at the end systole, right?
Mm-hmm.
So the cutoff is 1.5 centimeters. But if you are a little below 1.5, you get all the early systolic phases, and you will have a range more than 1.6.
So, Vasily, if I remember well, in the publications, 1.7, I think, that's the cutoff point. You went down to 1.5.
Yeah.
And now we're using new algorithm to include also the BMI, the septal bulge,
Mm-hmm.
and with an AI technique, they give you an LVOT score, which is a little more promising than what we used in the past.
So when you screen via Medtronic for a patient for possible Intrepid implantation, you get an AI kind of decision based on a proper algorithm.
You put together the new area, you put the LVOT area, the BMI, and the septal bulge, and all these calculations, we call it LVOT score, and with this calculation, it gives you another 14% more patients included in the trial.
And aorticomitral angle also in the
Everything
analysis.
above 120 is acceptable.
So the
Because in the past-
mitral angle has to be more than 120. Yeah, that's interesting.
In the past, from the TAVI trials, when the TAVI was done with the transapical approach, so the mortality was equal to the surgery when we look at but all the new technologies are going to transeptal approach, and the new results of Intrepid also compared to the first trials, Apollo trials, new results are much more better.
Yeah.
But every time it's a learning curve also.
Yes.
The risk of neo-LVOT obstruction, and I know the score with also CT evaluation is very, very important.
Exactly.
Septal bulge, anterior mitral leaflet length, calculation of neo-LVOT, and aorticomitral angle for the transeptal approach.
And now you have new tools. People know how to use Remensio, and the TOE, and Alison was just shown as echo data that you can actually be able to predict maybe neo-LVOT obstruction by echo by itself, right?
Well,
The screening committee doesn't evaluate the echo, only the CT.
mm-hmm. Well, Dr.
Both with the multi-phase analysis, you have all the early systole and systole phases.
Up to her talk, actually, Dr. Duncan was concentrating on the echo and the TE, which probably you can exclude some people even from doing the CT and sending it over. So that's the first step of, getting the easiest thing. If you see that the anterior leaflet touches the septum, then there's no point of sending it, do the CT. That's what she was, talking about. And using all the different techniques with the 3D from the ventricular side to see if it is eliminated, etc.
Yeah, this is very important that you mentioned last, because there is a new terminology also is coming for the neo-LVOT. It's called as skirt neo-LVOT when you put the valve. Yep. The skirt, I think, skirt neo-LVOT will be much determinant for LVOT obstruction rather than the neo-LVOT calculations.
You're right.
These all are learning curves.
Yeah, yeah. It's evolving. See, back again. Dr. Duncan is back again.
So, Alison, nice to see you again. Is something working?
Do you consider this as an option when you offer?
I hope so. Can you hear me okay?
Let's see. Let's make a new start.
I'm all for new starts. Thank goodness for that. So, so this is the LVOT view from the bottom on a patient who's got an unsupported mitral valve, and you can see it bulging into the LVOT. And the next, just click next. So the next video works perfect. So you can see that's turbulence through that sort of elliptical LVOT shape all the way through systole. Next. And here we have a completely different sizes of left ventricles. So particularly with the larger TMVR devices that sit in the left ventricular outflow tract, you've got space with the patient on the left-hand side, but there's no space, and that would contribute to LVOT obstruction on the patient on the right-hand side. Next. So fortunately for us, most of the screening is performed under CT, but of course there is a little bit of morbidity associated with CT, particularly if your patient's got significant renal impairment. And so, much of the screening can be done on transesophageal echo imaging because it reproduces similar pictures to CT, and the agreements between good and experienced TOE is very similar to CT, with the advantage of being able to see things in dynamic mode. So next. Having said that, CT is still the gold standard for screening for patients for TMVR, but you can see it's very similar to the TOE. So we look at the AP dimension, the intercommercial dimension, and the perimeter in systole and in diastole. Usually, if the patient's got functional mitral regurgitation, there's really not much difference between those two parts of the cardiac cycle, but that can change quite a lot in patients with primary mitral regurgitation. Next. And then once we've done the CT, we can reconstruct the neo-LVOT. So at the top, I've just put here Tendyne, which is the commercially available device at the moment. And then this looks at measuring the neo-LVOT, which you can see is slightly larger always on its lateral aspect, and also measuring the distance between the hip of the Tendyne to the basal septum. But now we're talking about the Medtronic device, and we use a cone method for similar device simulation within that left ventricle. And again, we can measure the left ventricular outflow tract, and you can see it's like a crescent moon shape. And next, one of the big advantages of the Intrepid device is that it's a lot more generous with its LVOT cutoff. So you'll see that for Tendyne, the cutoff predicted neo-LVOT is 250 millimeters squared, or 2.5 centimeters squared. So this causes quite a lot of screen fail, because a lot of patients come in just underneath that, whereas you can see for the Intrepid device, the cutoff is 1.5 centimeters squared. So next. And the other thing, that there's actually quite a lot of correlation between the pre-procedural scanning for the Intrepid neo-LVOT prediction. Beforehand, we predicted it here at 1.6 centimeters squared, and afterwards in the same patient, the neo-LVOT was much wider than that. So actually, we are not finding that the LVOTs are smaller than we predict based on the pre-procedural scanning. Next. So just to the second half of the talk is to give the update, particularly for the Medtronic Apollo EU trial. So next. So the Medtronic valve is a conformable outer stent which anchors without leaflet capture. So it acts on some degree of radial force, but because it's a circular design, we don't need to worry too much about clocking the device and aligning it in a particular rotational alignment. You can see that it's got an outer circle and an inner circle. The inner stent houses a 27mm tri-leaflet bovine pericardial valve. And at the moment, it comes in two different sizes, so a 42mm and a 48mm. And as we speak, the 54mm device is being developed. So next. So far, there has been worldwide, the clinical experience is over 500, approaching 600 Intrepid valve implants, with now more than 200 of those implants being performed as transfemoral cases. And now we have good clinical follow-up in a vast majority of patients for more than 5 years. Next. So if we look at the design of the Apollo trial in general, it was specifically to target patients who are unsuitable for mitral valve surgery or for edge-to-edge intervention. And I think it's already been mentioned, but really honing in and looking at those patients in the red zone who are prohibitively complex for edge-to-edge intervention due to unsuitable anatomy, as I showed you at the beginning of this discussion. So the trial design itself is, of course, all patients do need to be assessed by the multidisciplinary team and decided that they are not good surgical candidates and then they've not got anatomy that is suitable for edge-to-edge. And when that is the case, there is a small roll-in subjects, only 2 or 3 per site, and then patients are either divided into the primary cohorts, while the patients who've got primary or secondary mitral regurgitation, or the patients who've got mitral annular calcification. Next. So the results from the initial studies, which was the transapical experience, which was predominantly pre the COVID pandemic, showed really encouraging findings insofar as there was, as we might expect now, predictable and durable elimination of mitral regurgitation immediately, and that was a durable effect up to 2 years. And that was associated with a reduction in NYHA class and an increase in KCCQ score, and indeed for a 6-minute walk test. Next. However, and I think this has also been talked about, because this was a transapical access, there was a fairly high mortality, which is pretty similar to all of the other transapical access for TMVR, with a sort of early post-procedural mortality of about 25% in the first 1 year, and up to maybe a third of patients had died within the first 24 months. And of course, some of this is early experience, some of this is selection, but a proportion of this will be the apical access route. And next. So based on that, the Intrepid transfemoral access route was developed. This is a transfemoral access that comes with a dilator and a 35 French sheath. The device is very similar to the knobs and buttons that are used in transcatheter mitral valve repair. So the multi-directional steering capability is present, and that allows us to treat a wide range of anatomies. The device, as you can see, is clearly visible easily on fluoroscopy and with 3D echocardiography, and you can see that this is a single stage deployment, so no need for any subvalvular pre-habit with housing devices. Next. So looking at the early feasibility study for the transfemoral system, looking at the first 33 patients, you can see that the overall clinical outcome was pretty good, with no all-cause mortality in the first 30 days, very low rates of rehospitalization, no rates of significant thrombosis, and about 12% of patients had new onset atrial fibrillation. And that was really the clinical picture, just slightly accentuated out to 1 year. Of course, one of the problems that you will see already is highlighted is the vascular complications with the 35 French sheath, and most of these patients were taking already anticoagulation for atrial fibrillation. So this is something that's a discussion point and has improved, but we maybe got time to speak about that at the end. Next. However, you will see a dramatic change in the Kaplan-Meier curves for all-cause mortality, so much improved all-cause mortality using a transfemoral route rather than a transapical system. And this, again, also underscores maybe potentially better screening and also maybe more experience with using the device. But this, 12-year mortality of 6.7% is excellent. And also what's really important is you can see at sort of less than 6 months, the all-cause mortality was 0. Next. Again, this is associated with durable and predictable elimination of mitral regurgitation within a couple of cardiac beats, and again associated with good clinical response in terms of reduction in NYHA class. Next. So the other things just to say is looking at the implantation itself. So the time from delivery catheter insertion at the groin to removal is only about sort of 40 minutes. So it's a very quick procedure. And again, a bit unlike edge-to-edge intervention, the imaging is straightforward, and the technicalities and the challenges are much less than edge-to-edge repair. You can see that why we need a 54mm device, because the vast majority of patients that have their implantation have got fairly large annulus at 48mm, and 75% of the patients with the ASD were closed, and this is another talking point. But you can see again that procedural outcomes were very good, with the 31 out of 33 patients having a successful implant, and one of the patients didn't actually have the implantation due to anatomical reasons. Only one patient was converted to surgery due to valve migration after deployment. So next. And so you can see, because of this sort of transformative engineering and clinical developments, there's been a huge majority change from transapical access into transfemoral access, and this has really increased the number of patients who have been available to, that have been capable of being treated. Next. Just as a talking point about the ASD closure, this is not always needed. In the early feasibility study, about 73% of patients were closed. Now about 73% of patients are not closed, and the considerations for deciding when to close really do depend on really the degree of shunt and really basically on how much right ventricular impairment or significant tricuspid regurgitation patients have. And this really becomes a little bit obvious at the time. Keep an eye on the saturations and you'll see patients desaturate, and I think this is a clinical indication for closing that device, closing that ASD. Next. So the update again is that we've got a next generation Intrepid transfemoral system. This is the 29 transfemoral system, 29 French, and the development, as mentioned already, of the 54mm device. The 29 French delivery system is streamlined, it's improved designed for improved steering, and it is a hydrophilic coating, so it's nice and smooth up the femoral vein. Next. And again, so now transfemoral delivery is now the only option for access route in the Apollo trial, and there's the Apollo expansion trial that is ongoing in the United States and America, and currently in Europe. We are enrolling in the Apollo EU study. Again, as I mentioned already, after discussion in the heart team, patients are rolled into either the MR cohort or after rolling, and also the MAC cohort. Next. So just to make sure everyone is aware, of course, the patients we're targeting are those patients that are unsuitable for mitral valve surgery or edge-to-edge. So those patients with significant mitral annular calcification, with mitral stenosis, calcified leaflets, or multiple regurgitation jets. These are the patients that might be suitable for the Apollo trial. Again, at patients with mitral valve anatomies that are associated with inadequate MR reduction, because really we're looking to get to mild or less MR with our edge-to-edge device. And if this is not predictable or thought to be possible, then you might be thinking about mitral valve intervention with a replacement device. And then, of course, if you can't really see what we're doing, we do need to see with echo, but we don't need to see the intricacies of leaflets, which are obviously a lot more challenging. Next. So this is an example of a patient who underwent the Medtronic Intrepid transfemoral system. She's a 79-year-old lady with severe mitral regurgitation and a combination of type 3B, but some type 3A anatomy. She was in NYHA class 2 with an STS score of 2.7. She was frail at 2 points, and the CAT score was at 6. She did have a reduced ejection fraction, but not less than 30%, mild tricuspid regurgitation, and fairly well preserved right ventricular dysfunction and mild annular calcification. She had no atrial fibrillation, no COPD. So next, on CT pre-screening, she had an annulus that fitted a 48mm device. Next. And so this is the procedure. So, we'll go back one. Brilliant. Thank you very much. So the atrial septum is required to be dilated with a atrial balloon, and we used a true balloon, in this case a 40mm true balloon, with the aim of being 4 centimeters above the mitral valve annulus. Next. When the delivery system is inserted into the left atrium, at least 5.5 centimeters of the delivery system needs to be present within the left atrium, and so there's nothing left in the right atrium. And at that stage, the sheath is retracted and the brim is exposed, and you can see the brim being guided on continuous 3D and X-plane imaging on the echo. Next. And so once you've got good stable imaging, the valve is then navigated across the mitral annulus and adjusted to achieve its appropriate position and alignment. Next. And then with rapid ventricular pacing, this particular patient was for about half a minute at 140 beats per minute. The Medtronic Intrepid brim is expanded and the position is confirmed, and the nose cone is retracted, and you can see that the device it expands in the atrium first and then finally in the left ventricle. Next. So for this particular patient, it's a good result. There's a well-seated Intrepid device with no transvalvular, no paravalvular leak. There is an ASD, but there is left to right shunt, and so this patient had good right ventricular function, so the ASD was elected not to be closed. Next. So I did mention that there is a MAC cohort. The MAC cohort is now in the Apollo trial. This is a recent not adjustment, a recent inclusion with this year. So you can now include your patients with mitral annular calcification. Next. And so just to describe briefly, 3 patients who had significant mitral annular calcification, we can see that one of the patients, the patient number 3, had an STS score of 27.7. Next. Including patients with low ejection fraction. So we can see patient number 2 had an ejection fraction of less than 40%, and also patients with moderate pulmonary hypertension are included with the mitral annular calcification. Next. And then we can treat a range of mitral annular calcification, and I would start asking I certainly ask our CT images to quantify the calcification score, so long as it's more than 750, capital A, capital U, would count as a significant mitral annular calcification. So you can see we've got a patient even approaching 8.5 millimeters squared of, 8.5 centimeters squared of calcification. So next. And this is the final result of all of these patients. So patient number 1 had a well-seated device with no transvalvular mitral regurgitation. Patient number 2, I'm thinking you might need to click the video, has got mild MR. Thank you very much. And patient number 3, that patient with the very high STS score, has got a well-seated mitral valve replacement with only trace mitral regurgitation. So next. So just to summarise really, the early results from the Apollo trial roll-in cohort using the apical version established that the feasibility of the device, but the delivery system obviously raised concerns with treating that high-risk population. And so based on those encouraging results, the Intrepid transfemoral TMVR system was investigated in an early feasibility study with good clinical results and good reduction in mitral regurgitation, which has appeared to be durable. And therefore, the patients now being considered for the transfemoral Intrepid are now registered within the Apollo EU trial, which is now enrolling patients for transfemoral system as the only access route for patients with primary, secondary, and mitral annular calcification. Next. So really, the potential transcatheter TMVR is, of course, it's less invasive than surgery. We do have predictable and durable elimination of mitral valve regurgitation. And it is a fairly straightforward procedure for patients, but for operators, particularly those who are used to transcatheter mitral valve repair, interventional cardiologists and imagers, as the technical challenges are much more straightforward. Next. However, just looking to the future, clearly there will still be patients who are ineligible for this device, and so it is incumbent on the clinical engineering company future to try and continue their efforts to develop a wider range of valve sizes with a smaller valve profile to reduce the risk of LVOT obstruction, and just to make sure that we have got compatible valve anchoring for patients with mitral annular calcification. Thank you very much for your very kind attention.
So thank you, Professor Duncan. So this was an excellent demonstration of a new technology. So it's been a while when the Intrepid program started. So there are some teething problems, I suppose, because of the access route. Maybe transapical it's not the best solution, as it has been shown, time and time again. So, but when you move to transfemoral, everything comes more easier for the interventional cardiologist. And if you manage to make the catheter smaller, so it's now 29 French, so this is even better. So, we're talking, when we had this interruption, so maybe, so it's, now we have an acceptance rate. You have an acceptance rate in Intrepid protocol of more than 30%, as far as I understand.
That's correct. That's correct. And I think, it depends on the center, obviously, because actually I really like the way the Medtronic screen, because we can pre-screen the screened patients. So it's not to dodge, but it also manages patient and clinical teams' expectations. So in order to screen a patient for Apollo, for pre-screening, the patients need to have a CT scan. And based on that, you can then help to understand whether the patient's anatomically suitable for the procedure, and then they go on to have the rest of the screening, because of course it isn't just about the anatomical screening, it's about clinical screening, about right ventricular function, about significant pulmonary hypertension, about risk of afterload mismatch. So, when we say the screen fail rate, it isn't only about the anatomy. The anatomy is a really important part, but I think the anatomy is like the front door, and then the clinical is the second door, and patients need to clear both of those two doors before they're accepted for the procedure.
Exactly. Maybe you should avoid doing a procedure that is too futile, in certain patients, right? So if you have a less than 20% ejection fraction in a patient with really bad 6-minute walking test, I suppose maybe that this is futile,
I think that we have become better at managing afterload mismatch and identifying those patients that are at risk of afterload mismatch. But nevertheless, if you look at those Kaplan-Meier curves, and we talk about, what happens at 1 year and at two years, but actually the steepness of the curve actually occurs within the first 30 days. And so this is about the peri-procedural management of some patients that are maybe too sick for the procedure, who either bleed or they have really bad LVOT, really bad LV and RV dysfunction, so that they develop afterload mismatch. And so really those clinical things, we didn't really get time to talk about them, but those clinical features of patients are much more aware now, particularly in the Apollo trial, who will screen out those patients where it's either futile or the clinical risk is too high.
So do you happen to have preliminary data on the mitral stenosis cohort? Is it, the results?
No. So it's the device is still not licensed for, or in the trial for mitral stenosis. No. It's for mitral regurgitation. If they happen to have mixed mitral valve disease, that they might get in, but it's not for pure mitral stenosis.
Yeah. Do you anticipate to have to be on the long run?
Yeah, the only trouble with mitral stenosis is, again, going back to anatomies, they tend to have fairly small annuluses, and they also tend to have fairly small left ventricles, so they may not screen past because of outflow tract obstruction. So it's quite unusual to get a big ventricle with mitral stenosis.
So there is a caveat. It's not like the radial strength of the valve or something like that. So it's the anatomy per se. So that's very interesting. So if I have, let's say, a patient that has a MAC, and now in Greece we don't have Intrepid, we try, but we don't have. So what your suggestion is, so you have a patient with a circular MAC, maybe someone could place a balloon expandable valve inside it. After proper, let's say, a thorough examination of the CT, what would you advise? Should I wait for Intrepid, or should we go ahead and do a balloon expandable valve?
I think the technical difficulties at the time of the procedure and the long-term or even the short-term outcomes for SAPIEN or balloon expandable valve in MAC is really very bad. About 60% mortality, within the first sort of half a year. So I do not think that this is a viable. It's good, maybe a palliative process, but it's not a viable long-term solution for patients in a mitral valve program. I think there is a device on the market that is commercially available that you could potentially use in MAC, but it's the same problems. So for the technical limitations of outflow tract obstruction and LVOT obstruction and a small LV. But I think if you can generate some desire within Greece or funding within Greece to join the Apollo trial, I think this will be very useful because, of course, that the commercially available device is transapical, and we're trying to move away from that, and we have got very much better results by going transfemoral.
So is that okay?
I would advise you to try and join the Apollo trial.
Exactly, that's what we are trying to do, and thank God for the responsible for this technologies here as well. So we have two comments, one from Dr. Vavouranakis and one from Dr. Kilman.
Thank you very much, Professor, for this excellent presentation. There is a trend, at least in some centers, and it's been advocated that maybe by putting through a surgical, minimal invasive, a balloon expandable, you might get, good results. I don't know what's your opinion or your experience in the United States.
Yeah, that's a great question. And actually, we do have experience of that. So we've had a patient who's had MAC, and we've had another patient who aortic stenosis and MAC. And both of those patients had an open surgical procedure where the SAPIEN is sewed into the mitral valve annulus slightly high. So it's maybe sort of 80-20, I suppose, 20% in the left ventricle, so that the risk of outflow tract obstruction is reduced. And actually, with the second patient who had a transapical balloon expandable device, the MAC was the valve in MAC was put in as a transapical procedure. So one was an open surgical operation, one was a transapical access. They both did okay, but I think you do need surgeons to buy into this as well. And you need surgeons that have got transcatheter skills, I think, to be able to understand about the outflow tract issues. But definitely it's definitely a consideration. But again, if your patient's not a surgical candidate or very high risk for surgery, of course you need to manage expectations of the patient and the team.
And Dr. Gilman?
Alison, thank you for the excellent presentation. I want to ask about the AST closure in the trial. 74% of the patients underwent AST closure after the Intrepid implantation. And how do you decide according to hemodynamic criteria, color Doppler, or did you use, for example, large balloons for the ballonatrial septostomy? Because in some, in tier studies, 24 French, maybe not an issue to close the all ASTs. So what's your opinion about this?
Thank you very much. So the 74% closure was in the early feasibility study. Now that we're into the global expanded study, is that the thought process behind that is changing, and less patients are being closed. unless, and that, I think that's partly because patients with very bad right ventricular dysfunction or torrential tricuspid regurgitation, certainly more than massive, are excluded, their clinical exclusion criteria. And so that feeling of needing to close the ASD because of right ventricular impairment or severe tricuspid regurgitation is probably less likely now that those are specific exclusion clinical criteria. So number one, it would explain to me why there is a change in clinical practice now to not close the ASD in the majority of cases. But to close it again, like we used a 14mm balloon in the case that I showed you. So the closure devices are available for that size. The ASD created afterwards may of course be a little bit bigger than that if the interatrial septum is stretched beyond that. But I think the hole that is made by the 35 French delivery system, and certainly another 29, are all fixable with closure devices. So we would make the decision at the time of the procedure based on the hemodynamics and the saturations.
Good, excellent. So, and now, okay, we have two burning questions. One, Dr. Spilias, and then we have
very quickly. This is more a question I have, about the future of the TMVR trials. Do you think we should liberalize a little bit the mitral leaflet modification in the trials, because it looks like one of the most common exclusion criteria is the anatomical neo-LVOT, or you think this would limit the enrolling sites to very few centers that way?
I think that both of those two questions are really helpful, and for sure the anterior leaflet modification would help to screen past a lot more patients. Number one, the clinical experience for that is not very high, and number two, if I may say so, I can't see who else is in the screen, but of course in the trial these will be off-label. These are not the current TMVR devices associated with anterior leaflet modification. They disassociate themselves from it because this is not part of their entry criteria and patient eligibility. So to have done this, so in a way you have to have your experience of doing this separate from the trial and separate from the sponsors, and that is quite hard because then you're a little bit renegade. But for sure, if it became something that was a little bit more experienced or accepted, and perhaps was done with a good deal of reproducibility, because at the moment it's a little bit unsure about how much to cut, how much to tear, how far to, and of course sometimes there has once or twice I know of a case where the leaflet modification has entered into the annulus, and that's caused a lot of disruption to the aorta mitral curtain. So for sure it would help, but at the moment patients who have this are not in the trials, and doing those within the trials is not allowed.
Exactly. Anyway, it's very difficult to replicate. So, and the final question is from Dr. Papadis.
Hi, thank you for the presentation. I just have a question. I understand there is no follow-up and there is no, we cannot predict the future, but what would you say about the negative remodeling of the ventricle? I mean, let's suppose that everything works well, the new LVOT is nice, and the regurgitation that used to exist doesn't exist anymore, the device is there, the new ventricle will have less, lower filling pressures, so negative remodeling could be actually what we wanted to achieve. So is this device going to stay there, cannot be squeezed? What is your prediction? What do you think?
Thank you very much. So yes, absolutely. We're looking for LV remodeling. And to that point, it's really important if you do perform TMVR that you carry on and engaging with your heart failure service, particularly in secondary mitral regurgitation, to continue optimizing heart failure medication. But certainly I have 10-year follow-up for patients with TMVR and never seen any device moving or the strain, no embolization, no migration, no new paravalvular leak. So I think these nitinol, as mentioned in the outer discussion, they're very conformable and they endothelialize beautifully. So no, I don't think that that's the clinical worry. I think more the clinical worry is, and I'm surprised no one's asked, is about anticoagulation because of the risk of bleeding. We sort of moved the risk of bleeding from the apex to the groin now that we've moved from transapical to transfemoral. But I think nobody really knows about the anticoagulation A type and B duration. But I think for these for this trial, we mandate 6 months of oral anticoagulation, and then C, but a minimum of that. But certainly, migration has not happened, and remodeling has happened, and it needs to happen, and you need to keep heart failure medication going.
Okay, so we have to leave it there. So thank you very, very much.
Thank you, and I'm
Dr.
sorry about the
Dangat.
technical difficulties.
No, actually, it was good. It was discussion provoking. Sometimes you need to take things from the beginning, as Medtronic did the device. So I think it's nice, and we enjoyed the discussion. It was very learnful and educative. Your presentation. Thank you very much, and I hope to see
my
you.
pleasure. Thank you very much.
Okay, thank you again.
Okay, so I think we're ready to continue with the next session. I'm Professor Pavouranakis, and Dr. Chapers is with me as a co-chairman, and I think it's a very interesting session because we all like valves, but there are other fields in structural heart disease where you actually need to have experience and take care of the patients that they do not have a valvular problem like an aortic stenosis. I would like to ask Professor Tsikas to give us his opinion. Why do we need LAO occluder? Patient selection. We all know that he's very experienced. He's been a proctor in this procedure. So I think we have postulated a great opportunity to see exactly the details about this procedure, step by step.
Thank you very much. Thank you for the kind invitation. Fortunately, I could not attend this time in Athens, but it's a pleasure for me to present on this meeting. It is very exciting. So I will talk about the indications for LLA closure, a few things regarding what's an update of what is going on right now in the field, and a few technical things. These are my disclosures. So this is the decade of stroke, hopefully stroke reduction, because this is a big health problem. And one of the main reasons why we need a local therapy like LA closure is that all the patients that we are treated with anticoagulation, the patients that we can really treat are not 100%. Plus, the cardioembolic strokes are the most dangerous and the ones that create disability. And there is always a problem trying to find a balance between the stroke reduction and the bleeding increasing, especially when we have to deal with elderly patients with atrial fibrillation. These are the patients that are most difficult to deal with. The left atrial appendage has been characterized as the most lethal human attachment, since more than 90% of the clots, the thrombus, originates from the left atrial appendage. And just a reminder that the first oral coagulation medication started as a rat killer, as a poison. Nevertheless, it helped a lot for decades. And now we have the non-vitamin K anticoagulants, which are not new, by the way. And they were introduced in the clinical practice as early as 2010, more than 15 years. But unfortunately, they didn't increase the number of patients that are taking it dramatically, just a little. And the main reason for that is the major bleeding episodes that patients experience, which is from 5 to 7% per year, which is a very big number, unfortunately. So even if in the well-controlled and randomized trials, patients is very disappointing, only 50% with adherence. So there remains a problem right now. And the question is, can we deal with this problem with new anticoagulants, the anti-11 factor inhibitors? There have been some promising first trials. However, recently the Oceanic AF study stopped because it looked like the drugs were safe, but unfortunately they were not so efficacious. So in stroke prevention, in atrial fibrillation, there is no free lunch, or as in other things in life. I mean, you gain something, you lose something. And right now, what is happening, as you see here in this publication with small series of patients in the United States, that the left atrial appendage occlusion has been included now as a therapeutic option for the patients that had bleeding and they cannot take anticoagulation. As early as 2016, we published this paper, which had to do with definitions and clinical endpoints. And in this paper, we have a big list of indications. Most of the patients have the indication of major GI or intracranial bleeding, major bleeding as a history. So this is why they cannot take anticoagulants for the long term. However, there is a group B, if you see here, of the patients that can take anticoagulation, but despite anticoagulation, they are not. They have a stroke, either with or without a clot thrombus in the left atrial appendage. And the recommendation from this consensus statement that was published again years ago is that patients who are suitable for anticoagulation should take it. For others, LA occlusion should be considered, and there are some patients that need to be discussed nevertheless. The guidelines, the European guidelines remain a 2B indication. The surgical guidelines are changing, and my information tells me that the European guidelines that are coming up, there is a high probability that this will increase to 2A now, following the change in the American guidelines that are now in 2A for left atrial appendage closure. And these guidelines, they were based mostly on this surgical trial, the Laos 3 trial, which showed that patients who undergo LA closure when they do a concomitant procedure, they do open heart surgery, and they exclude the appendage, they do much, much better in the long term. And this was a New England Journal of Medicine paper, so very, very, very robust data. Now, we recently published this practical guideline for the non-implanting physician, and this is a European mostly effort to show which are the possible potential indications. And you see here patients with hemodialysis, for example, patients with that major bleeding from GI, bleeding that we cannot control otherwise. There are some issues with adherence. What I would like to draw your attention here is this intracranial and intracerebral bleeding with the microbleeds that patients sometimes have in their MRI. Plus, this second group of patients where there is ischemic stroke despite optimal anticoagulation with or without clot thrombus in the deeper side of the appendage. And this is an algorithm saying that in every patient that we consider for AF and give anticoagulants, we need to consider the bleeding risk always. And if we see that this patient has a prohibitive bleeding risk, he should be discussed for LA closure, as we see here. Now, even the neurologists in this very nice registry, they say that up to 43 centers, they think and they believe that the patients who had a stroke on anticoagulation, these are the non-responders, let's say, there is no meaning to change one medication to another. This doesn't add anything to their therapy. And they consider these non-responders should be considered for left atrial appendage occlusion. Even there is a lack of data about the benefit of this procedure because basically there is nothing else to do with them. So these are non-cardiologists, these are neurologists and experts. So I'll go to a few technical things, just a few. The characteristics of the appendage, it has enormous anatomical variability. This is why we need imaging. We need a lot of imaging to do it properly. It is a delicate cardiac structure. You can have complications if you're not careful. Plus, you need to do a transeptal puncture in the proper position, and sometimes this is a barrier, especially for people who are not used to it. So this is the two mostly used devices, the Watchman Flex device, a very good device with a single, let's say, plug configuration, quite automatic. I've started using that very recently, a few months ago, but I think it's a good device. I'm seeing here how the device is opposed and how it closes the appendage. It has to be implanted in a proper, optimal way. We'll discuss that. Plus, now we have the other dual layer closure devices like the amulet or other devices. When we consider maybe have less peri-device leak. Now, in 2016, I was asked to give this lecture about the general principles of LA closure in TCT. And at that time, we were mostly concentrating on avoiding complications. We do need to know the patient, which means indication, anatomy. We need to master the technique, and we need to know the device. So right now, the trend that is happening is technology and therapy. We need to perform an optimal closure. And this is, it may be easy to implant the device. I don't know if you can hear me. I hope I don't have breakdowns because there is a message from a computer. So there are two important things that we haven't solved. One is the peri-device leak, and the second is the device-related thrombosis. This reminds the TAVI era. Now, for the peri-device leak, we believe that, and this is an example of a leak. This is an amplexed device, amplexed cardiac plug. You see the communication here. So, and this is a leak from the Watchman device, Watchman 2.5. You see here that there is an opening. So at the beginning, people believed that these leaks were benign and nobody should worry about it unless it was half centimeter large. But recently we have seen that these leaks correlate with outcomes, bad outcomes. And we recently published this paper which took data from many studies up to 62,000 patients. And we found that any leak of 3 millimeter and higher is not benign, it's bad. In a similar to TAVI, I would say. More than mild AR was a predictor of mortality in the early days of TAVI, and we tried to fix that. So how can we deal with that? We need to do more coaxial placement of the device, maybe some larger device, or we can have more than one device type in the cath lab. Not all devices fit everybody. And what is very important is the CT planning. If there is a PDL, we should maybe, if we see the follow-up, we should close it. Now, the second topic is the DRT, the device-related thrombosis. And this had to do with definitions partially. And some papers that you see that has a very high numbers of DRT, they didn't know how to define it. On the left side, you see normal healing of the device. On the number C is a thrombus, but it's maybe not high-risk thrombus. And then here you have a very high-risk thrombus. So the trend now is to categorize the DRTs. And a way to mitigate DRT is similar again to TAVI. The depth of implantation of these devices should be lower. And we have seen that if we implant the device more proximally, the patient will better. Now, what about thrombus in the distal part of the appendage? Should we close it? It depends. Are there other options? I mean, with the patient, we try all medication, the abstinence, etc., etc. Is the thrombus distal or proximal? And again, it has to do also with the operator experience, and the patient should be informed. For example, there we have a distal thrombus that is seen on CT. This patient had continuous strokes on any anticoagulation. And then we went with an amulet device, the single visit technique. We occlude the appendage in the presence of thrombus, taking some small risk, of course, but there were no other options for this patient. So this is not an absolute contraindication, it just has to be done carefully. Now, 1 minute just to show you the most important studies. The Champs-on EF and how this thing goes says that we have all-comer studies, not leaders, all-comers, all patients with atrial fibrillation, randomized to the Watchman Flex device versus the NOACs. The study was ended enrollment 2022, and we'll expect results in 2 or 3 years from now. So we need to be more patient. Another study by Abbott, similar design. Enrollment is slow in this study, but again, people now we're aiming to patients that don't have issues with medication, so no contraindication to NOACs. And the last one, this is coming soon. In AHA, it will be announced in AHA in November in the US. And this is the option trial. It's a combination of AF ablation plus flex implantation versus AF ablation plus NOACs. So again, large patient study and the pool of patients that can be treated in the future. We did the first in Greece in Hippocratic University in Thessaloniki. It took us approximately 1.5 hours for both procedures. Very easy going with Professor Pagakis. And the last slide, just to give you an idea about the market trend. The market in TAVI is larger, obviously, and there is a growth of 10% a year. The market of LA closure is smaller, but the growth is double. So there is there are a lot of things to happen in this area, and I think it's very nice that you include it in this fantastic congress of yours. Thank you very much.
Thank you very much, Apostolis. I think we're going to proceed, and then we'll have a discussion with the comments if we have time. Okay.
Okay, and now we will proceed to Dr. Giannini from Milan, Italy. I think he has to be connected.
Good afternoon, everybody. I hope you can hear me very well, and I hope you can also see my slide. Can you confirm it?
Yeah. Yes, of course. Okay, you can go ahead.
First of all, many thanks for the kind invitation. I'm very sorry for not being able this year to attend the Congress in person, but anyway, it's a pleasure also to be remotely connected with you. Many congratulations to Professor Tsikas for a great presentation he had. I will try not to have too many repetitions with my presentation. I have no conflict of interests. So which are my goals when I have to perform a left appendage closure procedure? First of all, I want to have a safe procedure, and to be practical, I want to have a proper anchoring of the device, avoiding potential device migration or embolization. At the same time, I want to avoid any potential damage to the LAA structure and the surrounding structure resulting in pericardial effusion or pericardial tamponade. At the same time, we have already seen it's crucial to have a good final result that actually means try not to have a residual leak. Also, minimal leak may have an impact. And this is important because this really may have an impact on long-term patient outcomes. And the safety and the efficacy of this procedure is much more important if we think that the volume of this procedure has been growing in the last few years, and maybe we have seen something in the previous presentation. We may deal in the future with novel indication, and we may extend this procedure also to other subgroup of patients. What is the real key point, key step of the procedure is to try to have a good imaging-based pre-procedural planning. We know that the morphology of the LAA structure may be very variable. There are several classifications. The most utilized one identify 4 different type of morphologies. So the windsock, the chicken wing, the cactus, and the cauliflower. But we have other morphologies that do not fit in this classification. Typical example are the fishtail morphology that you see here on the top right of the monitor, and the inverted chicken wing morphology. We need, with our pre-procedural planning, that has to be imaging-based, and we know that in most of the centers is still performed by utilizing transesophageal echo, not only to evaluate the LAA structure, but also to evaluate the surrounding structure. We need to record of any fluid into the pericardial space, to have a reliable comparison with the baseline in case of occurrence of pericardial effusion after the procedure. We need also to assess the mitral valve, especially if the patient underwent a previous surgical or percutaneous mitral valve repair and replacement. We need to evaluate the position of the pulmonary vein, the position of the Coumadin range, the relationship with the pulmonary artery and the distance between the pulmonary artery and the LAA structure. And we also need to have a look at the interatrial septum to see if there is some aneurysm, to see if it's too floppy or too stiff, and to identify the perfect site for the puncture and the crossing with our delivery system. Of course, we need to exclude the presence of thrombi in our LAA structure. Sometimes it is quite clear because they are very evident, like you see on the right of the slide, but sometimes it's not so easy, and our echocardiographer needs to find the right view to identify also poor represented thrombus in the very distal part of the left appendage, as you can see here on the left. What is another crucial step in the pre-procedural planning is the sizing of our LAA structure. Actually, we need to take 3 main measures that are the ostium, the landing zone, and the depth. And this measure needs to be taken at 0, 45, 90, and 135 degrees. But the way also how we measure and how we take this dimension is different with a different device that we may utilize. Why? Because as we have already seen, taking as example the 2 most utilized ones, the amulet and the Watchman device, they work creating a ceiling at the LAA structure utilizing completely different principle. And this is why with the amulet device, we need to measure the true ostium. Let's call it the anatomical ostium, that is this blue line on the left side of the slide. And then we have to go 10 millimeter in and measure the landing zone, and of course also the depth. In case we utilize the Watchman, we have to measure the ostium in a different way. I would measure here on the left the ostium going from where the circumflex artery appears to where the B letter is standing, and on the right in a different view, in this different view, probably just in the middle between the blue line and the yellow line. And I'm not a big fan of just taking measurement at the landing zone and at the anatomical ostium. These are three different illustrations of potential cases with which may deal, in which we have the exact dimension for the LAA ostium and the LAA landing zone, but we have three completely different shapes. If we take the one in the middle, that probably may be applied to most of the anatomy with which we deal, and we select, for example, an amulet 25 millimeter for this specific LAA structure. For the one on the right, I would probably go with a larger size device, let's say a 28 millimeter, just because the distal part of the left appendage is much more represented and may accommodate a larger lobe, a larger distal part of the device. Vice versa, if I have to size my device in the left structure in which there is a very narrow shape and the distal part is very poorly represented, I would probably select a smaller device size just to avoid a jump of the device back during the deployment, just because there is not enough distality. So it's not only a matter of measuring the landing zone and the anatomical ostium, but it's more like to have an idea of the wall dimension of the left appendage in different levels. And here we can understand why the transesophageal echo is not probably the most accurate way for the pre-procedural planning. Ideally, the CT scan should be performed in all our patients. We know that logistically this is not easy, but here you can see also if we take all the measurement in all the suggested view at 0, 45, 90, and 135 degree, we can miss the maximal diameter at both level, at the ostium level, at the landing zone level. So the CT is definitely most accurate for the LAA dimension measurements, but is not only important for that, it can really provide much more information. For example, if you see on the right, on the top right of the monitor, by analyzing the pre-procedural CT, we can identify the best, let's say, a fluoroscopic view in which we can implant our device. That is the fluoroscopic view in which we have the anatomical ostium and the landing zone in a line. They are not overlapped, and we can see also the distal development of the left appendage. At the same time, the CT can provide a three-dimensional overview and the orientation of different lobes. This is something that we cannot have with the transesophageal echo, but it can also suggest where is the best site to perform the transeptal puncture, the site that guarantee the perfect alignment with our delivery system for the deployment. And in case we are used to work with the CT fluoroscopy fusion, the pre-procedural CT can be utilized also for this. At the same time, there are different softwares that allowed us to simulate implantation of different devices, implantation of different sizes, and to evaluate the degree of compression of the device and the ceiling that we can reach with a specific device and the specific size. And this can help in selecting the best device and the best size for the specific anatomy of the patient. Coming back to the step-by-step procedure, I prefer always to perform an echo-guided puncture. I prefer also to utilize a single ProGlide like I do with all the transfemoral vein approaches procedure, being ready to administer half of the dosage of heparin soon after the position of the perclosure. And then after the advancement of the delivery system, it's important to identify the best site for the transeptal puncture. We know that is a general rule that the puncture needs to be inferior. This is true. And in most of the time, let's say 80–85% of the time, it needs to be posterior, but there are some situations in which it's better to have a slightly more anterior puncture, and this is especially true in morphology like the inverted chicken wing. anatomy. In this specific case, the puncture was definitely inferior, was relatively posterior, but you can see here that there are some anatomy in which it's better to avoid the posterior puncture, and the typical example is the inverted chicken wing anatomy. Coming back to the case, here you can see in the angiographic view, in the two ones that are usually considered the standard view, RO 30 degrees, cranial 20 degrees, RO 30 degrees, and caudal 20 degrees, we can see how our delivery system is well aligned with the ostium of the left appendage. In this case, the measurement, the landing zone was 21 millimeter, utilizing the fluoroscopy. In the same case, the landing zone utilized the transesophageal echo was quite similar. There was a very good concordance that we not always see. Here was around 22 per 24 millimeter, so it was not so elliptical as we typically see. And we decide to utilize an amulet device. I would also like to spend a few words about the basic of this device. So actually it has two components, a proximal disc. In the distal part we have a lobe. In the distal part of the lobe we have stabilization wires that actually help to anchor our device. And the lobe, when the device is implanted, tends to pull the disc, and the disc tends to pull the lobe, and this is how the device stability is actually achieved. In our case, the landing zone, there was a mean diameter of 23 millimeters, so you can see here, looking at the sizing chart, that the optimal device size for this case is a 28 millimeter, for which is 14 French delivery system is required. So mainly the size of the device is based according to the landing zone, not to the anatomical ostium, but of course we have to take in consideration also the anatomical ostium. And how this device is implanted, the amulet one that I prefer to utilize in this specific case. So when we are outside of the LAA structure, we have to advance the deliver, creating a ball. Then once the ball is created, we can advance our delivery system inside to the LAA structure, most of the time with a counterclockwise rotation to get better coaxiality with the left appendage. And then once we are at the landing zone level, we have to advance the system, advance the device. By advancing the device, most of the time the device does not advance, but just we create the lobe. And then we have to perform an unsheathing to release the disc and to push the disc against the anatomical ostium of the left appendage. And then the tag test is required to confirm the stability of the device. And here I was already in this case very well aligned, so I created lobe already inside the LAA structure. Then I pushed the device to create the lobe. Here you can see the lobe coming, and then I just deployed the disc by performing an unsheathing of the device. And you can see here angiographically with the injection of contrast, the final result without leaving any residual leak, and this patient was just discharged the day after the procedure. And you can also see here how is clear the compression of the lobe, and this is one of the main sign to get a good anchoring of the device. Other sign as the fact that we have a lobe that is at least 2/3 distal to the circ artery, the fact that we have an orientation of the lobe that is in line with the axis of the left appendage neck. We need to have a separation of the lobe and the disc is always have this elliptical shape that actually is the sign that is creating a ceiling at the level of the anatomical ostium. So I would like to conclude here my presentation, just summarizing the main concept. The imaging-based pre-procedural plan is definitely the key step to get a successful procedure. We know that the pre-procedural CT scan provides relevant advantages compared to work only with a transesophageal echo, but we have also to say that it's not necessary, and still in most of the centers is not routinely utilized in the pre-procedural planning. The transseptal puncture, of course, should be performed taking in consideration the LAA morphology and its orientation, and if we cannot get a good alignment with our delivery system, we have to be ready also to reconsider to make the transseptal puncture in a different site. And of course, any device has its own characteristic. I mainly focus my presentation on the amulet that was presented in the case that I showed, and but there are many other devices, as we have already seen, and we have to know all the features of the device and all the related technical aspects. Thank you for your attention.
Thank you so much for your clear presentation. It is quite clear that this is a delicate operation, and of course it is necessary a very well preparation, as you said, very close cooperation of echocardiographer and the invasive guy, and also all the team has to know every detail of the operation and the anatomy of the structure.
Thank you very much for this presentation. Just a very quick question, because you know, in the field there are a lot of devices coming out. For example, we had this CSI, we saw an Omega device. Do you think these devices will, by changing the behavior of the occluder, might facilitate the procedure, you know, position and all this stuff, you know, that so they're kind of self-alignment, you know, regardless of the angulation? What's your opinion?
Yeah, in regard to novel devices, I think that some of them are actually very similar to the two principal ones, especially the Omega, I think, is quite similar to the Amulet one. Probably in my clinical practice, sometimes in specific anatomy, I prefer to utilize device like Lambre, in which you may have special sizes, in which you have different sizes of the lobe and the disc, and you can easily anchor the device in anatomy that I would consider otherwise challenging with the, let's say, more common devices. So for your specific question, probably the Omega, I'm not sure that adds something more to the Amulet device, but other devices like Lambre with special dimension of the disc and the lobe can be useful in specific anatomies.
Thank you. Yes, there, Professor Kilic.
Hi, Francesco. I'm Theo.
Hi, Theo.
I want to ask a question, especially about the point that you mentioned about the transseptal puncture. The classical point is that the inferior posterior puncture, but in some kind of anatomies like reverse chicken wing, what will be your transseptal puncture point at that kind of reverse chicken wing anatomies?
Yeah, when I deal with these, let's say, not so common anatomies, in which probably the typical inferior posterior puncture should not work, I always try in my hospital to perform also the CT, and then I try to identify the specific site of for the puncture by using the CT. When this is not possible because we work in real life, sometimes logistically it's also difficult to have the CT available before the procedure, or let's say that simply the patient do not have has some renal dysfunction and it's better to avoid also contrast injection. I always to try in this case to be not posterior, let's say relatively more anterior. Being ready if I'm not satisfied once I see the alignment of my delivery system, if I'm not satisfied eventually to, instead of trying to implant the device also if I'm not aligned, to do the puncture again. What I learned from some complications is that sometimes it's better if you try to deploy the device a couple of times, this doesn't work because you are not completely aligned, to do the puncture again. But when it's possible, I always prefer in anatomies like the reverse chicken wing morphology to do the pre-procedural CT and then to identify the right site for the puncture by analyzing the CT.
We have two more questions, I think. Kostas Kalogeras, Professor.
Thank you for the great presentation. Just a quick question regarding the way you assess any potential residual leak before you release the device. I understood, if I understood well, you assessed the leak by the angiography or the TOE, and how does it affect your further decision? Do you reposition the device? And how do you assess the severity of the leak? Is there an amount of leak that you say, okay, I will release it, or you want just no leak at all?
I don't know if you hear the question, Dr.
So let's say that maybe this was not clear in my presentation, but I always assess the final result before the deployment with both the angiographic injection and the transesophageal echo. But mainly, I'm guided in my decision to accept or not accept the final result by the transesophageal echo. Now we know, also looking at the data that have been just presented before my presentation, that also a minimal leak can be a problem for our patients. So we have always to try to get the optimal final results. Sometimes that's not possible, and it needs to be a balance between the risk of trying to deploy the device again and again, and the fact that you can accept it or not. I just had last week a very bad case in which there was a patient that previously underwent a mitral valve replay with mitral clip, and there was a residual regurgitation that was completely eccentric, directed exactly against the left appendage. So I tried to reposition my device 2-3 times, but finally there was nothing to do. I had to accept this not optimal good result because the jet was just against the LAA and was just, let's say, behind the disc of the device. So I had to accept. Sometimes we need to accept the not optimal result.
I think we're going to proceed because I think for the sake of time, okay. So the next, I see Dr. Niktari also, for whom we will ask comments after the next presentation. We have Dr. Vrachliotis, who is the imaging expert in neonatology. And I think, I have also, since I'm doing a lot of PVLs also, I have a lot of questions regarding the imaging that you get.
Fast because
okay, so.
Well, this is going to be a short talk in any case.
Okay,
because,
let's hear. Okay.
Okay, so thank you for your kind comments. Dr. Iacovo, thank you so very much for inviting me to this outstanding meeting. As Dr. Vavoranak said, he's doing lots of paravalvular leaks, so I suppose some of the images are going to be familiar to him, especially if at his hospital radiologists are doing the appropriate imaging with the appropriate CT scanner. I have nothing to disclose. And prosthetic heart valves, are devices that were first implanted in the United States in 1952 by Charles Hifnagel. And as everything that is inserted in the human body has a tendency to be rejected, the human body has two nice attributes. One is it doesn't like putting mechanical or foreign bodies inside, and second, whenever there's a hole in the body, it tends to close it with fibrous tissue. So consequently, when you put a heart valve in, complications may arise, and some of them are dysfunction, dehiscence, endocarditis, thrombosis, pannus formation, pseudoaneurysm, abscesses, and PVL, which is the topic of my presentation. What is a paravalvular leak? It is abnormal flow through a channel between the valvular prosthesis and the native valve annulus due to inadequate sealing. In other words, it's something that shouldn't be there. It is characterized by inappropriate apposition of the prosthesis ring to the native tissues, and this leads to perivalvular regurgitation, and unfortunately, it's a relatively common complication of both mechanical and bioprosthetic valves, slightly with a greater preponderance in the aortic valves compared to the, in the mitral valves compared to the aortic valves. The most important statement in this slide is that the most common cause of PVL is endocarditis-induced dehiscence. And interestingly, PVL can be seen in the absence of definite signs of dehiscence owing to alteration of the normal geometry between the valve and annulus, and that's induced by anatomical and hemodynamical changes of surgery. PVLs are common, 55 to 20% immediately after implantation, especially in the mitral position. And most patients with a small PVL go asymptomatic or even undetected initially until mild hemolytic anemia may kick in. However, large PVLs are seen in less than 1% of surgeries, and those can result in heart failure, severe hemolytic anemia, or endocarditis. And this is schematically how a paravalvular leak looks like. We have two chambers, two lumina. North, we have the aorta, and south, we have the left ventricle. You see the implanted aortic valve, and next to it, you see an S-shaped ribbon, which is the leak. And you have a very nice coronal reformation of, in a CT scan, where next to the aortic valve, which is dehiscent, you see a connection between the aorta and the left ventricle. Now, how do we diagnose PVLs? To begin with, maybe far and foremost of importance is the clinical history and clinical findings. That's hemolytic anemia, heart failure, and endocarditis. The first imaging tool is echocardiography, and transesophageal echo is the gold standard. And when it comes to CT, you have to see a contrast-filled channel in the paravalvular region that connects the two luminal. Now, as you will see further down, you have to have a clinical suspicion. So please, when you're suspecting a PVL, let us know that there's a questionable PVL in the CT scan that you're about to perform and read, because maybe the most interesting part of PVLs and CTs, no matter how good they are performed, is that they are very, very easily missed. Of course, you can do MRI, but MRI has a lower sensitivity, mainly due to the artifact, and MRI cannot image in a volume like CT does, so the performance of reconstructions in double oblique planes is rather limited. But if you do it and if you see it, then it's there. Now, as I mentioned earlier, 3D transesophageal echo is considered the gold standard of reference for evaluating PVL, and again, what you're looking for is a contrast-filled channel in the paravalvular region. Now, this is a rather extensive technique of how it is done. Again, the most important part in the technique is clinical history. You have to do, of course, a gated scan, and all the other parameters that you see here are just details that we can take care of, radiologists, I mean. So here are some examples. Up and to the right, you see, we see a jet as seen by ultrasound. On the left-hand side, we see the channel. Do we have a laser pointer by any chance? Lovely. Okay. So this, okay. Over here is the channel. That's the PVL. And over here, it's a much smaller channel. That again is the PVL, but this is very, very easy to miss. Even if, as you can see, it's a targeted image, the radiologist who did this examination knew where he was going, knew where to look. Despite that, it is very, very easy to miss this little channel. Again, here we have an image of a PVL in a mitral valve before and after therapeutic intervention. This is one of our cases. This is the left atrium. This here is the left ventricle. This here is the valve, and here is the channel that connects the two lumina. This is the channel. This is the PVL. Okay? That same patient in views that took some time to perform and construct. You see this crescent-shaped white area? This is the PVL. This is the PVL. And this here is the prosthetic valve. This here shouldn't be there. Again, we can perform measurements in double oblique images. Same here, same here. And when you report those PVLs, you have to follow a standard. In radiology, when we read images, we read them as if we're viewing the patient from the feet, from down up. When you are reading images in transesophageal echo, you read them from what I have read the other way around, as if you're viewing the patient from head to feet. So the images are flipped. So this is the image that was, sorry. So this here is the image that is flipped, and this is the initial image. With artificial intelligence and reconstructions, we can also perform casts, three-dimensional casts before and after interventions. Here is another PVL, okay, right here. That PVL was closed, was sealed with coils, and here's a cast of the coils after intervention. This is what I meant earlier when I said that it's very, very easy to miss. This is a case that was done a couple of months ago at our institution. Personally, I read it as normal. And then Dr. Athanasopoulos came to my office and said, I remember a case I told you a couple of months ago, so yada, yada, yada. With Dr. Iakovou, we had just finished reviewing it, and you know, then everything started falling in place. And as Dr. Athanasopoulos was telling me what happened, my hand was performing the three-dimensional reconstructions, and when I reached this image here, He said, yes, there it is. So this here is the prosthetic valve, and this here, between 1st and 4th o'clock, is the PVL. And in order to conclude, most important thing is history and clinical suspicion. Think about it. Have a high index of suspicion. Know what you are looking for. It is very, very easy to read an abnormal CT as normal. The first imaging examination is echocardiography with transesophageal echo, the gold standard. And in CT, what you need, the sine qua non, is a contrast material filled channel in the paravalvular region that connects the chambers proximal and distal to the valve. And again, it is very easy to miss. Thank you for your attention.
Thank you very much for a very precise and excellent presentation. Just a couple of questions, since you know that is actually common in the practice. From our experience, we have also Tao, who is very experienced also too. I mean, for mitral, we rely mostly on the transesophageal echo during the procedure to see what we're going to do. But for the aortic, it's very useful if you have given us some indication by CT what angulation could be precisely, you know, imaging the exact position of the leak. And my question is, a lot of the times, all the angulations that you as a CT analyzers provide, and operators provide me, do not reflect what I am seeing in the cath lab. And the question is it position of the patient? Is it because sometimes it's hard to see exactly where the leak is? And why is this discrepancy? I don't know if you notice that discrepancy is also, Yanni, in your institution, but this is something that I do. And this is the reality. And the question comes also because talking to different meetings, you know, is that, well, we don't have the SPECT CT, which theoretically would image some flow. So it's nice to see your opinion, why this is happening.
Do we have PVLs?
Well, we have, but we have a multidisciplinary team in our center.
I've noticed that.
And we always consult Dr. Vrachliotis in the heart team and Dr. Nichteri from time to time when we deal with the complex situation. But of course, we have the echocardiographers as Dr. Chaparas, Dr. Anthropopoulos. For instance, in this case that you just very nicely showed. So we were dealing with two failed rings. One heart ring in the aortic valve that we did TAVI, and another failed ring in the mitral position, a semiform ring, 32, so with paravalvular leak, which was not evident in the 3D printing that was based on the CT, but we had to rely in the TOE images that we show clearly that it's a paravalvular leak, you know, on top of the central leak that it's due to the rupture of the neocordi. So we were planning to do a paravalvular leak closure based on the TOE findings. Yeah, so this is really interesting.
John, my question is whether the angulation that they are giving you, because you are giving angulation, is that right? The appropriate angulation to approach aortic paravalvular leak, for example. You do give them.
Of course.
Yes. Do they correspond in what you're actually getting in the cath lab?
You have to make them correspond.
Well,
you
make
know
them.
What you're looking for, and it's something that you must be doing quite frequently. So there needs to be some experience. You mean to go in appropriate double oblique images in the aorta, you know, image that much sagittal, that much coronal, that much.
Yes.
Yeah. Well,
I mean, that's what I'm asking. They correspond.
Yes, so maybe we discuss with the echocardiographers about, you know.
Because this is different. The echo shows it clearly. I don't know, Theo, what is your experience? You get it appropriate orientation? Because
I fully agree that for the mitral paravalvular leaks, real-time 3D transesophageal echo is very, very important compared to CT. For the mitral leaks, we never use
I do.
CT. But for the aortic leaks, transesophageal echocardiography also give nothing, really. If there is a large leak, T shows suspicion about paravalvular leak. And for me, many people also think that aortic paravalvular leak closure is an easy procedure, but some of the course of the leak, like the S-shaped, double S-shaped leaks, it is very hard to put the device. You can cross the leak, but our selection of the device and the results are sometimes not satisfactory. In that kind of leaks, CT can be really useful. That for me, CT is very useful for the aortic paravalvular leaks, especially course of the leak. If it is, for example, double S-shaped type 1, type 2, and the terminology also is different, and I will give some examples in my presentation in aortic paravalvular leaks. Where the leak is, for example, the clog formation is different in some publications and in another publications.
And I think the example you showed
So CT is very important in that kind of situations.
The example that you show clearly show a leak that was coming down and then became horizontal, and that's very difficult when you try to position the device that will not actually, sometimes you will not close the leak and you have this perpendicularity. We have Dr. Nectari next to us. I don't know if, yes.
Complete, I think, the answer you.
So, I don't know if you hear me.
Okay.
Dr. Nectari should make a comment, I think, or not?
So, first of all, congratulations to all the presenters for the high quality presentations they made. I think going back to your question is that probably echocardiographers who are working very close with interventional cardiologists who put prosthetic valves, Transcatheter, are more familiarized to what you need. Because I find it difficult that a tomographic modality like CT or even MRI cannot accurately give the angulation and the course of the leak. It depends on the reconstruction you want, and probably this is a communication failure between us and you. And as it applies for everything in life, the best modality is the modality that is more accessible to you and you have been more familiarized to. To make a comment on the value of cardiac MRI, because I'm performing cardiac MRI the last 10 years, I have to say that it is an option in frail patients whenever you want to avoid radiation or contrast. It can give you by using a 3D data set from a single sequence, it can give you all the data to reconstruct at any available angulation or plane. And I think most recently there was an interest on how to quantify the paravalvular leaks, and it seems that the echo underestimates in some cases, difficult cases. So CMR is promising on quantification. And especially in the aortic valve position, it can also give you anatomical data because you can image the entire area and then take the plane where there is no artifact and quantify and visualize the leak. So we are a very good optional choice, and expensive and not that accessible, but we can do it. But going back to your question is probably a communication fail between the two teams, the imaging team and your team.
Okay, well, thank you very much. I think we're going to proceed for the next case. It's a great pleasure. May my co-chairman will introduce you.
to introduce Professor Kilic from Turkey, an experienced guy on invasive cardiology, to talk us about when to close and secondly, how to close.
First of all, I want to thank you very much for Yannis Yakovi and his team for inviting me this important Congress. And also I want to underline that I always feel myself in my second country when I come to Greece because of their nice and kind hospitality. I want to speak today about paravalvular leak closure. How do I do it, and tips and tricks for mastering. These all was discussed, but it's a serious complication from surgical and percutaneous valve replacement procedures, and more frequently after surgical mitral valve replacement compared to after aortic valve replacement. And the symptoms are dyspnea, left ventricular enlargement, but heart failure, symptomatic hemolytic anemia. And the heart failure and the hemolytic anemia are the main indications for the closure of paravalvular leaks. When we look at the current techniques, there are two main techniques, surgical and fully percutaneous. The surgical one is the open heart surgery. The other one is the surgical transapical closure, and some of our Chinese friends, transatrial closure. But the fully percutaneous approach is very, very important for the interventional cardiologist, and the antegrade transseptal, retrograde transfemoral, and the percutaneous transapical. But for me, percutaneous transapical is not a good option, and also it requires a surgical skills and also hybrid room, and has a lot of complications when we look at the surgical transapical approach. So to learn antegrade transseptal and retrograde transfemoral techniques are very important. So before paravalvular leak closure, an interventional cardiologist must first understand the mechanism of paravalvular leak development, use the appropriate imaging method for the localization, shape, and diameter of the leak, select the appropriate device, determine the appropriate crossing and closure method before the procedure, use appropriate crossing and closure equipments, and be aware of complications. So we learned these lessons from a lot of our cases, since we are a referral center for paravalvular leak closure in our country. So we published this with European Paravalvular Leak Group, our family, and Manol is also in that family, in Journal of Clinical Medicine, and also the circulation predictors of clinical success after paravalvular leak closure. So mechanism is very important. Why paravalvular leaks are developed? At these 2 points, one is the anterior region and the other one is the posterior medial region. Because after mitral valve replacement, the physiologic movement of the annulus change and antiphysiologic movement occurs, posterior contraction and anterior tilting occurs, and these abnormal movement causes abnormal force on the 2 hinge points. This is very important, especially for example, when we close the leaks in some our cases with appropriate methods and devices, 1 or 2 years later, maybe, another residual leak or another leak across to these areas can be seen, and this can be one of the accused mechanisms of recurrent paravalvular leak after transcatheter paravalvular leak closure. And the other one is mitral ulnar calcification. Is highly seen, especially in elderly persons in the posterior medial region, and is far from surgical eye. This region is near the circumflex artery, thus surgeons use superficial sutures in this area, and the fibrosa, the central core, and the lowest in the posterior medial region. So it's very important that these 2 points are very, very important for the mitral paravalvular leaks. So defect localization is very important. So this is the clock method according to the transesophageal echocardiography, and the anatomical localization also, the surgical point that where the aortic valve is present at the 12 o'clock clock, and the left atrial appendage 9 o'clock, and the septum is 3 o'clock, and just opposite of the 12 o'clock, the 6 o'clock, the posterior region. So, but when we look at the fluoroscopy on the left anterior oblique position, this is just a mirror image of the transesophageal echo. So it is very, very important to know also left anterior oblique caudal view for evaluating the, especially where we cross, for example, where we cross inside the leak or inside the valve, or also very, very important to evaluate the impingement after device implantation. So 2D transesophageal echocardiography is still important because you can see the color Doppler, and when, for example, these 2 points are A, B, C, D, E. For example, D is the left atrial appendage. You can easily see the two-chamber view on the 2D echocardiography where the leak localization at the left atrial appendage region. This is a combination of the 2D echocardiography, but the 3D is the gold standard because you can see the where aortic valve is, where anterior region is, where anterolateral is, where anteromedial, and where posteromedial. Here is the medial region, septum. Here is the left atrial appendage, and there is a posteromedial leak, as you see here. And the opposite, I mean the direct fluoroscopic appearance where the anterior and posterior leaks are localized is the right anterior oblique 40-degree cranial view is very, very important, and the anterior leaks usually localize the superior part, the posterior leaks also in the inferior part. So defect shape can be round, oval, crescentic, slit-like, crescentic, cutting edge. These are very, very important for the device selection of the device. And the defect size is very important, and we had to combine with 2D echocardiography and 3D echocardiography. On 2D transesophageal echocardiography, transverse speed of the paravalvular leak is very important. And on the 3D transesophageal echocardiography, transverse width and the actual length of the paravalvular leak is very important. And for example, for the distal and proximal discs of the device and the size of the device, we usually measure the length of the paravalvular leak. So, sorry. So how do I did, what are the tips and tricks for mastering? For the anterior leaks, I always prefer the transeptal antegrade approach. For the posterior leaks, I always prefer to begin transfemoral retrograde approach, second transeptal antegrade approach with modified pigtail technique, but hardest cases are the medial and posterolateral leaks. In the literature, many people, recommend a transapical approach, but I always prefer to use first transfemoral retrograde approach. These are the equipments, transeptal needle for the antegrade approach, mother and child technique, for the 7 French guiding catheter, long 120 centimeter impress peripheral catheter or navicross catheter, and the thermo guide wire is very important. So technique to cross the leak is a telescopic coaxial system, mother and child technique, 5 French peripheral catheter in 7 French right guiding catheter and 7 French in Aguilis sheath, and modified pigtail catheter technique for posteromedial leaks. This is the transeptal antegrade crossing of an antegrade anterior leak. After transeptal puncture, we put an Aguilis sheath in the left atrium, and by the mother and child technique, here is the right anterior oblique 40-degree cranial view, and the anterior leak is here, and we cross the defect with the thermo guide wire, and then put a stiff guide wire in the left ventricle, and over the thermo guide wire, we use the specific delivery systems. So retrograde approach is very, very useful for posteromedial and medial leaks, but it's very important to learning curve is very important. Equipments are Amplas left 1, left internal mammary and modified pigtail catheter, Terumo guide wire, and long catheter and long navicross catheter, mostly navicross, Amplas excessive guide wire, and long delivery system like Cook delivery system Flex or Cook braided sheet, and now new occlutic delivery system is also very useful for the retrograde approach. Pull and push of maneuvers of catheters to sweep posterior medial region for posterior leaks, and loop and curve technique for medial leaks, and left internal mammalian catheter for anterior leaks. Here is a retrograde crossing of a posterior medial leak. As you see, we made a high femoral puncture because the distance between groin and the leak is usually long, and we had to use a long catheters. And after sweeping to the posterior medial region with the plus one catheter, we easily cross to the FEC with the Terumo guide wire. The hardest case are for mitral paravalvular leak closure is the medial leaks. Here, as you see how we cross to medial leaks, this is the loop and curve maneuver. When we come to the apex, we make a loop here, usually with the plus left one catheter, and also the regurgitation between left ventricle and the left atrium usually allow to sweep the Terumo guide wire into the medial leak. And after crossing the leak, as you see in this case, I didn't make an arteriovenous wire loop, but nowadays I always prefer to use arteriovenous wire loop because of the, especially for the large leaks, because of the passing equipments of the delivery system. With the wire loop, the delivery system can easily cross the defect. So what are the limitations of transapical approach for mitral paravalvular leaks? Needs surgical approach, surgical skills, needs hybrid room, not suitable in cases of apical scar tissue, and we know that these patients are high-risk patients, very frail patients, and transient and permanent impairment of left ventricular function is really a problem. Even if transient, it is undesirable in patients with paravalvular leak who have cardiomyopathy as baseline. And the transapical related complications like pleural effusion, bleeding, atrial fibrillation, prolonged intubation, septum hematoma, ventricular septal defect, delayed drop apex, false aneurysm of apex, and coronary laceration risk. So it is very, very important for an interventional cardiologist to learn retrograde approach, I think. So, but limitations need to use long 120 centimeter delivery catheters and need to make high femoral puncture, and sometimes this can increase risk of retroperitoneal bleeding, and not a useful approach in patients with peripheral artery disease, and not a useful approach in patients with a concomitant mechanical aortic valve replacement. So in cases of double valves, first, I always prefer to begin with antegrade approach. It is easy for the anterior leaks, but if the leak is posterior or posterior medial, I always begin the procedure with antegrade approach by using a modified pigtail technique to cross the leak. If antegrade approach doesn't work, I always try retrograde crossing of the mechanical aortic valve with wire, but I always check the blood pressure, and I always think about creation of an arteriovenous wire loop. AV loop also useful if the device embolizes. Without AV loop, I hesitate to use large delivery catheters, and I always afraid of complications. These are the cases that we close the leaks with the anterior and posterior leaks without creating arteriovenous wire loop in patients with mechanical aortic prosthesis. Here, as an anterior leak, as you see, we come from the transeptal. It was easy for the anterior leak, but for the posterior medial leak, this is the modified pigtail technique that we used. We pushed the distal part of the agilis at the bottom of the left atrium, and then sent a cut pigtail inside in it, and try to find the exact localization of the posterior medial leak. Sometimes it works, sometimes it doesn't work, but it's a usual maneuver. And then in the first case, we used an ADO2 for the anterior leak, and in the other cases, we use AVP3 for closure of the paravalvular leaks. This is the loop and curve technique in a patient with mechanical aortic prosthesis. As you see, we pass through the mechanical aortic valve very carefully, but we look at the blood pressure, always control the blood pressure, and then never use large delivery system. and then, but the blood pressure and hemodynamic was very good, and we closed to the effect with 2 APP devices without using wire loop in this patient. Compared to the mitral paravalvular leaks, aortic paravalvular leak mechanism and localization are also different, and this is a very good surgical publication. Predisposing factors for development of aortic paravalvular leak is surgically induced anatomic change, aortic root anatomy and shape, LVOT shape, untrained and weak anatomic structures, prosthetic valve endocarditis, Marfan syndrome, bicuspid aorta, and severely calcific annulus. This is a classification of the surgical publication, but in the literature, this clog formation is completely different according to the different publications. So the mitral classification is okay, but there are, I think, this clockwise classification of aortic paravalvular leak must be revisited according to my opinion. But this is very important, right coronary sinus, non-coronary sinus, and left coronary sinus, and the relations between the sector of the periprosthetic leakage occurrence and the anatomy of the aortic annulus was investigated in this surgical series, and the most paravalvular leaks occur from the right to non-coronary cusp region. Because between 4 and 8 hour corresponds to the area above the membranous part of the interventricular septum and the right trigone of the cardiac skeleton, and basically includes the area of attachment of non-coronary cusp, and the embryologic origin of this leaflet and its portion of the annulus could be a reason for an intrinsic weakness. So this area is very important, right coronary to non-coronary cusp region, and this is the transthoracic and this is the transesophageal leaf. So we must be very careful to evaluate, although it's a simple mistake, where the transesophageal echocardiographic image and what is the transthoracic image. So the right coronary cusp is at superior on the transthoracic, but inferior on the transesophageal echocardiographic image. These publications are coming from the German group, and they identified the paravalvular aortic regurgitation on multiple views of transthoracic echocardiography and localization of the jets to a clockwise overlaid on the parasternal short axis view, and this new classification is much more adapted to the mitral paravalvular leak classification, and we usually follow up this clockwise method, and the determinants of leakage following TAVI also important, and bicuspid and aortic stenosis, it was really good, published by the Kerkhoff Clinic, and very good classification. So for the imaging, 3D is not good, 2D is okay, but aortography is for me very important during the procedure. So the aortography, if the, for example, leak is right to left or non-coronary cusp, we always use left anterior oblique angle, for example, LAO 40 degree, cranial 20 degree, and make an aortography. If it is left to right or none, I made an aortography at right anterior oblique, and if it's lateral, none to left, I use also even lateral aortography. So what are the devices? Devices are AVP2, AVP3, but the most common devices we are using is the AVP3 and occlutech paravalvular leak devices. The occlutech is indicated in its specific devices. There are rectangular W and square W device, 19 design and size options, square tip, rectangular, 2 shapes, and it gives much more opportunity to us and for its large sizes and to evaluate the paravalvular leak, and there was some problems, especially for the delivery systems of these devices, but now the new delivery system is performed, and it's this new ODS 3 is the reliable flex-tier braiding technology, and it's very, very useful to cross even from the retrograde approach and for the largest leaks. There are some side ports, heel and hemostatic valve and the minimizing blood loss and air entry, and 3-wave stopcock flushing and aspirating before and during the implantation. Okay, so I want to present some interesting cases. 70 years old man, alcohol septal ablation was done in 2017, and bioprosthetic mitral valve replacement was done in 2021. And paravalvular leaks developed and referred to our Center for Paravalvular Leak Closure. Patient has severe heart failure, recurrent pleural effusion, class 4 symptoms, but no fever, CRP was normal, white blood cell was normal, and the blood culture was negative. We always evaluate this before the paravalvular leak closure, and also for the hemolysis marker, we evaluate haptoglobulin, hemoglobin, and peripheral blood analysis. These are very important tests before paravalvular leak closures. You can see here the severity of the paravalvular leaks. There is an anterior severe paravalvular leak at 10 o'clock position, and it was measured as 15 multiplied by 6 or 16, and the posterior severe paravalvular leak at 6 o'clock position here, 18. Medial paravalvular leaks grade 1 and 2, but anterior and posterior leaks are very severe and large leaks. Here you can see, but it is not a full dehiscence, but very large paravalvular leak, one here and one here. So we measured this distance because you know that the largest size of AVP3 is 14 millimeter, and the disc will be 18 millimeters. So we decided to use an rectangular W, the largest size of occlutech in this case. Here you can see the transeptal puncture. We always do the transeptal puncture without sheath, only the dilator, and put a spring coil guide wire in the left atrium, and then dilate the left atrium, like our in mitral balloon valvuloplasty procedures. And then after transeptal puncture, as you see that the bioprosthetic valve is not completely seen on the fluoroscopy, and we cross the anterior leak with mother and child technique and put a stiff guide wire. And then during this, after crossing the leak with the Terumo guide wire, we always use a Navicross catheter because it usually allows to much good replacement of the an exchange for the stiff guide wire. And we select the 16 millimeter device of the rectangular W, open the distal disc of the rectangular W device, and close the leak. So you can see the appearance of the occlutech rectangular W device here. So then we cross the posterior leak and create an arteriovenous wire loop, because for the posterior leaks, it is very important to create an arteriovenous wire loop, because sometimes the angle is in this sample, angle cannot allow you to put your device properly. So if you have an arteriovenous wire loop, if you don't like the angle, you can come from the retrograde way. So arteriovenous wire loop is also very useful for the delivery system to cross the leaks. As you see, 18 millimeter device is not in a good position. So if there was a wire loop, for example, there was no need to recross the leak. So we changed the wire loop there, and we recross the posterior leak again with the modified pigtail approach. And then, sorry. Now, 18 millimeter devices, very good position. So these are the largest paravalvular leak devices of the Occlutech rectangular W family. So think about the size of the leak. So this is the 3D appearance of after paravalvular leak closure. Both color 3D show that anterior and the posterior leaks completely close, and we don't want to spend any time much more for the patient to cross this medial leak, and we decided to follow up according to the hemolysis, and patient is very, very good clinical status now. This is another case, as you see, the septal region, the medial paravalvular leak. So we tried to cross the leak anteriorly, but we were not successful. Then we again crossed the paravalvular leak by retrograde approach and made the arteriovenous wire loop, which Vlasis always called me the loop guy. So because of this wire loop, as you see, you can easily put your device, and if you don't like the position, it can you give an opportunity to you to change the device and your way. So it's very, very good approach nowadays. I always use the wire loops. And the second leak was recrossed by the thermoguide wire, and we used the long Occlutech delivery sheet. And this is a very interesting case also. As you can see the large medial paravalvular leak. We crossed the leak again by retrograde approach and made our wire loop again. We tried to cross the leak by the classical delivery system of the Occlutech, but look at the, always the distal part is going to the upper part of the left atrium. So we decided to take the new ODS 3 system and come from retrograde approach and close the leak by the retrograde approach. As you see, there is no impingement of the leak. So there are some limitations, still limitations of current devices. The Amplaster family is not specifically designed for paravalvular leak closure. Off-label usage, morphology of defect represents great diversity, and atrial and ventricular orifices of these defects can be different. However, two discs, proximal and distal, are same in Amplaster devices, and insufficient data still for the hemolysis. Delivery systems are not compatible with other closure delivery systems, but the long delivery system are limited only maximum to 7 French size. Thus, there is an important problem for retrograde closure of large defect with these delivery systems. But advantage of the Amplaster family is that you can use the largest size with 7 French delivery system, and you can also use, you know, Gregor's used the large sheet in the Oscar sheet in left atrium and multiplaque approach. But Occlutech family devices are good and specifically designed for paravalvular leak closure, but all delivery systems were not good. You cannot use the largest devices with this old delivery system. New ODS 3 is solving a lot of problems, especially during retrograde closure of defects, designed mainly for transeptal and transapical approaches, and pushability and stability of the device in all delivery systems are re-examined, and I think and I hope new ODS 3 system will provide great benefits. Thank you very much for your attention.
Theo, thank you very much. Excellent presentation. You don't need to show the live case. You saw the cases, 3 cases. And can I ask you a question practically? You leave when you do the loop, which wire you leave? The Terumo wire? Because sometimes, you know, it distorts the position of the Which device, which wire do you use for the loop?
I always use Terumo guide.
Terumo. So you leave the Terumo in and position.
Yes,
Okay.
yes.
So you have the access. That's very important because if you lose the access, you have to start with again.
Sometimes, if, for example, I never see, but some operators change the noodle guide wire sometimes, like in VST closure. But Terumo is always working.
Fine. Okay. So if I don't know if you have any.
May I have a question on the topic when to close? Your decision to go with this operation depends on volumetric measures of the regurgitation or on clinical grounds and clinical signs, anemia, shortness of breath.
This is a very good question. We especially look at first the clinical status and the clinical condition of the patient. Heart failure is really problematic for this patient, but when heart failure, for example, symptoms are prominent, when we look at the transthoracic image, paravalvular leaks we saw, but it's, for example, grade 1, 2. It is very important to do transesophageal echocardiography for these patients, because T shows the exact value of the paravalvular leak. Okay. And clinical hemolysis is very important and still is an unsolved issue. We are discussing a lot of these points. Why? Because of the inadequate endothelization, residual leaks, relics after that I present the mechanism of the leak, the anterior leak and posterior contractions. So these are all unsolved problems for paravalvular leak closure. But the clinical data is much more important than the imaging severity of the
you would agree also to finish, I don't know if because of time, that sometimes we close a patient who has cardiac failure, heart failure, and then if you leave a leak, you might develop an hemolysis. So sometimes so it might change the indication. So that's the other thing that you have to consider.
Yes, but even with transesophageal, volumetric measurements are quite difficult and inaccurate. It is not so easy to be accurate in regards to volume, for example. That's why I'm talking about clinical signs.
We rely more on clinical, I think. That's what
yes,
you said.
Clinical. Vilas has some questions.
Okay, I think we're going to close the session.
Vilas is...
Blasis? Yes, Blasis.
If we have a minute, I mean.
Yes, go ahead.
One of the most difficult, congratulations, Theo. We've been in this together, and Professor Vavronakis for some time now. One of the most difficult access points to close a mitral leak is the P2 area, 6 o'clock. And we've struggled sometimes transeptally. And we did the other day, we use your technique with the VA loop. And actually, it works very well. It gives you tremendous support. I mean, Theo taught us how to do it, and we're grateful for that. It's one of the things that actually work a lot. Otherwise, it's very difficult.
Vlasi, to tell you, and I agree totally with you, sometimes, I manage to succeed just by putting the wire all the way down without actually looping it. So this can also help if you do not have the femoral access done, and patient is heparinized. And but you can always puncture with ultrasound, so you can get the loop actually.
But for the delivery system, large delivery
system, it's much better if you have
really, if you make arteriovenous wire loop, because before I was thinking opposite, that I publish without wire loop approach, but wire loop really helps you to cross the large delivery sheet inside the leak.
Yes, no doubt about that. You're right. So I think we're going to close now. We have a break, 15 minutes, and then we'll come back.
Can be early and late, and these are mostly related with inadequate sizing, maybe second implantation to the residual leak after the first device implantation. And let me show you a case, not this case, sorry. This is a 53-year-old male. Aortic valve replacement and mitral valve replacement was done due to rheumatic heart disease and heart failure and hemolysis and severe aortic paravalvular leak. You can see the severe aortic paravalvular leak on transesophageal image. And 3D zoom also showed the crescentic aortic paravalvular leak. And we measured the distance of the leak as 13 millimeters. And then we decided to use the largest AVP3 14 millimeter device. Here you can see the double S curve of the aortic paravalvular leak. So we crossed the leak with the Terimo guide wire and then put the 14 millimeter device. As you see, everything was okay, but look at this last image, please. There was no stuck at first image. But after we release the device, you see a clear stuck occurred. This is one of the another frightening complication of paravalvular leak closure. So we quickly tried to snare the device. We were lucky, we snared the distal part of the device with the 7 French guiding catheter inside. We put the snare in the 7 French guiding catheter. But when we take it into the iliac region, it again embolized, and it settled to the iliac bifurcation. So we several times tried to snare it. It was really a nightmare. So then we called our good friends, the endoscopic forceps device. It's an alligator called from the gastroenterology department. And here we can easily use, I've got another case which the device was embolized to the left atrium that Vilas is also underlined. We also use this alligator device to catch the embolized device. This alligator is also very useful when a left atrial appendage occlusion device also embolized. As you see here. Then we closed the leak with a smaller AVP3 device, 10 millimeter device. But of course, nightmare was ongoing, iliac dissection after removal of the embolization device, and we put an iliac stent and finished the procedure. So transcatheter mitral paravalvular and aortic paravalvular leak closure is one of the most hardest procedures of interventional cardiology. Device embolization can occur in any time despite good TAC tests. Gooseneck snakes are effective, but sometimes not. Cardiac biopsy photomes is not an alligator. Endoscopic biopsy forceps is an alligator. And structural interventionalists will fall in love with alligators. Thank you very much for your attention.
Just a small comment, so thank you. So this was an encore of the previous presentation. So thank you, Theo, for sharing that. So do you advise everyone to have an alligator, everyone who is doing paravalvular leak closure or devices, an alligator device?
Because snares are not working when especially you put large devices.
Yes.
Some snares are designed for AST closure devices, but even with the larger AST closure devices, it's not very easy to snare them.
From time to time, we use the biopsy forceps in order to snare, but you think it's alligator?
Biopsy forceps can be harmful when you try to catch the device. But what we are doing, we first touch the device with a guide wire, then send the alligator and catch the device according to that position.
So you use the device as a bait for the alligator, right? And it catches, of course.
You must try it. I hope you will not try, but in any case of complication, it's a life-saving equipment.
I have the privilege of knowing Theo for a long time now, and I've seen what he can do. And really, I think that's a really wonderful thing. And I think it may bail you out from a nightmare situation. So thank you for sharing that.
Thank you very much.
So shall we move on with Elias? I think it's a parade of cases now, and he's the first in line from our hospital. He's going to show something interesting, I hope.
So that's a case with a mitral valve in ring implantation. It's about an 82-year-old female who was previously operated on the mitral valve with mitral valve repair, and she had received Edwards Physioring 30 millimeter. She has COPD, diabetes, moderate renal failure, and Euroscore of 13. That's the valve with the ring, as you can see. That's the echo before. And the gradient was 7. I think that's Vlas's after she was intubated, because I think initially was even more than 7. And that's the ring, non-fracturable ring. And we made the CT first, and the neo LVOT was 181. It's borderline. But we had also some septal bulging, and therefore we decided to proceed to a tip-to-base lampoon. And Theo, Dr. Professor Kilis, was our secret weapon. And first we implanted a sentinel protection system, and then proceeded to a transeptal puncture inferior and posterior. And then we had an Agilis catheter and an Innovi wire through the valve. And we made a balloon test, an inflation with a 26 millimeter balloon. We see that slow flow in the aorta. And after that, we created a VA loop with a long terumo, wife, and created and a rendezvous with a retro guide and the Agilis. And through that, we put a flying V, a wire which was bended, and with diathermy, we splitted the anterior mitral valve in the A2, and you see here, I think, the acute MR on the right panel that we created. And after that, we performed a balloon septostomy with a 12 millimeter balloon, and then a MyVal 29 was implanted with very good result. No paravalvular leak, no regurgitation, as you see also the fluoroscopy. No LVOT obstruction, of course, and no gradients between LV and LA. That's some images, an ASD, iatrogenic ASD from left to right with left to right shunt. In conclusion, valve in ring TMVR can be challenging due to the potential of inadequate anchoring, anterior leaflet displacement, and LVOT obstruction. Leaflet modification techniques can be maybe necessary. Tip-to-base lampoon is a relatively complex procedure, but is effective in splitting the anterior leaflet if done properly, and the cerebral protection is mandatory. Thank you.
So that's a case that we very quickly presented before, but we thought that might be an opportunity to discuss the tips and tricks of doing this case. First of all, the selection. If you see the CT scan, the neo-LVOT was 180 millimeters square, and it's not too bad, it's not terrible. I mean, 180 is probably manageable. So we did discuss a lot before the case and during the case, the three of us, whether actually modifying the leaflet was necessary. That's why we inflated this 26 balloon, in order to have an idea what will happen with the neo-LVOT. To be honest, I'm not sure if that helped with the decision, because the balloon prolapses inside the LV anyway and blocks the flow, so it will look bulky. So maybe it's a step that for the next case we could not do. But the anterior leaflet had a couple of features that made this unattractive. So, for example, it was very thick, and thick means that it will not extend as much to the LVOT, so perhaps it's not necessary. And it was relatively short. Having said that, we measured it many times, and we had measurement between 18 and 25 millimeters. And looking in the literature, any anterior leaflet length of above 23 millimeters, in theory, could cause LVOT obstruction. So, unfortunately, when it comes to native leaflets, the CT scan cannot give you an accurate prediction of the neo-LVOT, because it can only show you how far the valve protrudes into the LVOT. It doesn't take into account the length of the anterior leaflet, and that's the key. If your length is long, like this morning, Kostas Spargios showed this tear case in the repaired valve. If you had tried to put a valve in ring, in this case that the anterior leaflet was 30 millimeter, that would definitely cause obstruction. Doesn't matter what angulation you have, widening of the LVOT. The question is, now that we saw the Batman approach, which I think it's simpler, personally, would we do a Batman on this case, like perforate the leaflet and inflate the valve in there? I mean, that's an alternative as well.
Vlaska, if I may interrupt you a little bit. So we just saw in Intrepid satellite symposium. So Medtronic people have this AI-generated algorithm that actually, can see if there is an increased danger of LVOT obstruction. So based on the CT mainly. So maybe it takes into account, I suppose, the measurements. But if you can get, maybe it's easier and it's more, let's say, liberalized this approach. This AI generation.
I'm not familiar with that. That might be an option.
That would be an interesting,
The other thing that we need to measure in these cases, and this is happening already, is just if we use MyVal, we need to. I've already spoken to the company to do that. Is to measure the valve neo-LVOT and the skirt neo-LVOT, because if you have a septal bulge, if your anterior septum at the base is very thick, then you may modify the leaflet, but your septum is going to close the way anyway. And then you may do septal modification techniques, such as alcohol ablation or sesame or all this stuff. But if, on the other hand, the septum is thin and your leaflet is long, then it's nice to have a prediction of what will happen, for example, if your valve in the skirt area, because then the distal part in the LV, you don't care, because the cells are widely open. So if your valve in the skirt area leaves you a widely open neo-LVOT up to the IVS. So I think this is also very useful.
So in this case, if you have been doing that, tomorrow, would you do it the same, time, or in the same way? Would you prefer to do a Batman procedure?
I mean, I've only done one Batman case and two of those, but so I'm not mega experienced. But I think Batman was easier to do, to be honest with you, because all you have to do is just find the leaflet in the A2, perforate it, balloon it, and then put the valve in there.
Yeah.
So maybe, but having said that, I don't know, because the leaflet was thick. It was quite cumbersome. I mean, it didn't show how complex it was. I mean, we spent 2 hours to do this lampoon.
It's not easy, and you have to have an expert, to do that.
there was an interesting session in the New York Valves about electrosurgery, and Zafar Khan, who is the guru of this, described all the steps. It takes 3 people to do it. We did it 2 people, and we were holding and pulling and pushing each other. Eventually we did it, but it wasn't very easy, because you have to hold your catheters, the proximal and the distal catheter, very stable, and then pull the wire, make sure you don't lose the flying V position, because this area is denuded. So you scrape the insulation, you create a sharp V, and then you insert it into the patient.
So
and then you have to create
NIH group, also showed some results before doing the Lampoon. Letterman and Zafar Khan showed that maybe in some situations it's better to do septal ablation before, right? So it's maybe in this case it's not the
provided you have enough septal thickness.
Doesn't look very hypertrophied, but yeah.
Actually, we published a comment about alcohol septal ablation when a letter to the editor come to our first publication with Lampoon technique, and when we look at the alcohol septal ablation trials and cases, very harmful for these mitral cases, because these patients are sick and there is risk of arrhythmia development. And so instead of alcohol septal ablation, really Lampoon and Batman techniques are much important. To be honest, he will do the Vlasis will do the Batman procedure in that case. Maybe I prevent him, let's do Lampoon. But I saw that real heart team was working in entire Balkan Center, and I really congratulate them. And Ilyas is the eye of the Vlasis, and they are doing really very good techniques in their centers, and congratulations them for this case. And this case is really very hard case because very thick anterior mitral leaflet.
And also the problem with the septum, especially in this age population, is the angulation of the very basal part of the septum, which provides an impression or a real thickening, but it's very regional and angle-shaped. So in this scenario, the alcohol ablation is not applicable.
I agree. It's not the thickness, it's the angulation, the S shape.
Yeah.
That can cause dynamical VOT obstruction as well, so it's not a fixed. Totally agree.
Okay, so it was a great contribution for the well-known Inter-Balkan team. It's a privilege to have you with us, not only in the theater, in this theater, but also in the cath lab.
The pleasure is ours.
We shall continue to the next presentation, which will be given by Dr. Leodiadis. Leodiadis is another key person who contributes efficiently in our activities, Yannis Yakov activities.
Thank you very much. Can you hear me?
Εντάξει.
Can you hear me?
Ναι, εντάξει, εντάξει.
Okay. Sorry. Okay. So, this is the next case. Sorry, I can't be there because I'm recovering from COVID infection. So this next case was performed with the help of the Inter-Balkan team, Vlasis and Ilias Nignos. So this is about a 46-year-old female who underwent a heart transplantation almost 20 years ago and was admitted several times to the hospital due to right heart failure, symptoms of right heart failure. She had peripheral edema, dyspnea. She was almost on 200 milligrams of furosemide daily. And the lab group you see, NT-proBNP was over 2,000, and she had almost cardiorenal hepatic syndrome due to severe tricuspid regurgitation. So after meeting with the heart team to discuss about possible surgery for tricuspid valve surgery, repair or replacement. The U score was high, and the TI score, which predicts in-hospital mortality for isolated surgery on the tricuspid valve, was very high. So the heart team decided for us to go with the edge-to-edge therapy on the tricuspid valve. This is the baseline echo, as you can see. Sorry. You see a good functioning left ventricle and dilated right ventricle, severe tricuspid regurgitation with a PISA greater than 0.4, regurgitant volume over 50 milliliters. As I said, dilatation of the annulus of the tricuspid valve on both diameters, prolapse of the posterior lifted, the coaptation gap was 7 millimeters, and there was no chordal rupture identified, even though these patients undergo lots of biopsies, and most of the times we destroy the valve during the biopsy. The right ventricle was dilated with a mildly impaired function. You see the functional area range of 30% and a triangle strain of minus 15%. This is the TE screening. We can appreciate here the prolapse of the posterior leaflet with a jet of a severe tricuspid regurgitation going under the atrial portion of the septal leaflet. And as we know from the screening tool from Abbott, the line of coaptation goes through the posteroseptal commissure to the anteroseptal commissure, and we also know that during functional or during tricuspid regurgitation, the annulus dilates towards the lateral wall, the mural wall, so we use the septal leaflet as the anchor leaflet and put most of the times our clips between the septal and the anterior leaflet, and this was our strategy in this patient. Once again, the transgastric view, the aorta is here, the posterior leaflet, the anterior leaflet, the septal leaflet, and the jet comes mostly from the posteroseptal commissure, and this is where our strategy was to put the first clip. This is the data from the right heart cath. You see CVP was 22 millimeters mercury. The coronary vascular resistance was 1.16, and the output was not that bad, but still the patient had the severe symptoms and sign of right heart failure. This is the procedure. We do the straddling with the catheter, and then you see usually, as Vlasis said this morning, the catheter with the clip goes towards the septum at the beginning of the procedure. So we put some L on the guide catheter, and then we flex down to go away from the septum. Then we flex down to the valve, and you see here the line of coaptation. And this is the clip. We are in a transgastric view, and this is the clip with the open arms. We clock it like this. We have to go perpendicular to the line of coaptation. Then we close the clippers, we go in the arms, we go into the ventricle. You see we're in another posterior region. You see here we do independent grasping. First we grasp the posterior leaflet, and you see the grippers here to the septal leaflet, and this is after the grasping. You see there's a good grasp with residual tricuspid regurgitation in the anterior portion of the clip. This is the transgastric view. Once again, you see there is no SLD. The posteroseptal portion is well in the under the arms, and but you can still appreciate that there is a jet just anterior to the first one. So we went for a second clip at this region. This is the second clip. Once again, we do the clocking. We have to go counterclockwise to bring it perpendicular to the line of coaptation. And you can appreciate here and nicely that the two clips move in a parallel fashion, meaning that there is no blocking and that we didn't pinwheel the valve. This is the grasping after the second clip. You see anterior to the first one, the arms are open. And this is the final result. You see the two clips with just a minimal residual trace regurgitation. You see the clips moving in a parallel fashion. And these are the results 9 months after the procedure. You see here the baseline, and you see here just a trace of the two clips with a negative remodeling of the right ventricle. The right ventricle is definitely smaller at the forceps review at this dimension with a mild trace AR. Just a few words. TriClip had a CE mark in 2002 and FDA approval in 2024. This is the one randomized limited study which showed that it's a very safe procedure when it was compared to the medical therapy group. It was very safe. The severity of the tricuspid regurgitation in the arm of the TriClip patients was smaller and the quality of life was better. Just to remind you that there is no place for edge-to-edge tricuspid therapy in the American guidelines, only in European guidelines with the 2B position. And there's not much data on patients undergoing edge-to-edge therapy in the tricuspid valve after orthotopic heart transplantation. This is from 7 patients, going from 5+ according to this grading scale of Rebecca Hahn, going at 30 days to moderate tricuspid regurgitation. And I just found another case report regarding this group of patients. So there's not much data on patients undergoing edge-to-edge therapy after heart transplantation. Thank you very much for your attention.
Thank you, Dr. Leodiadis. It was a very nicely organized presentation in a very exceptional scenario of heart transplant patient. We have this advantage to deal with this cohort of patients in our center. So it was a nice contribution to this scenario. Any comments from the audience? Okay. So I think that we have to thank Dr.
Do you hear me?
Dr. Halapas has a comment. Yes. Yes. Dr. Halapas, yes.
First of all, I want to thank one more time Dr. Iacobu for having me here with you. It is a real privilege. That was a really excellent case, exceptional but excellent case, great result. Opposed to mitral valve, commissural jets in TR are very good candidates for TR procedure. That's just one comment. However, in tricuspid valve area, there are certain issues that we have not yet really answers, like when is the correct time to intervene. This is the first. Which is the optimal medical treatment in right heart failure patients? And of course, which is the best modality in order to evaluate the severity? How often you use cardiac MRI in order to evaluate PR cases? This is just a first question. And the other question is that based on the recently published classification of TR, we have the atrial TR, not ventricular secondary TR. In such cases, devices like cardioband and uroplasty having CE mark could be a good choice. Do you have any comment on that?
About the last question, we don't have experience at Onassis with these patients, but I think that the greatest experience so far is with edge-to-edge therapy. So I think we should go with the technique we're mostly familiar with, and this is edge-to-edge therapy. We don't really use in this setting of patients, we don't really use MRI. I don't think we really need MRI in this patient. And as we know, we have to intervene soon in the disease, because if we intervene lately, then there's a great dilatation of the right ventricle. The right ventricle fails. Then even if we have a very good end result and the procedure, still the patient is not going to go well because of right ventricular failure. So you're going to have a device, a clip, and a walk, or whatever, in which is you have a very good successful implantation of a device, but still the patient is not going to do well because he's going to suffer from right ventricular failure, hepatic failure, renal failure, and so on.
Okay. Thank you very much.
So the next speaker is Professor Kalogeras from Soteria Hospital.
Good evening. First of all, I would like to thank Dr. Iakovou for the kind invitation to participate in this very interesting case roundtable. So I'm going to present, actually it's two cases of mitral valve PVL closure, but they have some common anatomical characteristics that created some difficulties during the procedure and were managed in two different ways. So the first case is a 68-year-old male who had a past medical history of combined aortic and mitral mechanical valve replacement 6 years ago due to severe aortic stenosis and mitral regurgitation. He also suffers from paroxysmal atrial fibrillation, hypertension, CKD, and he's coming now due to symptoms of general fatigue, new onset orthopnea, and impaired functional status. So initially, the transthoracic echo revealed a well-preserved LV ejection fraction, and however, a severe paravalvular leak, which was further investigated with transesophageal echo. And as you can see, it confirmed the existence of this severe PVL located in the anterior lateral position, as you can see on the left side of the screen. It was measured about 9 by 5 millimeters. The second case is about a 76-year-old male who was referred due to severe hemolytic anemia this time and impaired functional status. He had a prosthetic mitral valve implanted back in 2008. He also has a pacemaker implanted, suffers from permanent atrial fibrillation, CKD, and his blood tests confirmed that he has a severe hemolytic anemia. Also, at this point, he has on TOE, there is a severe PVL located in the posterior lateral location at this time. I don't know if you can see here. It's quite big enough, as you can see. So, what's the common characteristic of these two cases? You can see the two cases next to each other, and in both cases, despite the lateral position of the PVL, which could be in favor of easy access and crossing, however, the orientation of the PVL jet is perpendicular to the mitral valve flow, or you can call it very horizontal in both cases. So the procedural planning concerns what is the proper access site, considering this parallel or perpendicular to the valve flow course of the jet, and what is the optimal sealing device. So starting from the first case, we did initially the transeptal puncture, as you can see on the left side, and the PVL was crossed with a Terumo wire over a multi-purpose 5 French long diagnostic catheter through an Agilis steerable catheter. The wire was then exchanged for a super stiff Amplatzer wire, and the Ocultec PLDW rectangular device was initially chosen and advanced across the defect. However, as you can see at this point, on the 3D and the 2D image, The device is deployed but not released yet. There is an obstruction of one of the two discs. As you can see, the one of the two discs is not moving at all. So this is probably happened due to squeezing of the device across the defect. And as expected, we did not release the device. We recaptured it and retrieved it back. And we chose another device, the Ambulator Vascular Plug 3, which was deployed at this time, as you can see here. There is no interference with the prosthetic valve. And we finally released it with a very mild residual leak. So at this case, we managed to deal with the case with implanting a different device type. Going to the second case, again, we did the transeptal puncture using a FlexCath sheath, a steerable sheath. You can see it in the left atrium on the right side, just positioned above the defect. And we tried to cross the defect with multiple catheters and multiple wires. The Terumo wire was not working at all. So we managed to cross the defect with Judkins right catheter. Because of this horizontal orientation of the jet, it was the only catheter that managed to help us cross the wire. And we managed to do it with a coronary wire, not a Terumo wire. However, after crossing the defect, multiple attempts were made to advance the catheter in the left ventricle and was not able to manage it because of the lack of support and the orientation of the jet. So what to do next? Somebody can think to change the steerable catheter for something different, to use a second support wire, coronary probably wire again. Now I would definitely add the Teoman-Kilic technique, or to stop and try an alternative approach. So we decided for the last one, and a few days later we came back with the help of a surgeon, and we performed a transapical approach. As you can see, this time it was much easier to cross the defect with Terumo wire over a multipurpose catheter, advance it in the left atrium. You can see here on the 3D images the catheter through the defect, some nice pictures. The next step was to advance a super-stiff wire in the left atrium and exchange it with for a guide multipurpose catheter, which gave us the opportunity to advance two super-stiff wires in the left atrium because of the large dimensions of the defect. We expect to use two devices, and here you can see the first device, a vascular plug 3, 14 by 5 millimeters advanced across the defect over here, not released yet. You can see on the pictures the one device and the wire next to it. There is still a residual leak, so indeed we are going to use a second device. And over the second wire, the second super stiff wire, we advanced as the second vascular plug 3 device, a bit smaller this time, 12 by 5. So here on the right side, you can see the two devices deployed next to each other, but not released yet. We have to confirm that we have a good result. And as you can see on the right side, on the TOE echo, the two devices next to each other deployed with no residual regurgitation. And when we are happy with that result, we release subsequently the two devices with a good final result. So in the second case, we managed to deal with it with an alternative access site. So in conclusion, the mitral valve transcatheter PVL closure definitely has a variety of technical challenges that somebody could face. The orientation of the jet seems to be one of that. The operator should be able to recognize any prosthetic valve malfunction, and different device sizes and types should be available in order to deal with these unexpected complications. And also, somebody should be able to use and utilize all the available techniques for access if needed. Thank you.
So excellent cases, Dr. Galgeras. So, George, you have any comments on that?
How often is the use of transapical approach in this area?
Not often. Very, very rare. And as we heard before from Professor Kilic, who has a very big experience, I think he never used it. Maybe for medial leaks, somebody could think about it, or the posterior lateral, which are also difficult, like the second one. So probably we could have used his technique, but it's quite rare.
Yeah, but
the other thing I would like to comment is now if somebody has a device, ASD or a PFO device, it's sometimes, or there has been another procedure in the past, then it might be very difficult to cross the septum. It's another situation.
And in the first case, so you were successful with AVP3 instead of the Occlutech device.
Yes.
Do you think it's the shape of that it was not because it's?
I think it's the orientation of the tunnel of the PVL. Yeah. It may be squeezed. It was the Occlutech W, which has a larger waist in the middle, the connection wire. So it might be the squeezing of this part that interfered with the valve.
Yeah. So when you are dealing with this kind of situation, maybe you need to be familiar with both devices.
Both devices be available.
Okay, good. So
that's
the
most difficult, I think.
George Bobas has a burning question.
First of all, congratulations, and I would like to ask, do you think 3D printing in terms of pre-procedural planning in this kind of cases where you have a mitral valve which can be seen easily in the CT scan, maybe do you think that it might have had an impact in terms of selecting the correct device or orientation in order to be faster, more efficient?
Yes, maybe it could be helpful. I don't know if it's very small anatomies and tunnels. You are an expert at this field. And the other thing, I don't know if you can predict with a 3D printing exactly how the device will orient across the tunnel.
So, George, since you are an expert, so if you do a 3D printing, you rely on CT, right?
Exactly.
In mitral.
We use the CT. The CT information that we gather is really, really amazing, and you really can predict.
Even in mitral.
It's even in mitral.
Because we just recently have a case that we did the 3D printing, and something that's evident in the TOE, and it was spotted by Dr. Athanasopoulos. So it was not there with the CT. So there are some discrepancies, right? Some caveats.
But if in this case you had the mitral valve, which was metal, and the origins of the metal is really, really clean in the CT, and the origins of the tissue is really clean as well, and some small holes it can be seen. I have done this kind of analysis in the past, and I don't know. I just asking if it could be possible.
Yeah. So if you're dealing with semi-rigid, which is not metal, ring.
Even it's kind of harder than tissue, so it can be seen easily through the
We can ask your help in the next case.
Exactly. So the next time we'll ask both.
Just ask.
So Adonis, you have a question?
I don't have a question, just to mention it sometimes when you position the device in the defect and you see that everything works fine. When you release it, you change the orientation, and sometimes that makes the problem. This is an issue that we have to be always aware and must be ready to manage. And the other thing is that unfortunately we don't have a dedicated device. This is a limitation of the PVL occlusion at the moment. Excellent presentation.
Good. So thank you, Adonis. So thank you, Dr. Galgeras. So we have to go to the next presentation. Is by Francesco Giannini. Francesco, is Francesco online?
Yes.
Hi, Francesco.
And I hope that you can hear me well.
Yes, we hear you fine.
So once again, many thanks for the involvement in the Congress and congratulations, because it's very interesting, and also the cases that I have just seen are very interesting. So the problem is always the same, not to have enough time for discussion. So thanks also for the involvement in this session. I have selected for this session a case of coronary sinus reducer implantation in a patient with refractory angina without obstructive coronary artery disease. So the patient was a 65-year-old lady with diabetes mellitus, arterial hypertension that was well controlled with several drugs. The patient was symptomatic for chronic refractory angina despite the use of different anti-anginal drugs, and she doesn't tolerate ranolazine and long-acting nitrates because of dyspnea and headache, respectively. She underwent an exercise tolerance test that was positive for both angina symptoms and also a diffuse ST depression. So she underwent a coronary angiography that showed a mild to moderate stenosis in the proximal LAD without any other significant epicardial coronary artery disease. So an IVUS was performed. The IVUS showed that the minimal lumen area was let's say sufficient, was around 7 millimeters square, confirming the not significantly of the stenosis. And we also performed the fractional flow reserve that was negative. It was above 0.85 across the mid-distal LAD. Also, an acetylcholine test was performed, and it was negative for vasospasm. So there was a very high suspect of microvascular dysfunction. In this patient, in our center, we prefer to utilize the cardiac magnetic resonance, the perfusion cardiac magnetic resonance, with both the qualitative and semi-quantitative evaluation. In this patient, there was a significant impairment of the myocardial perfusion reserve index that was that, as you know, is a semi-quantitative parameter that provides us information about the microcirculation performance, and it was below 1.3 in, let's say, most of the myocardial segment, showing a clear evidence of diffuse myocardial ischemia. So we have a patient with the absence of the significant epicardial coronary artery disease, evidence of diffuse myocardial ischemia, and a perfusion cardiac magnetic resonance in a patient that is symptomatic for angina symptoms, refractory to maximally tolerated medical therapy. So it was clear the diagnosis of microvascular dysfunction. We consider the reducer implantation for this patient. Very briefly, reducer is a stainless steel scaffold device, is an hourglass-shaped device that is implanted into the coronary sinus through the jugular vein under local anesthesia. A few weeks after the implantation, we have a full reendothelialization of the device with an effective stenosis of the vessel. This actually determines the increase of the pressure in the cardiac venous system, and this increase of the pressure promotes a redistribution of the blood flow from the less ischemic subepicardium to the more ischemic subendocardium, so at the end, reestablishing a normal ratio between endocardial and epicardial blood flow, thus reducing the myocardial ischemia and improvement of the angina symptoms. We have clear evidence about the efficacy of this device in patients with obstructive coronary artery disease coming from these two randomized trials, the COSIRA trial on the left and the ORBITA COSMIC trial recently published on the right. But we have also some initial experience about the efficacy of this novel therapy in patients without obstructive coronary artery disease. This was an initial case series that I have published a few years ago, 8 patients with angina symptoms, refractory to optimal medical therapy and non-obstructive coronary artery disease. In almost all these patients, we observed after the reducer implantation a significant improvement of angina symptoms, and this was also showed by using the cardiac magnetic resonance with an improvement of myocardial ischemia in almost all the cases. And there are other 2 studies that have been presented in the last 2 years at TCT by 2 centers, Tel Aviv Medical Center and Mayo Clinic, showing in 10 patients and 30 patients respectively as this device in patients with microvascular dysfunction is associated with an improvement of coronary flow reserve and an improvement of IMR. So as I said, the procedure was performed through the jugular vein, so a specific cath lab setup is required. The coronary sinus was engaged by using a multipurpose diagnostic catheter. A baseline coronary sinus angiogram was performed to understand where was the best site for the implantation. Then a stiffer wire was left distal into the coronary sinus, and over this wire, a system with a guiding catheter 9 French with inside this stainless steel scaffold was advanced into the right atrium and then into the coronary sinus. Once we achieved the right position, an unsheathing was performed, and then the device was deployed by inflating the balloon nominal at 4 atmosphere. And now you will see the final result that actually is a 20% of oversizing that we want to achieve to create a damage to the vessel wall, thus promoting the growth, new tissue, and effective stenosis a few weeks after the implantation. And this was the CT scan performed at a 3 months follow-up, showing the narrowing effect without contrast behind the struts. So our patient underwent at 4 months follow-up, a clinical follow-up, and also a cardiac magnetic resonance perfusion again. She had an improvement of angina symptoms from Canadian class score 3 to Canadian class score 1, so a reduction of 2 Canadian class score classes, and the cardiac magnetic resonance showed an improvement of the MPRI from 1.15 to 1.45. At 1 year follow-up, the improvement of angina symptoms was also confirmed. So this device seems to be also effective in this subgroup of patients that are patients with microvascular dysfunction, and there are 2 randomized trials that are ongoing. One performed in Mainz in Germany, and the second one performed in Brompton Hospital in London. Are 2 randomized trials versus that actually compare reducer versus shunt control procedure in patients with microvascular dysfunction. So definitely in a few months or few years, we will have definitive data about that. Many thanks for your attention.
Thank you, Francesco. As always, you had an excellent case to show. So this is an emerging, but quite old, right? So it took some time to take off. And still, a lot of people are skeptical, and we need to convince people that in a certain situation, this device will provide relief in the symptoms of patients. So, and we know heart endpoints are not getting better even with revascularization in most of the patients. So, can you help us identify which are the best patient candidates that will feel that we have some amelioration of the symptoms?
Yeah, thank you for the question. Current indication for reducing implantation are patients with the refractory angina, clear evidence of myocardial ischemia in the left coronary artery territory. Patients are already in optimal medical therapy without any further option of coronary revascularization. And there are now 2 randomized trials. You're right, a lot of people do not believe in that because we had, until a few months ago, only 1 randomized trial, a relatively small randomized trial with only 100 patients that was published in 2015, the COSIRA trial. But now we have a second randomized trial that was presented this year, the Cosmic Orbiter trial at the American College of Cardiology, and was published in Lancet, actually showing the same results. So now I think with 2 randomized trials, it's difficult not to provide this option for patients that otherwise do not have any other option. I also believe that this could work in patients with microvascular dysfunction, but we need to build evidence about that. We need to wait results from randomized trials.
So, and so in your case, you relied on CMR to show evidence of microvascular dysfunction. Do you do any intravascular test, or you just rely on CMR in this patients?
Yeah, I think now that is much more utilized, the invasive coronary physiology assessment. This will be more and more utilized. Also in my center now, we utilize much more this invasive coronary physiology assessment, and we don't need to wait too much time because, usually in the hospital, you need to wait a lot to have a cardiac magnetic resonance available. So now that everything could be on the hands of the interventionist, could be easy to have a diagnosis, and also eventually could be easy to see if there is an improvement of coronary flow reserve and IMR after the treatment.
Excellent, Francesco.
Is it necessary? Excellent contribution. Is it necessary in the workout to deal with the microvascular resistance index in this scenario?
Yeah, I think if you have a patient without obstructive coronary artery disease and you have evidence of impaired coronary flow reserve, I think that's enough for me to think about this novel therapy for this patient. I think that's my opinion, but I'm curious also to know which is your idea, that coronary flow reserve looks to me much more stable as compared to IMR. So sometimes if I do IMR 2-3 times, I see that the value is not so stable. I trust much more coronary flow reserve. So coronary flow reserve below 2.5 for me in patient with angina symptoms without obstructive coronary artery disease is sufficient to have a diagnosis of microvascular dysfunction.
That's a very nice tip. So let's keep this number, 2.5 in CFR. Easier to do. So thank you very much, Francesco. Say hi to all the friends in Milan and have a great Saturday night. Bye-bye.
Thank you. Thank you. Bye-bye.
Thank you. Bye-bye. So the next presenter is Dr. Mezilis from Thessaloniki.
Can you hear me?
Yes, Nico. Yes, we're all ears.
Hello. Hello to everybody. Thank you for the kind invitation to present a case from St. Luke's Hospital. I'm really sorry I had to change my schedule and not be with you in person today, but I watched most of the conference today, and I must say it was great sessions and I learned a lot. So let's move to the presentation. It's a mitral valve case, and I'll give you some clinical data. This is a lady, 83-year-old, known rheumatic fever in childhood. She had mitral valve stenosis in the 70s, and she had a closed valvotomy, what they used to say digital valvotomy at the time, with a finger of the surgeon. It was great therapy, but in the 80s she had a balloon valvuloplasty, and 2014 she finally underwent the mitral valve replacement with a Magna 27. She did fine for a number of years, and she was admitted in St. Luke's Hospital with acute pulmonary edema a couple of months ago due to severe stenosis of the prosthetic valve. She was intubated, she developed atrial fibrillation and deteriorated her renal function while in CCU. This is the TOE, and you appreciate the dysfunction of the mitral valve prosthesis, both in 2D and 3D images. And the Doppler confirmed severe mitral stenosis with an orifice of 0.8. You will notice that she had a pre-existing hole in the septum from previous procedure, which was a good and bad thing, both at the same time. And to summarize the case, she had moderately impaired left ventricular function with ejection fraction of 45%. GFR was 26. It was the 4th procedure. She already had 3 procedures. Advanced age, intubated, so no wonder why the Euroscore was sky high at 78%. And we felt that there was no option for further classic surgery, and the only option we had was transcatheter mitral valve repair. In other words, valve in mitral position. And I'm going to show you some videos from the procedure. We had to put the temporary pacing wire, of course, in order to deliver the valve. She had a transeptal puncture, and I am to find the pre-existing hole, which it wasn't very easy, but finally with an SLO catheter, we managed to advance an amplatized stiff wire in the left atrium, as you see here. This is the amplatized stiff both in TOE and in angio images. And after that, we dilated the septum with an Armada balloon, 14 millimeters, in order to be able to cross with the valve. And then we inserted the Agilis French and the Terumo through the valve, as you see here, and exchange it with a Landerquist wire in order to have maximum support to deliver the valve. And then there was a question, what type of valve? Obviously, we discussed that previously, before in advance. And I'm showing you this to really show that the measurements from 2D and 3D TOE are not really accurate. We had a measurement of 2.1 and 3D 2.9 on 2D echo. So we based our decision on the CT scan plus the relevant application from Minneapolis, which I'm showing it to you. This is the Magna, as you see it here. It's a stented valve, flexible valve. Obviously, this is not relevant for mitral position, but it has pericardial leaflets. And for the 27 the 27 valve that we had in our case, we decided to go on for a Sapien 329. And I'm going to show you the sequence of angios here. From now on, it was a straightforward procedure. The advancement of the valve through the septum. And for the positioning, you need to have the dot, the middle dot, a couple of millimeters on the ventricular side of the annulus of the prosthetic valve, or you can orient yourself with a distal part of the Sapien valve to be a couple of millimeters ventricular to the stents of the prosthesis. And this is the inflation with rapid pacing. And this is the immediate result, and you see it was nice opening of the valve, both in TOE, 2D and 3D images. Here in another view. And there was no mitral regurgitation. This wave was from the wire, you see here, and also the 3D color, which shows absence of mitral regurgitation. And with the angiogram, we had to do an angiogram just to check the coroners, and the coroners were fine. So the patient recovered quickly. She was extubated next day, remained in hospital for 7 days. She had an atelectasis and respiratory infection, but she recovered and she's discharged in good general condition. And now it's 1.5 months post the procedure, and she's doing fine. So to conclude, I think the mitral valve in valve is an excellent therapy for mitral valve prosthesis, bioprosthesis. Of course, we don't see too many of those because the surgeons obviously tend to put mechanical valves in mitral position. But nevertheless, this is supported by the various publication, and I'll show you the most recent one from Jack, showing that the 5-year survival for valve in valve is 80% compared to valve in ring and valve in MAC, which is much lower. So thank you very much.
So thank you, Nico. This was an excellent case. It's almost a standardized approach. So you used maybe 12 or 14 millimeter balloon in order to do the septostomy. An Atlas balloon, what did you use?
We used an Armada balloon. That's the balloon we had, and you can go from 12 to 16 depending on the size of the valve. We chose the mid part, so we went for a 14 millimeter, which I think was sufficient.
So today we talked a lot about LVOT obstruction, in case of placing a valve in a mitral position. Were you worried at all in this case?
No, I don't think this is a case for bioprosthesis. Obviously, the angio, we check the outflow, but with the prosthetic valves, I don't think that the outflow tract obstruction is really an issue.
Exactly, because the anterior mitral lift is not there. Good. Adoni, do you have a question?
Yes, when the excellent case, fantastic result. When you worry about the ASD, when you worry about it, in which cases?
This is a good question because we discussed that and we worried a bit where might had a desaturation after the procedure, but and we had some devices available in the cath lab in case we needed to close it. But the oxygenation was fine and she extubated nicely, so we decided not to close this hole, which obviously was pre-existing. Maybe we made it a little bit bigger, but I don't think it was of clinical relevance again.
Good. Excellent. George, any comment?
Well, it's a nice opportunity to review this data that you presented about the outcome of these interventions when we have the rings. So when we have prosthesis, bioprosthesis in the mitral valve, it's an ideal way to deal with them, in contrast with the MAC and the rings.
Yeah. Good. So thank you, Nico. Have a good night, and thank you for contributing in this conference.
Thank you.
So, we are going to the last lap of the conference. So Dr. Kurkovelli will wake up the people with physical presence and also remotely. So, Dr. Kurkovelli, what's your case?
Good evening. Okay. Good evening. Thank you for inviting me here once again, Dr. Iakovou. So in the next few minutes, I'm going to present you a quite, I would say, a case that we often see in our patient clinics. And there are patients that at some point we don't have anything else to do with them. Diuresis doesn't work, so we have to think forward. So the patient is a 70-year-old male, rather slim. He reports shortness of breath and minimal exertion in the last 6 months. He has multiple admissions for decompensation. In 2014, he underwent a coronary artery bypass with 2 grafts, and he has also multiple ablations for atrial fibrillation and SVT. So in 2020, he had also an iliac bypass surgery, and he suffers from hypothyroidism, hypertension, and dyslipidemia. So this was the ECG on admission. It's a normal sinus rhythm with a good ventricular rate, and his chest X-ray. So this chest X-ray, I need to mention, is after the patient was admitted in another hospital, and he was hospitalized for 10 days, and he received very intensive diuresis. So in order for us to be as much as possible fit for the intervention. So these are the medication he is on at the moment of the admission. Apixaban, furosemide, rather small dose. You can appreciate eplerenone, petaxolol, ramipril, felodipine for his hypertension, amiodarone, atorvastatin, lansoprazole, and T4. His renal function was rather good, and his BNP was 247. And this is the baseline transthoracic echo, where you can see that the LV is rather small with good function. But this is not the case for the RV, which is dilated, and you can see the gap, the coaptation gap between the leaflets and the massive tricuspid regurgitation. With an arrow of 1.6, a regurgitant volume of 82 ml. So LV, as we said before, good function, small size, RV, huge, with and diastolic volume of 160 and systolic volume of 80. And this is the baseline TOE we did for the assessment of the patient. The left ventricle, as you can see, is small with good function and with a mild mitral regurgitation. And then we do the sweeping for the tricuspid valve. In the tricuspid valve, you can see a central jet with a radius of 1.2. The transgastric views, these are really helpful to locate the Z. And when it comes to transcatheter edge-to-edge repair of the tricuspid, it's very important to have like good transcatheter views. And in this case, we were quite lucky with that. Again, more views of the tricuspid. And 4D views, we can see the coaptation gap and the Z that comes. Radius 1.2, coaptation gap 0.6. Patient, because he had a coronary artery bypass, we had to see the graphs as well. So we did a coronary angiogram. In the previous slide, I'm sorry, you can see. In the previous slide, you could see the RCA was not dominant, and you can see the graph to the LAD, which is good. But this is the graph to the OM, which is probably closed in the beginning, and there's a retrograde flow. Right heart cath, rather low pressures in right atrium, right ventricle, and with a mean PA of 14 and a wedge pressure of 9. So we have a patient, 70-year-old, with all these comorbidities we mentioned before, and left ventricular ejection fraction 55%, dilated RV, impaired systolic function, huge regurgitation with a central gap, bilateral dilatation, mild MR, and an RVSP of 40, which is probably an underestimation because of the huge tricuspid regurgitation. So the Euroscore 2 was 5.95, and the TRI-score 14%, which makes him like having an intermediate risk for surgery. So the heart team decided that the patient should probably benefit from an transcatheter edge-to-edge repair. So these are the inferior vena cava before while he was intubated, which was quite dilated, and the RV annulus dilatation. Again, more views of the tricuspid valve, just to locate the Z, and where should be oriented the device. In this image, you can see that something pushes the wall, the RV wall. This something is probably the sternum of the patient, because he had the pectus excavatum. So probably it's the pressure that the sternum applies. We don't really know if this has anything to do with the tricuspid regurgitation. So multiplannar reconstruction of the valve. Huge jet, again. And this was with blood pressure of 90, because the patient was intubated, as we said. Again, the gap. And so we decided to go with a Pascal Ace device, and this is the device inserting the right atrium towards the tricuspid valve. So initially, we decided to go more commissural, I would say, but this was not the ideal location. So the residual regurgitation was quite big. So we removed the device, and we forwarded that more, I would say, posteroseptal, multiple attempts. And this was a more, ideal, but not ideal. So we still had regurgitation of more than 50%. So we consider that the operation is successful when we have like more than 50% reduction of the initial regurgitation. So we decided to go with another device. So at this point, we decided to go more anteroseptal, just right to the previous one. And at this point, I need to say that the operation lasted 3 hours. We had so many attempts, independent grasping, but finally, we had this result, which you can all appreciate that was quite good, with all mild residual regurgitation. And more images. And we can see that we have a good grasping of the leaflets. And this is the fluoroscopy with the two devices. And the patient was discharged on the second day post-op. And he came like 2 months in the outpatient clinic, and this was his transthoracic echo with the mild residual regurgitation. And you can see that the tricuspid regurgitation has previously had a more triangular signal. This is the signal we know in tricuspid regurgitation Z. So this is it. Thank you so much.
Thank you, Dr. Kourkovelli. So this is a good example of when to do a procedure where, you know, it's not a futile patient. We're talking today a lot about, and Dr. Dangas was talking about hepatologists, and but this is a clear-cut case, a good coaptation gap. Despite, you know, it was not an easy procedure. Most of the times in TriClip, you needed to place two Pascal or two clips, I suppose, right? Yeah. So, and most of the times you don't get to have this kind of beautiful result. George?
So it was a nice, an excellent contribution to this scenario. Well, probably the RV dysfunction had to do with the ischemic substrate, not with the volume overload. Yes. So in this scenario, we had a combination of dysfunction in RV due to the chronic ischemia.
Or, sorry for the interruption, because of the multiple episodes of atrial fibrillation. So maybe he had a natural functional regurgitation.
No, because the indices of the RV was decreased.
Yes, that's true. That's true.
And also it was impressive that even the TAPSE was eliminated, and the strain was pretty. So it was an obvious dysfunction of the RV, which could not be the outcome of the tricuspid regurgitation.
Yeah, I know what you mean.
So in this scenario, I think it's irrelevant, the quantification of the TR.
Okay.
If you have this kind of RV, you have to be more aggressive to intervene.
Yeah.
It's something which should be taken into account in the real world. And another point is, why? How do you explain the low level of BNP?
Because, as I mentioned before, the patient was admitted for 10 days in another hospital. He had a BNP of, let's say, 800 to 900, and he received like Simdex, I don't know why, but he did, diuresis like over 200 milligrams per day. So when he came to us, he was, I mean, we wanted him to be like dry. So I think it was like a false, let's say, normal, sort of normal.
So, and George, have you ever seen pectum excavatum to
Yes, it's
to get implicated with this kind of.
Well, I didn't want to make these comments more complex, but you irritate me. Actually, when you have this kind of pectum excavatum, there is always malformation of the annulus, of tricuspid annulus. And there is always an amount of tricuspid regurgitation. It is a fact. But in this scenario, the key point for your decision should be the RV dysfunction.
Okay, yeah.
Because having this background of the RV, in the case that we had a properly functioning RV, I would be, well, hesitant to intervene with the same color of TR.
Of TR, okay. Yeah.
Dr. Katsianos has a comment.
Thank you, Jota, for the great presentation. I would just like to comment. The TR era is an era that we're gaining experience every day. There are a lot of options in terms of interventional therapy, TR, TMVR, and as Dr. Halapas mentioned before, the cardioband, which maybe in the future could be a good option, leaving other options open. So, in my opinion, it is very crucial to choose the right patient for the right therapy and the right time, as you said before, to treat the patient with the good therapies that we have in option.
Yeah. That's a great comment, you know, and all of the, you know, many of these devices, like the cardioband that has been mentioned, you know, it has been tried, very difficult to place, very cumbersome, but at the end of the day, it's a part of a solution. And anyway, this valve, it's not aortic valve like the mitral valve as well. So it's even more difficult to be treated. Donna, you have a last comment?
We hear an excellent case, fantastic result, great heart team work. Sometimes the problem with the tricuspid valve is imaging. In that case, we didn't saw that, but that's an issue in these TR procedures. And just I want to say that the comment by Dr. Athanasopoulos was really excellent. Another issue is the pulmonary hypertension that must be taken into account. And finally, that it is not sometimes necessary to proceed with right heart catheterization in order to evaluate and estimate the pulmonary hypertension in such cases. Excellent case, excellent result.
Okay, good.
So I will take the opportunity, since Dr. Halapas made an excellent comment concerning the dynamics, the RV dynamics, the pulmonic pressures and resistances in this area. We see quite often patients with severe TR having at the same time high wedge of around 30, plus increase pulmonic pressure around 50, 55, 60. In this scenario of an increased wedge around 30 and pulmonic pressure, secondary pulmonic pressure of around 50 to 60, how this data affect our decision-making for tricuspid interventions?
So, because the tricuspid agitation is not a valve issue, we need to find out what causes the tricuspid agitation. So, if the tricuspid agitation and the pulmonary hypertension has other, causes, we need to focus on these causes. If it's another valve, we need to focus on the other valve. If it's pathology, like ischemic etiology or anything like that, we need to focus on that. So, to be honest, when we have a patient with tricuspid agitation, having or not having a pulmonary hypertension, because sometimes we don't have, like in this case, high pulmonary pressures, we always need to find what causes the tricuspid agitation. In this case, you mentioned correctly, it was the RV per se. It might has a word to say the pectus. It might has a word to say the annular dilatation of the atrial of the valve. But when it comes to tricuspid agitation, we need to see the whole thing, and not only the valve. Because if we fix the valve and we haven't fixed the problem, the valve will come back again as a problem.
Good. I think we'll have to leave it there. Thank you, Yoda.
You're welcome.
Thanks a lot. So, Dr. Bagiannakis is not available because he has something came out in the hospital, but Dr. Katsianos is here, so he will present the one before last. So it's almost there.
Good evening, dear colleagues. I would like to thank Dr. Iakovou for the kind invitation to participate at your great conference. Thank you. I will move on presenting the patient. 59-year-old female with a BMI of 31.5, history with fatigue and short of breath on minimal exertion, on for years, but worse in the last 6 months, NIHA 3. DCM on myositis background, MTR with 2 Pascal devices, CRTD, PAF, COAD, and hypothyroidism. We see on the right side the elevated hemodynamics. In the medical therapy, high volumes of diuretic therapy, and the labs, we see a normal creatinine and a BNP of 300 to 600. Tri-score 14%, Euroscore to 3.8%. This is the chest X-ray of the patient with the cardiomegaly. We see the proper position of the CRTD leads. the baseline transthoracic echo, we see the impressive tricuspid regurgitation with a TR radius of 1.1 centimeter, TR arrow of 0.52 square centimeters. Impressive is also the TR in the baseline transesophageal echo, and we see also that the RV lead could play a role in the mechanism of the regurgitation. ERO in the transesophageal echo 1.3 square centimeter R volume for 112 ml. In the coronary angiography, we don't see any significant stenosis, neither on the left nor on the right coronary system. So it was for us at HYGEA a heart team discussion. We took into consideration the option of optimal medical therapy, of surgery or interventional therapy, TR, or we could have also the option of TTVR. So we discussed about pros and cons, and we decided to treat this patient with TTVR. Why? We have IACD lead involvement in the mechanism of the TR. We have a big arrow of 1.3 square centimeter, a large tricuspidal valve annulus of 45 millimeter. Of course, there are challenges for this patient. It is crucial to know if this lead is compatible. That's why we asked also for the opinion of our electrophysiologist. And we have the impaired RV and LV function, about 30% respectively. So the procedure, we see the Safari extra small wire in RV apex, steered by Agilis 8.5 French. It is really crucial for the TTVR, for the EVOQUE implantation, to take time to place properly the wire freely in the RV apex, because it is really crucial for the delivery system, for the maneuvering. Here we see the delivery system of the EVOQUE valve. Through TOE assessment in MPR, it is very important to adjust properly the position, the trajectory, and the depth of the valve. We shouldn't go too deep because we would interfere with a chordae, and we shouldn't stay too shallow because we wouldn't grasp the leaflets of the valve. So after the TOE assessment, and here we have to emphasize the crucial role of the interventional echocardiographer at this procedure. When we have the green light to proceed from the TOE specialist, then and only then we proceed. We expose the anchors to 45 degrees, and we have to say that from this point there is no return. We cannot extract the valve from this point. So we have to implantate the valve. We see on the right side the MPR. For each of the 9 anchors of the EVOQUE valve, we check if the leaflets lie nicely on the anchor before we proceed. Next step is the anchors to 90 degrees and then flipped, always under strict TOE guidance. The next step is the ventricular expansion, full ventricular expansion, and then when we are all satisfied, then we release the valve. We see that the valve intervenes with the RV lead. So we have to say it's very important that the RV lead is not tensed before the implantation of the valve. And we see the TE assessment after release with elimination of the TR and no paravalvular leak. we see the nice images of the TOE. We see all 9 anchors of our evoke valve and no TR. So it was really unremarkable recovery. The patient was discharged on day 3. In the follow-up, 3 months NIHA improvement to 1 to 2, and 3 months free of cardiovascular events. This is the follow-up TTE. It remains a good outcome. And so, from our experience, from Dr. Spargas and our team, we try to summon selection criteria in order to be able to choose the suitable patient for TTR or for TTVR. So, from our initial experience, also with EVOQUE, the criteria that could favor and would favor the TTVR therapy would be major coaptation gaps above 5 to 6 millimeters, lead involvement, the bicommissural TR, anterior and posterior septal, torrential TR plus large annulus and very wide VC. And on the other side, criteria that would favor the use of TR, would be the severe RV impairment, the severe PHT above 70 millimeters of mercury. Also, if the anticoagulation therapy would be strictly contraindicated. And of course, it remains to be answered which therapy would we use in terms of younger age and life expectancy. So the evoke valve, bovine pericardial leaflets, nitinol self-expanding frame, 9 ventricular anchors, and intraannular sealing skirt, available in dimensions 44, 48, and 52 millimeters. On the right side, we see the intraannular sealing skirt and frame of the valve. And as we said, the key procedural steps of the evoke system: access point, positioning, and deployment of the valve. It's a promising valve based on the TRISCEND 2 trial criteria, but of course, as we said before, we have to be very careful and choose the right patient for this therapy. Thank you for your attention.
Excellent case. So this is an exciting technology. Maybe it's not for everyone, but do you think it's how was the acceptance rate from the company when you are sending a CD to be evaluated by Edwards? What's your acceptance rate? Do you have like a kind of intrepid, like 30%, or it's 10% or less than the 10 times? So
thank you for the question, Dr. Iakovou. It's really to the point. Indeed, the acceptance rate, I would say it's much under 30%. I would say about 10%, since they're really concerned and eager to establish, to get this very good method, this gift for the patients established. So it is very important also to choose the right patient and achieve the right outcome.
Yeah. But once you get in a position, maybe position is the most difficult to attain, right? Because you need to have a better trajectory, right? So
yes, that's very, very correct. Crucial, and they insist on it, is the placement of the wire. Is very, very important because the maneuvering, the entrance of the delivery system is really demanding. So we have to be sure that the wire and the RV apex is really free. And so also is very important the dimension of the RA, so that we could maneuver and insert the RV. So as you said, the exclusion of patient is really something very often.
Good. George?
Well, excellent contribution on this very difficult, technically speaking, issue. From the clinical point of view, when you have an RV ejection fraction of 30% and you eliminate the tricuspid regurgitation, what is the expected outcome of the RV function?
Yes, until now, from our experience in the few months of follow-up, we see mainly improvement of the symptoms of the patient. We don't see objective outcomes concerning and referring to the RV ejection fraction. So also for us, and that's why we try to summon the criteria, it is indeed very difficult to choose patients for this method.
And another part, and again, clinical issue is, well, there is a notion about some cutoffs for the pulmonic hypertension, secondary pulmonary hypertension. Well, from our experience, if you have more than 50, 60 peak systolic pressure, it means that there is a severe left component, and the decompression of the RV is ameliorated by the TR. So it is difficult to accept that if you have a severe secondary pulmonary hypertension, the elimination of TR will improve the clinical status and the hemodynamics. It is something which cannot be accepted. So this notion, I think, has to be omitted.
Of course, I respect your opinion and I agree with it. And this is also the meaning of opinions exchange. We learn from each other, and of course, we have to think and find the criteria, indeed, to choose the best for our patient. And if it is optimal medical therapy, then it is optimal medical therapy.
Yeah, so it's a patient selection, as always. Yeah, it's not easy to see which are the patients that they will have the biggest advantage of it after this procedure. As in every procedure, that's why it's important to discuss this case, all these cases in the heart team meeting. So thank you very much, Dr. Kassianos.
Thank you.
And the last but not least is Dr. Spilias. So last year he had maybe the best case, and actually we got to see today, you know, the aftermath of the case that he showed us, like the Batman procedure. But let's see what he has for us tonight.
Hello, and thank you very much for having me again this year. We've talked extensively about edge-to-edge repair and orthotopic tricuspid valve replacement. I would like to talk to you a little bit about the heterotopic tricuspid valve replacement and a few cases of IVUS-guided bicaval valve implantation that we performed. So I have an 89-year-old male with a long history of moderate to severe tricuspid regurgitation. He wasn't really following up with his cardiologist and presented with worsening dyspnea and lower extremity edema and signs of right heart failure. In terms of comorbidities, had atrial fibrillation, CKD stage 3, and an IVC filter that was placed in the setting of pulmonary embolism and GI bleeding in the past. So he was diuresed and he was quite functional, his baseline, so we considered a treatment for his tricuspid regurgitation. Here you can see the wide open TR and the coaptation gap, the no coaptation essentially, and the dilation of the right ventricle, right atrium, and the classic triangular shape of the severe TR. We proceeded with the TE for further assessment, and interestingly, one second, this has to play too. Okay, great. We found that the anterior leaflet had some flail and prolapse there. That was probably happened some time ago, and that led to worsening remodeling of the right-sided cardiac chambers. So here you can see also in the 3D MPR, you can see the large coaptation gap, and you can see that the tricuspid valve actually appears to be quadricuspid, having like 4 leaflets, which poses additional challenges. So we screened the patient also for orthotopic tricuspid valve replacement. We did a gated cardiac CTA that showed that the tricuspid annulus was very, very large. The average diameter was 55.4 millimeters, as you can see. So this is the most recent landscape of tricuspid transcatheter therapies. We have devices that target the leaflets, coaptation devices. We have the orthotopic tricuspid valve replacement, some like annuloplasty devices, and also the heterotopic devices. This is, as we know very well, this is the disease progress of tricuspid regurgitation. The further down the disease process, the more severe the RA and RV remodeling, and the fewer the options we have to treat the tricuspid regurgitation. And this is very bad outcomes. So here we have a patient with severe symptomatic TR, elderly patient, large coaptation gap, very large annulus, high surgical risk. We also did a right heart catheterization after diuresis and so preserved cardiac output without significant pulmonary hypertension. So we decided to offer compassionate use of the Tric valve system, which is the bicaval valve system. So the Tric valve system consists of 2 self-expanding valves, one for the SVC, one for the IVC. They come in 2 sizes, and they have the sealing skirts, as you can see. So the patient actually, in the meantime, was readmitted to the hospital again with volume overloads. He was diuresed again. He also had acute kidney injury, so we decided to perform the procedure in the inpatient setting. So conscious sedation, we used the transthoracic echo and fluoroscopy, and we decided, because of the acute kidney injury again and the fact that he recently received contrast for the CT scan, to use IVUS during the procedure for sizing of the SVC and IVC, and also to mark fluoroscopically the landing zones in an effort to spare the contrast. So this is the IVUS pullback. So we advanced the peripheral IVUS catheter over an 035 wire all the way up to the right brachiocephalic vein. We did a pullback, and this is what it looked like on the pullback. We, as I will show you, we measured the key spots for the sizing of the valves and also the fluoroscopic marking areas. We also placed a Swan catheter in the right PA, which also helps with orienting us for the landing zones. So what we found is that actually the measurements we made at these levels with the IVUS correlated very, very well with the measurements from the CT scan. So these are the SVC measurements, and these are the IVC measurements, which again correlated very well with the CT scan that was done a few weeks prior to the procedure. So based on these measurements, we decided to deploy a 25 millimeter SVC valve. You can see here how the delivery system went through actually the IVC filter without any issues. And the SVC valve was deployed. Then we proceeded with the IVC valve deployment. For the IVC valve, the transthoracic echo and the subcostal views are very important to make sure we have enough valve in the right atrium, but the valve is not too low, so we don't obstruct the flow of the hepatic veins. And you see we have a pigtail also in the hepatic vein. And this is the deployment of the IVC valve, the final release that you will see there, very stable. It's about 5 millimeters inside the right atrium. And here you can see how we use fluoroscopy also to mark the SVC confluence and the other areas for proper landing zones for the valves. It was very helpful. And same with the IVCRA junction. We marked it with IVUS, and then we're able to land the valve exactly at that level without having to use contrast. So the patient was discharged 2 days later. Interestingly, at 1 month, he already had some reverse RV remodeling, and which was not seen in the Tricuspid Euro study. Usually the patients that had reverse remodeling were a little later, like 3 months, 6 months. And the patient was doing much better in terms of symptoms and diuretic requirements. So this is just very briefly another case that we did actually the same way, and this patient had a dual chamber pacemaker with the right atrial and right ventricular lead. And what I want to emphasize here is that we also use the pacemaker leads as a marker fluoroscopically. We can use every piece of information, and we did the same approach with IVUS, and these are the pacemaker leads in the SVC, and we mark the same areas that we had marked with the CT scan, and we found great correlation actually. So, and this was actually, after the deployment of the SVC and IVC valves, and this is a pullback from the SVC now into the right atrium. You can see the ventricularization of the right atrium that is expected after this procedure, and you can see there's very nice sealing at the SVC level, and there's no really tall V waves in the SVC. So the key points here are that the bicaval valve implantation is a treatment option for severe TR in patients who are too far down the disease process with large coaptation gaps and severe dilated annulus. Patients with severe TR are usually have some renal dysfunction from the congestion. And intra-procedure IVUS can be easily used to provide an accurate and actually real-time assessment of the caval size, because the caval size also depends on the volume status of the patient. So we need to be very careful when we size for these valves, and real-time sizing is always the best. We also use it to mark the key anatomic landmarks on fluoroscopy and eliminate the need for contrast administration in these patients that had CKD. And obviously the future, I think IVUS applications can be expanded in other structural heart procedures. We already have a few publications on use of IVUS in TAVI to study the expansion of the frame and other applications as well. I would like to thank you very much, and also invite you to Miami Valves in January 2025. If you have any interesting cases, please submit, and we'll be happy to see you there. Thank you.
Excellent case, Nico. So this is a really interesting thing. So peripheral IVUS is coming again, and the trick valve, all this heterotopic valve issue. George, what's your take? Do you think we need to investigate if there is a RV reserve in these patients? Do you do a stress echo or something?
So we did the right heart catheterization. That was one of the main ways we also assessed for the RV function with the cardiac output, and also the PAPI was favorable. In this case, the pulmonary arterial pulsatility index. And the patient actually was responding always very well to the diuretic, and so we thought that we had enough RV reserve to proceed.
Well, I think it's a very impressive, pathophysiologically speaking, intervention. And I have to confess, Yannis, that I support this idea because it provides actually a new physiology for the RV. It's an invert Epstein, actually. You increase the availability of volume to the RV. And with this way, you increase, you fortify the Starling substrate for the RV.
True, because you technically cause more.
Yeah,
there's more volume circulating.
It is a volume. Well, it is an effective stimuli to increase the potency of the systolic function of the RV. The RV is much more prone than the left ventricle to the Starling phenomenon.
Yes.
So, speaking on physiological grounds, I'm very triggered to see this intervention in real life. So, Yannis?
Yes, we have to see that, in Greece it's not reimbursed. We had a couple of cases that we couldn't do because it were not covered by insurance, and the one that was covered, it was outside of the IOU because it was the 41 device. It was not is not approved yet. At least in Europe, it's not CE marked. Do you have any information, Nico, on the larger device for the inferior vena cava?
For the inferior vena cava, no. We still had the 35 was the largest device available for the
Okay,
IVC.
that's interesting. Antoni, you have a comment?
Fantastic case. It's obvious that we are going to face more frequent such cases in the near future. It is obvious that not all procedures and devices are the best for each patient, so we have to better select which case is capable and which device we have to use for. And just a short question regarding the medication of the patient after the discharge. Did you change anything in your medication or regarding diuretics or something regarding the medication?
So So the one patient, the first patient, the first case I showed, actually the diuretic was decreased at 1 month follow-up. When the patient came back to see us in the office, outpatient office, the diuretic dose was less, and actually he didn't have recurrent edema, and he was doing well. He was still on a diuretic. We cannot, unfortunately, eliminate the diuretic on these cases completely. And the experience is still very limited, so we need more cases to try to understand how these patients respond more likely, long-term, and yeah.
It's a fantastic case. So thank you, Nikos. Thank you very much. And I have to thank everyone that stayed up so late. Not a lot with physical presence, but maybe a little more in the web. Οπότε να ευχαριστήσω λοιπόν όλους όσους βοήθησαν σε αυτό το συνέδριο. Ήταν 108 ομιλητές. Είχαμε 613 προεγγραφές και περίπου 80 χρήστες ανά πάνελ παρακολούθηση από το web. Ήταν νομίζω ένα ιδιαίτερα εκπαιδευτική διαδικασία. Μάθαμε πολλά πράγματα στα workshop που γίνανε από την Abbott, το training, το περιογραφικό που οργάνωσε η κυρία Γράψα με τον κύριο Τσιάπρα, για την εκπαιδευτική κάψουλα που ήρθε για πρώτη φορά στην Ελλάδα, που το χορήγησε η εταιρεία Medtronic, έχοντας 4 ταυτόχρονα simulators. Νομίζω μάθαμε πάρα πολλά από αυτά, από τα 11 live in a box που παρουσιάστηκαν και τα 2 live cases. Είχαμε πολύ καλές συζητήσεις. Νομίζω γίναμε όλοι σοφότεροι σε ένα ειδικό θέμα. Υπήρχαν υπερβατικοί καρδιολόγοι, χειρουργοί, imagers, αναισθησιολόγοι και είχαμε μάλιστα και ένα ιδιαίτερο τραπέζι στο οποίο συμμετείχε και ο εκπρόσωπος του Συλλόγου των Ασθενών, που η γνώμη τους για τη θεραπεία την οποία θα διαλέξουν στο επόμενο χρονικό διάστημα με την όλο ένα και μεγαλύτερη εξέλιξη διαδερμικών τεχνικών που που μας δείχνουν ότι αυτοί οι ασθενείς οι οποίοι δεν μπορούσαν να χειρουργηθούν ή μπορούν να χειρουργηθούν τώρα με πιο απλές μεθόδους, νομίζω πως η γνώμη τους θα μετράει όλο και παραπάνω και θα μένουν ακόμα περισσότερο στην επιλογή της κατάλληλης θεραπείας για αυτούς. Τελειώνοντας, θα ήθελα να ευχαριστήσω όλες τις εταιρείες που στήριξαν αυτό το συνέδριο, τη Pfizer, τη Medicare, τη GE, τη Medical Horizons, τους bronze sponsors που ήταν η Abbott, η Edwards, η Merrills. Είχαμε live in a box από αυτές τις εταιρείες. Το silver sponsor είναι η Cardio Innovation και η Biosensor και φυσικά και το gold sponsor, τη Medtronic. Ευχαριστώ πάρα πολύ και ελπίζω να τα πούμε σε αυτό το σημείο και του χρόνου με ακόμα καλύτερες συζητήσεις και με καλύτερη οργάνωση. Ευχαριστούμε πάρα πολύ.